طيب بسم الله الرحمن الرحيم. ازيكم؟ مرحبا بكم كلكم. نبدأ بعد شوية. أنا دكتور أسامة علي، واحد من المودريتورز والأورجنايزر فور دي سيشن البيدياتريك تريننج انترفيو. فتتفضل إيمان حامد ويتفضل دكتور أحمد شوك. يتفضل إيمان.
Assalamu alaikum. Good morning, everyone. I'm Iman Hamid. I'm a pediatric SC4 trainee in West Yorkshire, and I'm one of the newest members in the academic office of BSAPCH. So welcome, everybody, and thank you all for joining us today on day one of pediatric interview workshops. I hope all of you find today's session useful and exciting. In the next coming hours, we will cover pediatric interview common topics. The session is mainly for applicants who applied for ST1, ST3, and ST4, but everyone is absolutely welcomed. Our topics today will be delivered by distinguished speakers. Please, for any questions, pop them down in the chat box and we will read them and we will try to answer them by the end of each session. Please keep your mic muted all day just to minimize the disturbance. So now let's start, and let me introduce our first speaker. So our first speaker is Dr. Ahmed Showk. He's a consultant pediatrician in child development and neurodisability with special interest in medical education at Hillington Child Development Center. Dr. Showk is the president of the BSAPCH. So let's begin our day and let's welcome Dr. Showk.
Okay. Good morning, everyone. Can you hear me well?
Yes, we can.
Okay. So, welcome everyone, and thank you for making your providing some time and effort for this interview workshop. It's not easy, as we know, on Saturday morning. My name is Ahmed, as I said, as Iman said, so I'm a consultant pediatrician working in a child development center in West London. And I'm the president of the Association of Pediatric, or British Sudanese Association of Pediatric and Child Health. So over the next few minutes, I'm just going to give you some general idea what this organization is and what we do. And hopefully by the end of this workshop, so you will be motivated to come and join all of us. Welcome to the interview workshop. This is the second in its nature. And I'm really grateful for Dr. Simon Bruton, who keeps coming, helping us with this interview workshop, bringing all his experience. I'm also grateful to Ala, Mohamed Mutalib, Jessica, Hani, and Sara Abdelgalil for their contribution. And I'm sure that you're going to have an enjoyable day. British Sudanese Association of Pediatrics and Child Health, or in short, BSAPCH, established by a group of Sudanese pediatricians in the UK and Republic of Ireland in 2003. Its members include all people who are working in children health from Sudanese background. So that means probably all of you are eligible to be members if you are not members in the association yet. And I really urge you to do so if you are not a member yet. We also have an ordinary membership for all those who contribute to the children's services in Sudan and to the work and aims of the BSAPCH. Throughout the years, as any other organization, so BSAPCH has been up and down for several reasons. Many of the founders committees, so we lost them over the years. Unfortunately, we lost our late Dr. Ahmed, the first president for the association, who unfortunately passed away last year. Many founders members so left the country. And therefore, so the work of the BSAPCH has been up and down for the last few years. However, over the last 2 years, things has been quite stable with the injection of many trainees and the contribution to the work for BSAPCH, and our membership is fastly growing. which is a good thing. This is the first executive committee. The structure of organization is a general assembly with the executive committee with a term running for 3 years. The current term started a year ago, or about 9 months ago, or 10 months ago. What we do in a nutshell, so we do some work in Sudan and some work in UK and Ireland. In UK and Ireland, we concentrate mainly on our members' development, supporting them throughout their career, provide the education, career advice for them, and we also support the Sudanese community in the UK and Ireland. In Sudan, we have got a lot of work with the authorities in Sudan to improve children's services. And we provide lots of training and education to trainees over there as well. In the UK and Ireland, we promote professional development through education. We provide a lot of professional support, especially for you as a trainee, and this workshop is part of it. We also have a mentoring program, which is very helpful for those who joined it. And again, I urge you to join the mentoring program, but unfortunately it's only for the members. So members benefit from networking that BSAPCH provide, togetherness, being together, and social support, and as well as many opportunities to thrive and succeed through the work of the organization. We also support Sudanese community in the Republic of Ireland and in the UK by providing health advice for them, training, awareness sessions, and parents group, and etc. In Sudan, we have got lots of links, mainly with the BSMB, which is the board for postgraduate training in Sudan, and Sudanese Association of Pediatricians. We contribute regularly to the Sudanese Association of Pediatricians annual conference, which is coming up in the next couple of months. We provide training and education for the staff over there. Unfortunately, over the last couple of years, because of the corona pandemic, so most of it is through online sessions. But in the past, we used to go there and provide direct hands-on training. We also participate in several projects for different governmental offices in Sudan and Sudanese Association of Pediatricians. We also contribute to general humanitarian activities, and all of you know the political unrest that's going on in Sudan since the 25th of October, the terrible situations in terms of health, systematic violence against civilians, people denied access to health and care, tear gas thrown in the hospitals, and we have up to 70 people who were shot dead since the military coup. 25% of them are 18 years old and under. As professionals in diaspora, we have to stand for the health of our children in Sudan. We are aiming to attract all child health care professionals and all children professionals working in children's services in the UK and Ireland. By dividing them in subgroups, we promote specialism and networking and provide a think tank for the organization to work with our partners. We support colleagues in diaspora to set up their own organizations, and we are in the process now of setting up some parents support groups in the UK and Ireland. And as I said, we provide regular training and education for our members and for trainees in Sudan. So we have many opportunities for training. Please go to our website and update yourself. They are really helpful. We have got a very popular emergency series in pediatrics. I think so far we did metabolic one, and the coming one I think is about emergencies in radiology or neurology. We also provide very successful workshops in feedback and reflections, which are quite popular as well. And we hold a lot of other workshops and training activities for the members. So please go through the website and make sure that so you are not missing any opportunities. In addition to this training, so as I said, we support our juniors members by providing advanced career for them. We provide mentorship programs. In the past, we did a fellowship program, unfortunately fell apart for several reasons, and provide the social support for our members.
Dr. Ahmed, we're just about the time.
Thank you. We support people who go into Sudan to provide training over there. And as I said, so we contribute to the SAPCH conferences, which is Sudanese Association of Pediatrician conferences and workshops. We also managed to bring MRC BSAPCH to Sudan, and we do regular courses and examination there. We, as I said, we sponsored teams before to go and visit Sudan and provide hand-on training to our trainees and nursing teams in Sudanese hospital. So we have lots of projects going on, and we really want your contribution and help with them. Please ensure that so you're registered as a member if you're not. And I'm sure that at the end of the workshop tomorrow, and for ST3, ST4, by the end of the workshop, end of this month, there will be some discussions about how to become a member and how to contribute to the organization, and don't miss this opportunity. Thank you.
Thank you so much, Dr. Showk. There will be a slight amendment in our timetable.
For you. And I wish you a successful day today and tomorrow. And thank you very much.
Thank you, Dr. Showk. So there will be a slight amendment in our timetable. Our second speaker will be late a little bit, so we will introduce our third speaker. We will start with the communication session. So our second speaker is Dr. Ala Fadilah. Dr. Ala is an ST8 pediatric neurology grid trainee at Sheffield Children's Hospital. She entered the pediatric training at an ST4 level at Yorkshire and Humber-Diggery in 2014 and started her neurology grid training in 2016. She will complete her CCT this year in pediatric neurology, and her interest is in the functional neurological disorders and movement disorders as well. So Ala will talk to us today about the communication station. Welcome, Ala.
Thank you very much, Iman, and thank you very much to the BSAPCH for inviting me to speak at this interview workshop. I'm just going to start sharing my screen. Is that all right? Yeah?
Yeah.
Okay, lovely, thank you. So thanks again. I'm Ala Fadilah. I'm an ST8 pediatric neurology grid trainee at Sheffield Children's Hospital. So today I'm going to be speaking about communication scenarios in the interview. And having been through that situation myself in several interviews, from my point of view, I've always found it one of the more daunting aspects of the interview workshop. I mean, sorry, the interviews itself. So I was hoping if we kind of speak through things today, and I'm hoping there will be some interaction, and then we can go through what our thoughts are about communication scenarios and interviews, and what are the challenges, and really how we can work around those. So just going through the overview of the curriculum. Essentially, I know that some of you will be applying for ST1 level in the interview, and some at ST3 and ST4 levels. The basics of communication are the same. The expectations are different for each stage, as you will appreciate. At level 1, the key learning outcomes, and this is from the RCPCH progress curriculum, is being able to demonstrate effective listening skills, communication skills, while respect for cultural awareness and sensitivity, etc. And clear, straightforward communication that avoids jargon. And level 2, which is something that's going to be tested in the ST3 and ST4 interviews, the expectations change slightly to involve more complexity in the situations. So there will often be they'll often be looking at examining, for example, how communication, how you would run communication where there's uncertainty in management, for example, or whether there's dissatisfaction or difficulty or distress, or kind of gray area situations rather than straightforward situations. So the expectations are different, but the basics are the same, really. Sorry, I'm just trying to get to my next. Yeah, okay. So the main categories of scenarios, and we'll just go through these quickly just to get an overview. The main categories of scenarios are, number 1, breaking bad news scenario. And these are just kind of broad categories of the kind of scenarios that you would get in a communication station. So there's the breaking bad news scenario, for example, a new diagnosis, something that will entail long-term difficulties or short-term difficulties for the child or young person. And this is probably more relevant to the ST3, ST4 interview communication stations. Number 2 would be explaining a new diagnosis, and this would probably be one of the main communication scenarios you might come across. Explaining a new diagnosis and whether that's what the management plan is, what that diagnosis actually means, and the things that people will be looking out for here is clarity, avoiding jargon, and being empathetic and sensitive to the needs of the child, young person, and their family. 3, discussing a management plan or an acute plan for transfer. And again, there can be lots of complexities in that. And again, the level for that will be pitched differently for the ST1, ST3, and ST4 interviews. However, it's it's one of those things that actually look at several things. Number 1, the candidate's awareness of the details of a management plan or the plan for transfer, or what actually happens, and being able to communicate that clearly and sensitively with empathy, and acknowledging the uncertainty around that. And another category would be discussion of long-term treatment compliance. And that's more a scenario that you would more commonly find in the ST3, ST4 interviews. For example, having an adolescent, for example, with long-term bronchial asthma, type 1 diabetes, or epilepsy, who are having difficulties in terms of concordance with treatment. Another category is dealing with a situation where a child or young person or their family are unhappy or are complaining. And that is a common scenario category in the ST3, ST4 interviews. Duty of candor incidents, and that's again more kind of in the ST3, ST4. If something has gone wrong, and then there's the explanation of what has gone wrong, an apology, and ensuring safety for everyone involved. Scenarios involving colleagues and patient safety would usually make an appearance in communication scenarios. However, my understanding from the information for this year's interviews is that the role players are mainly going to be child, young person, families, and carers. And then safeguarding, which actually is probably going to be tested in other places in the interview, rather than definitely in the communication station. But I've just had it here because it is one of the categories where actually communication is very important, is actually critical. The guidance for the ST1 interviews this round, basically the information is available is that the applicant, if you're applying for ST1, you'll be given 2 minutes to read the scenario before starting your virtual scenario. And the scenarios will broadly involve an explanation of a clinical condition or reasons for an intervention or transfer. And the interaction will be between yourself and the role player directly. The reason that I've put this up is just to be aware of but actually this is very much a scripted scenario, and there is a scoring framework. There's positive indicators, there's negative indicators, and we'll have a look at what these indicators could be. So you'll be given 2 minutes to go through the scenario. And that's just enough time to familiarize yourself with what it is that you need to go through. In contrast, for the ST3 and ST4 interviews, you'll be given 4 minutes to read the scenario before starting the virtual interview. And that probably reflects the increasing complexity of the scenario, or the awareness of other details around the scenario that the candidate needs to take into account, whether it's social background or specific details, tricky areas in the scenario that you need to be aware of. So yeah, so the longer time is probably just a reflection of the increasing complexity of the scenarios. So what is being assessed in the communication scenario? And just to note that communication is being assessed throughout your interview. It's not just the communication scenario. It's worth getting communication right, and that's not just for the interview. Obviously, that's for our practice. So what is actually being assessed? The capacity to communicate effectively and sensitively, and ability to discuss with patients in a way that they can understand. And that's not meant in a patronizing way, but it is important to be able to get the information across in a way that's suitable for the person that you're speaking to, whether that's the child, young person, their parent or carer, whoever is with them. The discussions need to be tailored appropriately for the people receiving the information. Ability to build rapport, that's very important. Listen, influence, and negotiate. So in complex communication scenarios, things will go wrong, as they often do. There will be conflict. And what is being assessed is how you manage this conflict, how you negotiate your way around it, how you listen, and how you communicate your point of view and take in others. And essentially, this is what's being assessed broadly. Sorry, I'm just trying to get, yeah, okay. So, so I've borrowed this slide from the scoring framework for the MRC-PCH clinical examination. And the reason that I've done that is that the scoring frameworks for communication scenarios are pretty much similar, actually, and the interviewers will be looking for quite similar abilities. So what is it that we are looking for? So what is being looked for is a candidate who explains relevant, clinically accurate information. So it is important. What you do say is important. The content of what you do say is important. It's not only the way you say it and the way you manage the consultation. It's actually the content of it as well. Information provided in a well-structured manner, and structure is very important. It's all about structure, isn't it? And we ourselves can identify when things are explained to us in a non-structured manner that we become confused, obviously. So structure is very important. And structure is often a reflection of our confidence and our confidence in our knowledge of the material that we are going to speak about, and our confidence that we are able to deliver it in a way that is acceptable. So verifying, understanding, and summarizing. That's very important. That's not, again, another reflection of confidence in being able to manage the communication scenario. Is checking where the patient or the family parents are in terms of their understanding, and summarizing in the end, because obviously a conversation can be very long, and at the end of it, we're not really sure what the outcome of it is. So it is important to summarize. Appropriate level of confidence, greeting and introduction. Professional, sensitive with appropriate body language and response to verbal and non-verbal cues. Now in the virtual interview, responding to non-verbal cues can be a bit more tricky to assess. But this is obviously a kind of a general standard. Appropriate level of confidence, I cannot stress on the importance. I couldn't stress anymore on the importance of level of confidence. It is very important to come across as confident. Confidence allows confidence allows the conversation to move forward. If it's felt that you're hesitant or not very confident in what you're saying or what you're delivering, the communication really does suffer. And yeah, so yeah, I can't stress that enough. Develops appropriate rapport. It is important, and simple things obviously like asking what people's names are, and starting off by introducing yourself appropriately, and putting people at ease, which is just kind of basics of communication. Clarifies the role in the shared agenda, and that's very important. So when you come and speak to somebody, don't just start speaking straight away, obviously, and this is kind of from your day-to-day practice as well. You wouldn't start speaking to people and just start talking about what you're wanting to. First of all, you need to clarify what your role is, why you're there to speak to them. They will have spoken to, and maybe are going to speak to, several other health professionals. They need to know why you're there, who you are, why you're there, and what are the outcomes that you're hoping for from that conversation. And it is important to pace yourself doing that and allow time for them to get back to you, and to confirm that that there's a two-way street in the communication. Applies active listening and displays interest with the role player. Definitely allows others opportunities to speak, and appropriate language in challenging circumstances without any jargon. Without any jargon is very important. And we'll go through that as well. But the important thing to note is that jargon is really, if you start using jargon, it's the communication just kind of gets lost. It is important that you have in your repertoire the translation of medical English to normal English for the conditions that you're going to speak about. That is very important, because medical English is not really the same as plain English, and it is important not to use jargon, and that's not just in the names of conditions. It's in actually all the other medical language that we use. Seeking, identifying, acknowledging, attempting to address the concerns appropriately. Natural empathy, and that can be that can differ from person to person. And displaying empathy virtually, I can understand that is, a lot of us may ask, well, how do we actually display that empathy virtually? And displaying empathy is one of those things that is difficult to actually measure, and it depends a lot on non-verbal cues as well as verbal cues. So again, it's just one of those things that, when we think about in the virtual environment, how that translates across. Checks knowledge and understanding and agrees next steps. So that's again coming to verifying, understanding, and summarizing. So basically that is what the interviewers are looking for. What the interviewers are not looking for is inaccurate, irrelevant information, definitely. Going off topic and speaking about, well, in too much detail, for example, or more detail than is needed. Really, for example, if you're breaking a new diagnosis of diabetes, for example, and you have a certain number of minutes, then actually, would you be talking about some of the less common long-term complications? that's a thing to think about. So it's important for the information to be appropriate, structured, and actually appropriate for the scenario. If there's no verification of understanding, that's a bit like what you don't want is to go in there, say what you need to say, and not have a two-way conversation with the person. Communication is it's a two-way street, and I know that sounds a bit like it goes without saying, but sometimes, especially with interview nerves, I think sometimes we can often go into a bit of the kind of the didactic, like this is what I'm going to say, and although sometimes it's difficult, but it is important in the interview scenario to try as much as possible to replicate your normal communication, your day-to-day communication. Do what you normally would in your day-to-day. Poor body language and nonverbal skills. Yes, again, we're talking about kind of virtual versus face-to-face. Unprofessional manner, definitely not. Insensitive or overconfident, yep, definitely. These are big no-nos. Poor rapport, fails to put role player at ease. So I think that's one of the important things, because some of the scenarios will have the role player, whether it's a part of the child or young person or the family member, will seek reassurance regarding a certain point. And a lot of the time, I think we worry about giving false reassurance, which is a valid concern. We shouldn't really be giving false reassurance. However, it is important to provide appropriate reassurance. And I think that sometimes, especially with interview nerves, we might fail to actually provide appropriate reassurance. So that's important to recognize that you are there to put your patient, their family, you are there to put them at ease, whatever the situation, whatever the news that you're breaking. No clarification of role. As I said, it's important to put to clarify your agenda and do it at a pace and tone that is appropriate. Not listening or displaying interest in the views of the role player, definitely that's a no-no. Missing cues, obstructive and inappropriate language. So interrupting, dismissing concerns, and over-reliance on jargon. Okay, those are definitely things that we do need to be very careful about, avoiding jargon.
Ala, we've got 5 minutes left.
Yes, okay, thank you. Didactic delivery, definitely that's one of the things that we spoke about. Sorry, I'm just trying to get to the next slide. So again, this is just a screenshot of the MRC-PCH exam marking sheet, which just shows exactly what it is that people are looking for. And these are the no-nos: poor approach, failure to deal, lacking in empathy, factual inaccuracy. So where can things go wrong? I was hoping for things to be a bit more interactive, but just in the interest of time, I think I'm just going to, hesitation, demonstrating a lack of confidence, definitely. Jargon, definitely jargon. And, we just need to remember that medical English is not the same as plain English. And we need to have a ready repertoire of translations in our mind, really. This is how I'm going to explain type 1 diabetes. This is how I'm going to explain epilepsy. This is how I'm going to talk about celiac disease. This is how I'm going to talk about a gluten-free diet, for example. This is how I'm going to talk about nephrotic syndrome. It is important for us to have these to mind, and these things do come with practice and experience. But if we haven't had the specific experience, if you're applying for ST1 level and you haven't necessarily had the experience of speaking about epilepsy to a child, young person and their parent, it is worth getting that structure in your mind in preparation for your career as a pediatric trainee, and B, for the interview, obviously. So lack of structure, as we said, lack of clarity, language barrier. And I talk about language barrier because a lot of us who apply for specialty trainee interviews, our first language is not English. And the language barrier, I mean, everybody's more confident speaking in their first language. And if your day-to-day language is not the same language as the person that you're speaking to, then there is a degree of you needing to put in place certain prompts in your mind, certain ways of communicating that are learned, rather than things that come naturally as they would in a first language and your main medium of communication. So I think the way around that is practice, definitely. Practice, experience, and just getting yourself, recognizing that, yes, this is something that I do need to work on for several reasons, that this doesn't come naturally to me. And I've certainly been in that situation. This doesn't come naturally to me. I need to work on this and put in place a way to work around it. And the language barrier can be in either direction. You may be communicating with somebody whose first language is also not English, or somebody who uses British Sign Language, for example, with communication difficulties. So the language barrier happens in either direction. It is important to take into account what that means actually for the communication scenario, and trying to get around that to provide the kind of the best outcome possible. Sorry, again, lack of factual knowledge. Yes, again, communication is about how you say things, but it's also about what you say and the content of what you say. So it is important to get your facts right and communicate the appropriate facts for the situation. Not sticking to the task. So you'll have a task in your crib sheet, the 2 minutes, the 4 minutes time that you have. You do need to stick to the task. What is it that you're being asked to do? You do need to follow the instructions. And again, interview nerves get in the way, and sometimes we don't really follow the instructions the way we should, or we interpret them in a different way. So that's very important, just to focus on what is the task? Have I achieved it? How do I achieve it? One-way communication, as we said, again, being didactic and not kind of getting the feedback and just focusing on, this is what I need to say, and I'm just going to say it, and that's how it goes. Talking over people and interrupting, definitely not great. Not offering an apology if appropriate. Again, these are in the kind of the duty of candor scenarios. So again, just an overview of the categories of scenarios: breaking bad news, explaining a new diagnosis, discussing a management plan or acute plan for transfer, discussion of long-term treatment and compliance, dealing with a situation where the child or young person or their family are unhappy or complaining, duty of candor type incidents, for example, drug errors that you need to communicate, that kind of thing. Safeguarding scenarios and scenarios involving colleagues and patient safety. But as I said, these are probably less likely to be directly examined, but just for you to be aware. And this is just in the interest of time. This is just an example on the underperforming colleague scenario. This is kind of like a scoring framework, and these are the positive indicators and these are the negative indicators. And again, the negative indicators are also general ones, not considering impact on patient safety, and that's very important. Compromising patient safety, handling the problem alone, and it is important to always say when you're going to ask for help in your communication scenario as well. Even if you're breaking the news of a diagnosis and you're at ST1 level, you're going to say, well, my colleagues are going, you just need to, whatever you do in real life, you wouldn't be just breaking the news of the diagnosis and following them up in your clinic as an ST1 or ST4. So you do need to let the family know who else is going to be involved, who else is involved, who will be doing what. So involving the appropriate team members and being supportive. It is important to be supportive and clearly supportive in these scenarios. So in summary, communication is an essential skill for a pediatrician. It's assessed throughout your interview and not just in the communication scenario. Get to recognize your own strengths and weaknesses in communication. Every one of us has a different communication style, a different personality type. Every one of us has different strengths and weaknesses, and it's worth knowing your strengths, capitalizing on them, knowing your weaknesses and practicing to improve them. And this isn't just an interview skill, communication, it's an involving everyday skill. It becomes part of your professional identity as a doctor. Are they, is this doctor, a good communicator or not? And for a pediatrician, it is essential. Obviously, it goes without saying. And yeah, practice, practice, practice. That would be my, piece of advice. So thank you, and sorry for overrunning. And please feel free to email me if you have any questions. I don't know if we have any time for any discussions. Thank you.
Thank you so much.
I'm just going to stop sharing.
No, it's all right. We got 10 minutes for the questions. So,
oh, okay. Lovely.
Yeah. Thank you for the tips and tricks.
I'm just going to, yeah, I'm just trying to stop sharing this.
So I see there is one question in the chat from Ahmed Mohammed. He's saying, are there common communication scenarios for ST1 that we should concentrate on, like febrile convulsions, for example?
Yeah, sorry, am I still sharing the screen? Sorry, because I'm...
Yeah.
I'm just trying to stop sharing the screen. I'm not... Yeah, sorry. It's all right. Yeah, sorry. Yes. So, so common, yeah, ST1 scenarios. So, so a lot of scenarios will be the kind of explaining a condition or a kind of a diagnosis, and a lot of those will be acute conditions rather than kind of long-term conditions. But as I said, a lot of them will be, for example, you know, you mentioned febrile seizures. That's one of the more common ones. That, you know, as an ST1. You will be seeing a lot of these children doing the initial assessments. There will be other scenarios, for example, management of bronchiolitis, and for example, should they be like, there could be a question about having a parent asking if their child needs antibiotics if they've got bronchiolitis, for example. That's kind of a standard scenario. So a lot of it will be about the kind of or for example, bronchial asthma, diagnosis of asthma, you know, talking about, for example, going on prophylaxis, you know, that kind of thing. So these are the kind of the main type of scenarios to anticipate from an ST1 point of view. There could be scenarios, for example, about for example, transfer of a child, for example, a child who needs surgical management, who needs to be transferred, for example, to another hospital, things like these. Although these are kind of, this would be kind of more kind of aimed at an ST3 and ST4 level. As I said, the ST3, ST4 scenarios will be more about situations where there's a kind of almost like a breaking bad news, a transfer with uncertainty about what the outcome of the transfer is going to be and the subsequent management, and other situations where the child, young person or their family are unhappy, for example, or dissatisfied with management or uncertain, etc. And the other one is obviously about for ST3, ST4 is more about kind of your adolescent who has a long-term illness, who there are difficulties with compliance and concordance with treatment, and then there's the whole exploration of the psychosocial issues around that.
Thank you. Any other questions from the candidates? If you got any question, please either you unmute yourself or you can pop it in the chat and I can read it.
I think Simon said he can cover a bit on this as well. Thank you, Simon.
Lovely.
Yeah.
Any questions?
I don't know. Sorry. Yeah.
I know that you really went through everything. Thank you so much. It's just, is there, let's say for a diagnosis, for example, is there a certain structure in which we should speak, or like a kind of way that we should think about it, as in the way, or should we be having it based on the questions that we're getting from the parents or from a guardian? Or it's just, if there was maybe just a way of thinking about it for every single one, in a way, like, oh, should I be going, okay, what is the diagnosis, what is the management, what is the, it would be nice just to have a way to think about it.
Yeah, okay. So how I would go about it is, it's obviously, it differs depending on the complexity, and it also depends on the actual scenario that you're given. What does the child know, or the young person, what did their family know already? So the important thing is obviously structure, is obviously the initial introductions and clarifying, you know, your role here. I'm here to speak to you about, you know, this and this and this, and then assessing prior knowledge. Is this, you get to know them, you get to know who everyone is, obviously, and then assessing prior knowledge. I think that is what I would do first of all, is definitely assessing prior knowledge, finding out what it is that they know, whether it's the parent there or a kind of a role player in the place of the child, young person. What is it that they know, and essentially, after assessing prior knowledge, and you've clarified your agenda, I'm here to talk about the results of this and this test, for example, and then from there you say, well, what we found, and then try to explain it in a kind of a simple sentence. For example, what we found, for example, is that, for example, your child has, well, if we give an example, for example, of type 1 diabetes, for example, and then. So you allow that to kind of to sink in, and you can ask questions, for example, about, have you heard about this, for example, that kind of thing. What's your knowledge about it? Again, after saying what it is, and then you can go through an explanation of what that means in simple, as I said, non-medical English, just plain English. And it is really important to break it down in non-medical English, and a lot of our medical English are things like, for example, there are some words that are not just names of organs or names of conditions, but there are things like, for example, there are words that we use, like, for example, empirical treatment, for example. That means something to, starting empirical treatment, empirical antibiotics, or that kind of thing. Empirical doesn't, it means something different for people. And taking a history, we say taking a history, but for a lot of people, history is the History Channel. And that it's not really the story of what is going on. So it is important to break this down. So and then there will be the opportunity for questions, and it is important to pause at different bits and take the opportunity for questions, and then talk about next steps. And acknowledge that this can all be very new, overwhelming, etc., depending on what's appropriate to the situation itself. Acknowledging that at various bits, and then responding to questions and taking it back and forth. And it is important that if, for example, in the middle of the scenario, you have a role player in the place of a parent or carer who becomes very angry, for example, and you're unhappy, it is important to remember that this is all scripted. So it is important that we don't necessarily feel that if they become angry, then there's something that we did that was wrong. This is all very scripted, and it's about what we do after that, how we deal with that. That's very important. So it is important to keep our calm in these situations, and it can all, although it is. We do know that it's role play at another level. We feel very much that we're in a real situation, so I would go through questions and then do a summary of this is what we've spoken about. These are the next steps. These are the people who will be involved. Someone will come and speak to you about this and this. This is what will happen. Either you'll be discharged now, or for example, someone else will come and speak to you about further details. Etc., depending on what's appropriate to the situation. I think that would be kind of my general structure. I don't know if does that helpful, Zubair?
Yeah, that's really helpful. Just as an added question, just what would you say would be an approach to, let's say, because a lot of these things maybe we haven't seen, what is the kind of approach of like, I don't know? But I know it would be something like, I don't know, but I will be able to get that information for you, or just maybe just a clarification of that would be great.
Yeah, I think this is where we get a bit, although we're kind of trained very early on that we need to be very good at saying we don't know. It is also difficult to say I don't know, and there is a certain way to say I don't know. What we don't want to come across when we say we don't know is that we have no idea what we're doing and we have no idea how to go about it. It is important to say, well, actually, that's a good question, and that's a good question. I'm not entirely sure, for example, when exactly your child will be seen in clinic, for example, as a follow-up, but I can get back to you on that. But I'll consult with my, with whether it's my senior colleague, if you're like ST1 registrar, or I'll consult with the, the consultant who's overlooking the care of your child, and I'll get back to you about that. But it is important to feel confident about saying that you don't know and that you'll get back to them. There are questions that we are going to be expected to know the answer to. for example, like, you know, if, for example, if you're diagnosing somebody with bronchiolitis, and they ask you, for example, you know, is this going to be a long-term condition? We can't stay on the fence there. We really need to be able to say, well, actually, no, this is more a kind of a short-term condition, but we'll need to obviously follow and see them through until, you know, see how they progress and how they get better. So there are things that we are not expected to actually know the answer to, definitely, but there are things that we really, at the level that we're being interviewed, we do need to be able to answer some questions, for example. Does that make sense? Yeah.
Yeah, thank you. Thanks a lot.
Sorry to interrupt. I think our time is up. It's been lovely to have you, Ala, and hopefully we'll see you more and more in the future. Thank you so much.
Thank you. Thanks.
Okay, now let's move to our next speaker. So our next speaker is Dr. Simon Bruton. He's a general pediatrician and clinical director of child health at King's College Hospital. He's also an RCPCH officer for recruitment. Dr. Bruton has a research interest and multiple roles in education. He is an assistant director of medical education and course director at the King's College London Advanced Pediatrics Master. Dr. Bruton will talk to you today about preparing yourself and maximizing your score in the interviews. With no further delay, welcome Dr. Bruton.
Many thanks. Just checking, can everybody see me and hear me?
Clearly.
Perfect. So thank you for the kind introduction. I don't do all those roles anymore. I have to move on from a few of them, but I have done them all in the last 13 years. And obviously most importantly is that I'm the recruitment officer for the RCPCH. So I set the questions. So I do know the answers to just about everything, all the questions that have been given. So just checking the audience, do we have a mixture of ST1 applicants and ST34 applicants?
Yeah, all of them.
So if it's okay, I will break down what I'm going to say into ST1 first and then ST34. I'll take all the questions for ST1 at the end of the ST1 section, and then we'll move on to 3-4 if that's okay. So ST1, so just to kind of reassure you, 40% of the applicants that come into paediatrics have never done a paediatric job before. So we don't expect a huge amount of knowledge of paediatrics. The amount of knowledge we expect is what you would expect of a final year medical student. But we do expect you to be able to apply it at the level of an F2. So we expect you to really focus on patient safety, teamwork, strong communication skills, early escalation, and really, really good communication with all of the people that you're working with, the nursing team, the medical team. But we don't expect you at ST1 applicant level to, for instance, know the biochemical parameters in pyloric stenosis, which we used to ask many moons ago, but we don't anymore. So the questions that you will be asked in ST1 are all things that you would have encountered as a junior doctor in adult specialties, such as diabetes, asthma, sepsis, pneumonia, but they're applied usually into someone who's about between 6 and 10 years old. We don't tend to ask in ST1 questions that involve babies, but if we do, it's more of a communication situation with the mum. We also don't ask much about safeguarding at ST1, and if you are asked a safeguarding question, then the key thing is identification and escalation. We're not expecting you to know all of the safeguarding procedures and policies at ST1 applicant level. So hopefully that's reassuring. The things that we're after are, firstly, people who want to do pediatrics is really important. Strong communicators, so smiling is so important during your interview. So please do smile and engage with the interviewers. It makes it a lot easier for them to engage with you. And we're focusing on that communication, early escalation, really good teamwork, prioritization, ability to think clearly, and use everybody within your team. So that applies to both the communication station and to the clinical thinking stations. In particular, the clinical thinking station will be, as I've said. So following on from what Ala said around the communication station, she pretty much got it bang on. With the communication station, you will have a role model who you will speak to for the, we're not sure if it's going to be 8 or 10 minutes. We're hoping it's going to be 10 minutes for you to be able to speak to the role player and to go through the scenario. And as she said, the first thing you need to do is firstly take your time, smile at the role model, and be polite and engaging. Speak at a pace much like I'm speaking now, so that you're not rushing, you're not speaking too fast. There's plenty of time to cover everything that you need in the process for you to be able to have a really good communication scenario with this person. But if you rush, then it becomes more difficult then to understand the nuances of what you're saying. So firstly, so imagine if the scenario is, you know, little Johnny has come in after being found having drunk half a paracetamol bottle. And little Johnny is 2 years old, and we're not quite sure exactly how much he's drunk, but he's drunk at least half. The mum wants to go home to be with her other children and doesn't want to stay there to be with little Johnny. So the first thing you will do is take the kind of key history from the mum. You know, what happened? What did you see? What did you witness? How has Johnny been since? When did it happen? And then to talk her through the management of paracetamol poisoning, which would be the same as in adults as it is in children. You know, bloods at 4 hours and review, and consider starting an acetylcysteine if necessary, and paracetamol levels are high. And you have to talk her through that. Now, the key bit about the communication station is that she's going to want to go home with her child. You know, she can see that little Johnny is absolutely fine. He's running around the room and looks fine. Why can't she go home? And so your job is going to be communicating the importance of finding the children who have got high paracetamol levels and are at risk of liver damage. And that's going to be the communication scenario. And you need to negotiate with her. If you just tell her, no, you can't go home, little Johnny has to stay, that probably won't go down so well. It's about negotiating with her. So saying, well, who else can go and look after the other children at home? Do you have anyone else who can help you? You know, is it possible that, you know, it's not ideal in the current situation, but can one of the children be brought here at the moment so you can look after them? But negotiate with her to try and help her to solve her problems. And then the actress, the role player, as was said earlier, has got a script, and they're expecting for you to obviously keep little Johnny in, so that they will try a little bit for a minute or so to convince you to let her go home, and then they will then start entering the negotiation with you. And then what you need to do at each stage is to just go back and summarize, maybe after every 2 or 3 minutes. Say, well, thank you, Mrs. Smith. So this is what we've agreed so far. You understand that little Johnny has drunk, you know, a significant amount of paracetamol. We don't quite know how high the levels are or the effects on his liver. It is possible that it's caused liver damage, and we need to do some blood tests to find out what's going on. And that he will need to stay in until we know the blood test results, and almost certainly for the next 24 hours. Do you understand that? And she will say yes. And then you can move on to the next stage. But have those little mini summaries as you're going through the communication station, if that makes sense. And the final bit that you'll be asked around is a kind of like a governance reflective practice type scenario. And what they will ask you is around, well, firstly, it's more around why do you want to do pediatrics, what your motivation is to do pediatrics, who your role models have been, and what you consider to be the key criteria to be a really effective pediatrician. So all these questions are published on the RCPCH website, and those sections are going to literally be read verbatim. So the only ones that vary are the communication station and the clinical station. So really, really, really know the content of those questions and have a kind of practiced answer before the interview. You know, you can write down some key points about what you want to say. I wouldn't make it too rehearsed, because if it's too rehearsed, it then looks, it kind of lacks character and empathy. But do make sure that you've written down some key points for what you're going to say for those questions, because, you know, they form a third of the marks. So, so they form a third of the marks, then communication's a third, and clinical thinking's a third. And then overall, the application form, I think, is 40%, is that correct? And the interview is 60%. And then from that, you'll get your ranking according to where you'll be positioned. And there's going to be 650 interview slots. And I think as everybody received their interview invite, do we know if that's been received? I presume so.
Yes, they have.
Yeah. So with that in mind, with ST1, is there any questions around the clinical thinking scenarios? That's good. Any questions around the communication scenarios? No. You've all gone very quiet. And any questions around the governance and reflective practice scenarios? Okay, anything else? Any other questions from ST1 at all? Please, there's no such thing as, so someone's written in the chat, when shall we do communicate, oh, that teenagers will be ST3-4. So you won't get a difficult teenager to speak to in ST1. Everybody you speak to in ST1 will be reasonably easy to have a communication scenario with. So any questions about anything to do with ST1 or process or anything else? If not, I'll move. Oh, we've got a baby who wants to ask a question.
Try to cut out the picture.
Oh, there you go. So I'll move on to ST3-4 then, if that's okay.
Can I ask a question?
Yeah, sure.
Yeah, my name is Nusrat, and I've applied for ST1. I have an interview on the 3rd of February.
Yeah.
I have done pediatrics in my home country in Kenya before, so I'm a bit worried that it'll come out as overqualified. So I don't know how to play it, you know, like, am I supposed to answer the questions at an ST1 level? And yeah.
How many years have you done in Kenya in pediatrics?
I've done 4.
4 years.
Yeah.
So, I would answer the questions truthfully. Assuming you then get appointed, you can then kind of accelerate through your training. So you can do less time at level 1 and progress into level 2 a bit quicker. Mm-hmm. Assume you've not got the full membership exam, which is why you've not applied at ST3-4.
Yes, I haven't applied to ST4. I've applied to ST3.
Okay.
Yeah, I'll try both. Yeah, so just go with how the stations are, and
yeah, definitely. Okay. And you know, you don't. I wouldn't dumb down your question, because you might end up digging yourself into a bit of a hole. So just answer as you would do in real life. And on the motivation question, you know, be absolutely honest. Say, you know, you've got 3-4 years of pediatric experience. You now want to come and practice pediatrics in the UK. These are the reasons why you want to be a pediatrician for the future. I imagine your interview will be very strong.
I pray so. Thank you for your help.
You're welcome. Any other questions?
We've got a question in the chat from Ahmed. He's saying, regarding the clinical thinking, what are the common scenarios?
Yes, I've kind of run through them. So there are things that that you would see as an adult trainee, which you can then apply to pediatrics. So as I said, they're not going to be pyloric stenosis, intussusception, those kind of things. They're going to be sepsis, pneumonia, diabetes, asthma, you know, common clinical conditions, epilepsy, seizures. So not so much febrile convulsions. I don't think we've got febrile convulsions in ST1. We might do, but it wouldn't matter. It is around the management of a seizure. You know, in which case your answer is going to be very much around ABC, early administration of oxygen, safe management of the seizure, and then progressing through as per APLS guidelines. And then you obviously need to know your APLS guidelines for the management of all the common conditions. So that, you know, as you would for adults. And so, but they will be common conditions. You won't be asked about, you know, transverse myelitis and stuff like that. Common stuff that you would expect to see in adults. Someone's does that answer your question, Ahmed?
Yes, thank you so much. Thank you.
You're welcome. Any other questions around ST1? There's no trick questions. We're honestly not trying to trick people. We're interviewing 650 people for about 400 jobs. So it's a massive process, but you know, you've done well to get an interview because we had over 1,000 applications to pediatrics this year. So shall I move on to ST3-4? So ST3-4 is obviously more challenging. Personally, in the future, I find it really hard to run a kind of process for ST3 because it is still level 1 pediatric training, but you're kind of looking to recruit somebody who's got the experience, who's going to be able to be a registrar the following year. So I think in subsequent years, so not this year, it may well be that we have level 1 entry and level 2 entry rather than ST1, 2 and ST3-4. But don't worry about that. That's just me ruminating. It's not going to affect anything that happens this year. Now, there aren't many jobs. I think there are about 30 jobs for ST3 and ST4 this year. And there are not going to be an enormous amount of interviews. We'll be looking to, last year we interviewed way too many people for ST3-4. I think we interviewed nearly 250, 300 people in total for about 60 jobs, which is obviously, you want to be interviewing maximum of 3 to 1 for each job. So I would imagine we'll be looking to interview around about 150 to 180 people maximum for ST3-4 intake this year. So with that in mind, obviously the questions are harder, and they will definitely contain safeguarding, and they will definitely contain neonatology. We very much are expecting you to be able to answer the question kind of at ST4 level. So even if you're applying at ST3, the following year you're going to be an ST4, and in some parts of the country the ST3s are on the middle grade rota. So the answers will be with you expecting to be the registrar and team leader for that particular scenario. So you can expect everything from that we would expect to see in the UK, including sickle cell, which some of you may not have that much experience with. And including some COVID related presentations. We've not really put any COVID related presentations into ST1. We may put COVID anxiety into the parents for ST1, i.e. they're scared to come in because of the COVID pandemic, but the actual presentations have got nothing to do with COVID, whereas we have put some COVID-related presentations into ST3/4, such as PIMS TS and Kawasaki-related conditions. So with the clinical thinking scenario, so again, there will pretty much all be emergencies. So it'll be moving the child around to resuscitation, early administration of oxygen, finding out who your team is, and which nurses and junior clinical colleagues you've got to work with, and ascertaining what the clinical history and diagnosis is for the particular child, and then delegating tasks to manage that child as per the appropriate guideline. So it might well be asthma who's going to require intubation and transfer to a intensive care. It could be sepsis that's going to require peripheral inotropes and transfer to intensive care. Could be a non-accidental head injury, could be a raised intracranial pressure presentation. All of these things that we would expect you to be able to manage at ST3/4 level in the emergency setting, the clinical scenario can be. So it's difficult for me to, we've not set the questions for ST3/4 yet, so I can't tell you what they will be. I've still got that pleasure to do. But the clinical thinking scenario, it's really important to patient safety, ABC, find out who your team is, use your team, escalation to anesthetics or to your consultant. Always, always, always speak to your consultant. The people that go through their scenario and don't mention the consultant tend to do badly, because these are going to be particularly sick children that you're going to need help with in terms of the politics of the hospital, and that's the reality in real life. So before I move on, any questions about the clinical thinking ST3/4 questions? I can see someone's written any neonatal communication clinical thinking scenarios in ST3/4. I think I've covered that. So yes, yes, lots and lots.
Yeah. May I ask about the politics of the hospital? How we can deal with it as ST3?
Yeah, you're not expected to know the politics of the hospital. You're just expected to know that you need to speak to the consultant to work stuff out. So, the line would be, at this point, I would speak to my consultant to see if they had any other ideas that might help me in managing this patient. But you're absolutely not expected to know that it's a small DGH and doesn't have a high dependency area. The staffing's a problem. You're not expected to know that, but you are expected to escalate to the consultant to see if they've got any other ideas that can help you in managing this case. Bear in mind, the consultants would have been at the hospital for at least 5 years, if not longer. And they will know how to manage situations better in that respect. So it's just about checking in with them. Any other questions around?
Hi, Simon.
Yeah, hi.
Hi. We have good number of people, of candidates applying from overseas. What's your advice for those people who are not practicing medicine in NHS? Thank you.
Yeah, I mean, it shouldn't matter, because the questions are fairly generic sick children. So you are applying for an ST3/4 role. You are applying to be able to come and look after sick children in the NHS. That's the job. So if you wanted to apply at ST1 to get more experience and to have more gentle entry, then you would have applied at ST1. So by applying at ST3/4, you're saying that you feel comfortable to manage neonates, you feel comfortable to manage safeguarding, and you feel comfortable to manage sick patients. That's the job. If you want to be a florist, you need to know about flowers. If you want to be an ST34, you need to know about sick children. So, so we're not expecting you to, as I say, know about politics. We're not expecting you to know where the nearest PICU is, but you will. But the answers will be based with you being a district general hospital, and what that means is that you will not have an intensive care on site. You will be the most senior paediatric practitioner who is resident on site. So there won't be anybody else who is able to come help you from a paediatric perspective immediately. There might be, if it's a neonatal question, then you've got the paediatric registrar who will have the same amount of experience as you. And if it's a paediatric question, you'll have the neonatal registrar. So you could potentially think about calling them down. And also the emergency department team, there will be an adult emergency department team who have paediatric experience in resuscitation. And you can say that you would engage with the senior nursing and medical teams in the emergency department. And it's all about checking in to see if anybody else has got any other ideas. You know, if it's a PIMS TS patient, you know, post-COVID, they are challenging. And, you know, it's like early administration of inotropes and senior clinical assessment early on in the process is really important. So you may not know that because you may or may not have seen that, that type of case. But that's fine. You're going to manage the child as per ABC. If the child's hypotensive, then you obviously need to do something about it. And that would be, you know, fluid boluses at the same time as making sure you're feeling the liver, looking at the JVP, that you're not fluid overloading, and then considering inotropes. But the key thing is going to be communicating to other members of the team who are further up to be able to come and help you. So we're really, really not expecting you to know everything, but we are expecting you to be able to apply your knowledge to be able to look after safeguarding neonates and critically unwell children, and to use all of the team that are around you. Does that answer your question?
We've got two more questions in the chat. One from Tagreed. She's asking, when should I mention escalating? Does it make a difference if I mention it from the start or after the stabilization?
So what I would do is firstly carry out her own assessment. So you know, I would move the child around to resuscitation. I would set them up, and I would put oxygen on, and I would carry out an ABC assessment from top to bottom, and then take a relevant history from the parents. At this point, you know, you'll probably be given more information. So then you can say, okay, it now sounds like I'm going to need an anesthetic registrar to help me. I'll ask the anaesthetist to come and attend. You don't mention it right at the beginning, because then you've not processed any information. It needs to be mentioned at the right time in the scenario. As you would in real life, I mean, you wouldn't escalate every single patient that came through the front door. You know, you have to carry out your own assessment and take the history, and then escalate. And often the scenario will finish at the point of escalation and handover. So when you decide that the child needs to be retrieved and go to an intensive care, and you say that you would then communicate with the retrieval service for them to come and pick up the child and take them to intensive care, that will be the end of the scenario. Or if it's a safeguarding situation, you'll say that you've you know, spoken to the safeguarding lead, you've spoken to social services and have communicated to them about your concerns, you've kept the child safe, and possibly let the police know if it's relevant, then the scenario will finish. So at the point of escalation, it normally finishes, but you do need to work through the whole scenario.
Thank you. Mohammed is asking, how would I avoid pitfalls in answering motivation to career in pediatric question? How can I give a good answer?
So we'll come on to that in a second. Let's just finish clinical thinking. So is everybody else happy with clinical thinking?
Just a small question. In terms of managing resuscitation scenarios, there are some key drugs whose dosages usually we're supposed to know. Is that something that you'd be looking at?
Not, I mean, so drug doses we're not going to be that concerned about. You can say as per APLS guidelines or
Right.
antibiotics as per local antibiotic guideline. There's obviously, I mean, probably the key antibiotic we'll expect you to know is ceftriaxone for meningitis. And for, I mean, but we're not going to expect you to know the dose of all the other types of medicines that you'd be expected to give. You know, and if you're in doubt about the dose, you would just say you would check the guideline.
Sure, thank you.
You don't have to know. Yeah, I wouldn't worry about doses.
Okay.
Okay.
Last question from Mohammed asking, do we need to make a debrief?
So if, so obviously debrief is important where something, you should do it when something good has happened or when something not so good has happened. So we had a situation at King's, it was a while ago, where a child came in who was septic. The nurse at triage recommended it straight away, moved the child around to resuscitate. And within 17 minutes, 17, the child had 2 IV lines in 40 mils per kilo peripheral anatropes and was intubated, which was just amazing. And the child had a fantastic outcome. So we actually debriefed that scenario because they did so well. We were interested in trying to work out why they did so well. And of course, it came down to teamwork and communication. But if there's been a poor outcome to the scenario or it's very stressful, then it would be good to say at the end, you know, I would like to be, you know, to organize a debrief for the team members involved in this so that we can talk through it and make sure we capture any learning for the future. But you don't need to talk through the detail of how the debrief is run, but just mentioning it is probably a good thing. Okay, so shall we move on to, we'll do communication next, if that's okay. So the communication scenarios are harder in ST3-4 than they are in ST1-2. And you are likely to encounter, so for instance, so you might get a child with cystic fibrosis who is refusing to take her medications, a teenager, and who's difficult to engage with and doesn't want to talk to you. Now that's really challenging when you're in a 10-minute scenario and your job is to have a communication scenario with this person, especially over Teams. It's easier in real life when you can pull your chair a bit further forward and kind of demonstrate empathy. But empathy is a lot harder to demonstrate over Teams than it is in real life. So I think the key thing here is to listen, to be careful with saying that you understand their concerns and their problems, because you probably don't. You know, you're not a teenager, you don't have cystic fibrosis, and you don't understand the implications of it in terms of interacting with other members of the team. You can say that you understand it, this must be really hard. But don't say you understand how they're feeling, because you don't. And so I think in those situations, the key thing is listening. And then if it's a teenager, you can use the HEADS assessment. I don't know if people are familiar with HEADS. So HEADS stands for home, education, activities, drugs, and sex. So firstly, you ask about their home environment. You know, so you sort of kind of change the direction of travel a little bit and saying, okay, let's talk about home. You know, how is it at home? Who lives at home with you? Do you feel safe at home? How's school going? Do you have some good friends? You know, what do you do? What are your hobbies? What do you like doing outside of school, outside of home? What are your activities? Yeah, and then eventually you might then get on to talk about drugs and other aspects. But you might find that just starting that HEADS assessment in a teenager, it will be what they're expecting. There you go, someone's put on HEADS, so thank you very much. it will be what they're expecting in the scenario, and the scenario will then follow, and she or he will open up and will give you a route in. So so difficult teenagers don't just keep asking the same question. They will be told not to answer. If you keep saying, you know, why are you not taking your medicines? You've got cystic fibrosis, it will kill you if you don't do it. You know, that will be a very poor way to run the scenario. So just ask the questions, see if she or he will engage with you, and then go down a heads route is a good thing to do with a teenager. The other common communication scenarios are obviously safeguarding, where you're in the emergency department, you've noticed a significant safeguarding concern, maybe a spiral fracture without any mechanism of injury, or a significant bruising in a non-mobile toddler. And you'll be expected to have the conversation around the fact the child needs to come in and to enter through the safeguarding processes. So you do need to know the kind of safeguarding referral pathway that we use in the UK. We're not expecting you to know the full book, of course not, but certainly that you would call social services and do a background check and see if the child is known to social services and if there's any concerns. Find out who else is at home, other children who are at home, anybody else who's at risk, and if anybody at home is on the known to social services. Make sure the child is kept safe. Bring the child in, speak to your consultant, speak to the safeguarding team, and make sure they get involved. Think about having a discharge planning meeting before the child is discharged, and possibly a kind of child strategy meeting for that child, with the multidisciplinary team involving the police, the school, everybody else who needs to be involved. So these things would need to be discussed in the safeguarding scenario, but the key thing is keep the child safe, and speak to your consultant and to the safeguarding team and check with social services. But the most important thing is keep the child safe. So if you do that, then you'll almost certainly have done pretty well in that type of scenario. The other common communication scenario is as Ala was saying earlier on, the kind of retrieval of, say, the cardiac neonate. If you're in a DGH and you've got a child pitch up who's got oxygen saturations of 70%, but a clear chest and has got a heart murmur and is tachycardic, then the retrieval of that baby to the retrieval service and how to manage it and think about starting prostaglandin, etc. Is a reasonably common scenario. So they are the common communication scenarios. The key thing is to speak to the mum, ascertain what they know, give the information that you know in a nice packaged format, pause, check understanding, summarize, move on, try to give a plan with some summaries throughout the scenario as you go along. Any questions about communication? So everyone's happy with that? So we don't do the motivation question so much in ST3-4 as we do it's obviously more important ST1-2. We kind of think by ST3-4 you've demonstrated that you want to do pediatrics by the amount of peds that you've done. So we tend to focus more on governance, and the governance question will usually be about an adverse incident that's occurred, and on reflective learning. So you will need to know about the adverse incident process in the UK, and there isn't really much you need to know apart from the fact that if a mistake has occurred, we need to speak to the parents and let them know through what we call a duty of candor conversation, and fully document that in the notes so that it's well recorded. And it's about openness, honesty, and transparency. and not about blaming at this stage. It's then about organizing a full root cause analysis. So we would call this, you know, a serious incident investigation, or an RCA, root cause analysis. And we'll work through with a full investigation involving interviews of those involved if necessary, and coming up with a report which will be shared with the parents. And that then will form the sort of process of, you know, any ongoing complaints or further processes that the parents want to pursue with the hospital. But the key thing is it will be done with the parents, with them being involved and sort of co-produced with them. And it's about learning from the process and then sharing that learning. So probably the most important thing about any adverse incident, and it's probably the thing that most people struggle to do the most, is demonstrating sharing of the learning, and that the learning has been shared and learned by the whole department. But I think that's a really key thing to emphasize. It's why we do this, is to find out what happened, how we can make things better in the future, and to share that learning. So that will be the things that you're going to get in governance, and it can be anything. It can be a 10 times drug overdose. It can be a, you know, a nasogastric tube that's gone down into the lung rather than into the stomach, and feed's been given through that. It can be a child who's not been assessed properly in the emergency department and then has returned with fulminant meningitis, all sorts of things. But the key thing is openness, honesty, transparency with the parents, demonstrating you're going to do a root cause analysis, and you're going to learn, and you're going to share everything with the parents. Any questions about governance? I think there were some questions further up. I can't see any other questions there.
No, nothing regarding the governance so far.
Okay. And again, read everything on the RCPCH website, because the wording of the questions for the governance and for the reflective practice answers will be verbatim what is written on the website. So for the reflective practice question, you will be asked, tell us about when something has gone well or not well. What did you learn from that process, and how have you incorporated that learning into your kind of everyday daily practice? So think of a scenario that you're going to talk about beforehand where you've genuinely had learning. You know you're going to be asked a question, so be prepared for it. Everybody has made mistakes. So, you know, you can't do medicine without making mistakes. And if anybody tells me that they've not made mistakes, I'm really generally very worried about them. I kind of think, well, they probably have no insight into the fact that they're probably making mistakes the whole time. So we've all made mistakes. And the key thing is we recognize it and we learn from it. So do read everything on the RCPCH website, and where there's a verbatim question, it will be read out verbatim. Any questions about anything else to do with ST34 interview process?
In these questions for governance and reflective practice, will the interviewers like prod you or ask you for more information, lead you, or just let you speak?
So, so each interview day will do their own benchmarking, and they will decide on what prompts they're going to give to every candidate. Normally for the governance and reflective practice sections, you won't prompt too much, because you know the question is there on the website, and you know you're going to be asked it. So I would suggest just being really prepared for that. You might be more likely to get a prompt in the clinical thinking scenario if they feel you're going on the wrong tangent. So if they think you've gone down the wrong road and you've not understood the scenario, they'll stop you. And they'll do the same thing actually in governance as well. If they think you're going down the wrong scenario, they'll read the question again and emphasize the key bits. But they won't, you know, it's not a tutorial. It is an interview. So so they probably won't get too many prompts, I'm afraid. Any other questions?
I'm sorry, I have a question about ST1 again, interview.
Yeah, that's fine.
Is it make a difference if I have like an experience in pediatrics? If that will affect my answers if they ask me about clinical scenario in ST1, and then, you know, yeah, my experience will top up what I'm saying. So is it make a difference in my scoring?
So not really. I remember interviewing this candidate a few years ago, and I was asking about previous experience, and she said, I've deliberately not done any pediatrics before in my F1 or F2 year. I know I'm going to be a pediatrician for the rest of my life, and I wanted to get as much experience and everything else before going into pediatrics. And I thought that was a fantastic answer. So no, so you don't, for ST1, we're not expecting any previous clinical experience. It obviously does help to give your answers more context. You know, if you can say, when you're talking about managing, I don't know, severe asthma in children, and you say, you know, I've frequently seen that children get salbutamol toxic and get tremulous. It does tend to give it a bit of context, the fact that you've seen it, but equally you'd see that in young adults as well if you were doing, you know, adult medicine. So we try not to give marks for previous experience, but it is difficult because those kind of unconscious biases that we all have, and where a candidate has got previous experience, even though there's no marks for it, sometimes I think examiners find it difficult to not give an extra mark. So I think unconscious bias does come out in terms of previous experience. I'm not sure if that reassures you or not.
Yeah, it's reassuring.
I wanted to just ask, of course we outweigh the pros versus the negatives, but is there anything specific that we should talk about when speaking about NHS, about COVID anxieties, people presenting to the hospital? Is there anything specific?
Yeah, I mean, I think you probably just need a few throwaway lines that you've got. I mean, so obviously COVID was more of an adult problem in pediatrics, but we have seen quite a lot of it in pediatrics as well. But a lot of children are admitted with COVID and not because of it. And some of them obviously do become very unwell and end up on intensive care, but it's very rare. So I would say that, you know, we're following all of the, you know, PPE and infection control policies as per the NHS. And it's as safe to be admitted here to hospital into a cubicle as it is anywhere else. And the most important thing is that the child's in the right place to manage their condition. And we do everything we can to ensure that there is no transmission of COVID in the clinical environments. So try to be kind of reassuring. You can't 100% reassure and say that there won't be any, you know, any cross-contamination with COVID in the clinical environment, because it does happen, but it's extremely rare in pediatrics. And you could possibly say that all of the workforce have been double, if not triple vaccinated, which reduces the transmission of viruses amongst the workforce and helps to protect our patients. So I would be reassuring, but understanding. So, you know, completely understand this is incredibly stressful. Everybody's been through a really difficult time over the last 2 years. However, we do everything we can to minimize any chance of sort of COVID cross-contamination, and we consider it to be a safe place to be admitted. Something like that. Does that answer your question?
Thank you very much. Yeah.
So I've got a question here. What's a good answer for the example of severe asthma management structure for an ST1 candidate not reflecting the subconscious bias? I mean, you can't really prepare for reducing unconscious bias. I'm just being honest and saying that there probably is a bit of unconscious bias in everything that we do. But I think just managing it, as they say, playing everything with a straight bat in terms of the cricket reference. So if it's severe asthma, I would take the child around to resuscitation, connect the child up to monitoring, put the child on oxygen, and then carry out a thorough ABC assessment. And if if I find that there is decreased air entry and the chest is very tight or is nearly silent, then I would progress as per the severe asthma protocol, as per APLS. And that would involve a combined nebulizer with salbutamol, atropine, and magnesium, early administration of intravenous magnesium, and continued salbutamol nebulization, and ensuring that there is no salbutamol toxicity, monitoring that with blood gases, etc. So it would just be very specific, the same way that you would do for an adult. But it's there's no, I mean, I'm just putting it out there about subconscious and unconscious bias, it's the things that I think you're probably talking about 1 or 2 points maximum. Hopefully all of the interviewers have had training in how to minimize unconscious bias. So we do take it very seriously. But I was asked about would extra experience help? And it's difficult to, when someone's able to give more context or demonstrate previous experience, it probably does help. But I wouldn't deliberately go to try to reduce the effect. You can just do the best that you can do.
Okay, we got Arwa is asking, is there any plan for ST3, ST4 interviews to change to face-to-face if the COVID situation improved within the next week?
So it won't be changing face-to-face this time around, definitely not. It will be remote. I would love for interviews to go back to face-to-face as soon as possible. You have a much better interview experience. You actually need less interviewers. It might sound crazy, but you do. So for ST1, we're going to have 3 interviewers on each panel, and the whole 3 interviewers will interview for the whole half an hour. Last year, it was just 2 interviewers for the half an hour. But we wanted to have split panels and have 2 interviews doing 15 minutes each. But that was felt to be too technically difficult with our current IT infrastructure that HEE use. But yes, I would love to go back to face-to-face, but it won't happen this year.
All right, I think our time is up now. If you got any questions, we can, just for the candidate, we can send them an email for Dr. Bruton as well. Thank you so much, Dr. Bruton, for today. It's always a pleasure to have you as usual.
No, thank you. I enjoy coming. And I've managed to find one of my people who I've helped to train, a guy called Shahid Kareem, who's now a consultant and is part of the recruitment team. He would be keen to get involved in this in the future as well and to help out.
Sure.
So he's one of my consultant colleagues at King's, and he's absolutely brilliant.
Then definitely we'll reach out to you to take his contact details, of course.
Will you email me and remind me, and I will, and I'll connect everybody.
Definitely, sure. Thank you. Have a lovely day.
And you, take care, chaps.
Bye.
Bye.
So everyone, now we will go for a break, 10 minutes break. Please be back at 11 to continue our afternoon sessions. Have a lovely coffee.
unmute naweza kuzungumza.
بأبناه الحروب لا نهاب الموت أو نخشى الخطوب نحفظ السودان في هذه القلوب نفتديه من شمال أو جنوب بالكفاح المر والعزم المتين وقلوب من حديد لا تلين نهزم الشر ونجلي الغاصبين كنسور الجو أو أسد العرين ندفع الردى نصد من عدا ندفع الردى نصد من عدا نحن جند الله جند الوطن إن دعا داعي الفداء لم نخن نتحدى الموت عند المحن نشتري المجد بأغلى ثمن هذه الأرض لنا فليعز سوداننا على من بين الأمم
فعلت فيها ندم الدم بحيل الدم سامحني يا والله إذا أنا على الشيطان فعلت فيها ندم الزم الزور بشيل اخوه سامحني يا ملضم يا داري يا يما جسمي الفقد دمه يا داري يا يما جسمي الفقد دمه عيني بجافية النوم قلبي الكتير همه عيني بجافية النوم قلبي الكتير همه قلبي الكتير همه الروح تحل الروح ولا لأخوي حنين دفقت دمي بكيت أنا بكيت الروح تحل الروح ولا لأخوي حنين أنا دفقت دمي بكيت دفقت دمعي بكيت الروح تحل الروح وانا لاخوي حنين
Welcome back, everyone. Good morning. It's my pleasure to be here today. Let me introduce myself. My name is Buran Khalifa. I'm currently working as a pediatric trainee at ST4 level in the very beloved West Yorkshire Deanery. I'm not trying to sell it or anything. I'm also a member of the academic office at BSAPCH, the organization that is setting this event. I'm very proud and my pleasure to introduce our next speaker, Dr. Mohamed Mutalib. He is a pediatric gastroenterology consultant at the Evelina Children's Hospital, London. He is also head of the Service for Pediatric Gastroenterology and joint clinical lead for the South Thames Pediatric Gastroenterology Network. As well, Dr. Mohamed Mutalib is a honorary senior lecturer at KCL. In this upcoming 45 minutes, Dr. Mutalib will take us through an essential station in your interview, which is also a common encounter for all of us in our daily practice, which is reflective practice. Please welcome Dr. Mutalib. Enjoy your next 45 minutes. And Dr. Mutalib, the floor is yours. Thank you.
Shukran jazeelan. Let me just share my screen. All right, I hope you can all see my screen. Can you hear me okay?
Yes.
You can hear me, right. Excellent. So, to start with, let's start with what is reflection. So reflection as an English word, as a clear meaning. You will all be aware of it for now. However, reflection in medical educations have a slightly different meaning. And some of you who are already practicing in the UK and trying to apply for a training job will very much be aware what reflection means. And the people of you who've not yet worked in the UK, who might not work in a country where reflection is embedded in practice, may want to look into this in a different way and try to take some of what I say today, not only for your applications, but for your day-to-day practice. I'm not planning to talk for a whole 45 minutes. I will talk for the first part of it, and I'm trying to really make it to give you a chance to ask as many questions as you can. The talk will be divided into aspects. One of it will be first to tell you what exactly the whole story of reflection, and we will end with an example case report. We'll discuss an aspect of reflection in a case. At the end, you will have a chance to ask me if you have any questions. So to start with, reflection is a metacognitive process that creates a greater understanding of self and situations to inform future action. Without reflection, we wouldn't really survive. Human has identified reflection all the way from as long as we existed. Cavemen realize if you toy with animals, certain animals, you die, then you better avoid them. If you eat some plants, you die, you better avoid them. That's a basic form of reflection. You stop, you evaluate your actions, you take lessons, and you implement those lessons in your future practice. From there, we've moved forward a little bit, and we've now trying to look at reflection as a process that you take from your practice. So in medical education or in education in general, reflection, in the educational context, reflection is considered as a process which thoughts are turned back so that they can be interpreted and analyzed. So you take each steps that you take in your reading, in your writing, in your learning, you stop back and you turn them back on yourself. Then as you're looking at the mirror to see your own reflection, you turn back your thoughts. You can then reinterpret them and you reanalyze them after the event has happened. Furthermore, reflection is also can be taken as the process where an individual thinks analytically about anything relating to their professional practice with an intention of gaining insight and using the lessons learned to maintain good practice or make improvement where possible. So you can see different definitions stemming from the same angle and reaching back the same endpoint. They're all looking at it from a slightly different point based on what aspect that you're looking for reflection in your practice. So the basic aspect of reflection go into you do, you review, you plan. We've taken the caveman as an example. You eat wild berries, you poison yourself, you become ill, you don't do it again. So your actions, eating something, you review what happened, you plan your future, and you do it again in a different way. And that's a basic cycle of reflection. Okay. We can't really take this basic cycle of reflection in medicine, in particular in a very complex medical setting, and I will show you in the next few slides why is that. But if you've never had any form of reflection before, I think that should be your starting point. If you're completely confused about all of these presentations, all what you want you to take over is this slide. Is you do something, you review, you plan, you do it differently, you review and you plan. It's a cycle because the cycle never stops, because reflection never stops. Every stage, it allows you to refine your revision, allow you to refine your plan, it will allow you to change what you do. Yeah. The cycle reflection based on learning. That's what we've agreed on so far. So what we have to address now in this slide will be what is a cycle of learning. Your cycle of learning will be, we all go, you learn something new every day. Okay? That could be really a passive learning. You can turn that around and try to make it an active learning. So the first question you'll ask yourself, what happens? I walked out, it's very cold, I don't have a coat. Okay, so you're starting with your concrete experience. You then to go to next step, for analysis. You reflect on the observations. What did I feel? What is actually this experience has made me do? And that is your initial step of analyzing without being mad of it. Okay, without you completely immerse yourself into this experience, you take yourself out, you analyze and reflect on the observations. Then the next aspect from that, you make generalizations. It's abstract conceptualizations. Okay? You make a general aspect and general analysis of what has happened. From this analysis, you plan your future action. Okay? This is general things. That is a little bit a step further from the slide earlier we've talked about. And about really the 3 cycles, you've taken it a step to a better understanding your experience. You take your experience, you analyze it based on your observations, you're trying to make generalization from that. I will not walk out of the door again because I walked out of the door, I was really cold, I didn't have a coat. That is a generalizations. Then you realize actually what is the future plan of action. If you want to leave, you have to make some changes. You have to put a coat. So enough, that's a concept. Then this is just a general thought. So how do I reflect? It is all good and fine. And that is, I say, I stopped, I learned, I assessed, I made plan, and I do them again. So what actually in medicine, what do I reflect? You can simply be skip all that one and straight away jump to the part where you're all awesome and we are all awesome and then no reflection is ever required. But that is really missing the point, right? If we've never actually learned how to reflect, we will never be able to produce or progress in our career in which direction or never directions. Yeah? And that is, as goes, are really, really simple things that you could do, all of you, day in and day out, to much, much more complex things. The simple things goes, given again, and I go back to our basic example, you touch a very, very, very hot cup of tea that will make you burn your tongue, then you wouldn't do it again, all the way to having resuscitating a 24-weeker and what actually the steps has been taken and how to utilize your team and what is the outcome for that particular resuscitations. The principle is the same, and the aspect is the same, the outcome is the same, and the learning journey is the same. It's just a structure of that's a little bit much more different, and it always starts with a cycle. It is what, so what, and now what. What is the thinking aspect? Okay. That you stop and you think. So what is the feeling of that? And now what is what you're doing from it? And I take you through the journey, trying to understand each one of those. So what? That is the first start of having a reflection. And we say, what is it is to focus on thought at the time of the experience. It explores thought process when a particular action or decision was taken and how those may have impacted on actions and feeling. This sounds a completely abstract idea, but let us take it as an example. What was I thinking when I took the action or made the decision I did? Okay. Basics, you are eating something very, very, very spicy. The question is what I was thinking when I took the action and made that decision I do. Maybe I was really feeling very full, but that is you completely blocking the idea. You're missing the point if I say, actually, I shouldn't have done it. This is now you're blocking. That's not reflection. That is not allowing you to define in a structured way what is the best next action to take. Okay. So the what aspect is what were you thinking when you took that action or make that decision. Okay. And that has to become after the incidents or after the action has been taken place, because you really can't really take that thinking while you're right inside the action you wanted to analyze. So that is the what aspect. Moving to the next aspect, it is so what. Yeah. The so what aspect is involved considering the significance of what happened, as well as the value and the feelings at the time of and prompted by the experience, and why these may influence future learning or actions. If we take that as an example, how did I feel at the time and after the experience? Why was it important? Okay. Back again to the basic example, you're eating something really, really, really spicy. You're kind of in the panic stage, it's already finished. You do the what aspect, and now you go to the so what. What did I feel at the time? So you're looking back into it. You're not just saying, oh, actually, I'm a completely idiot. I will never do that again. This is not a reflection. That's blocking your learning process, blocking your ability to move to the next step of understanding and learning and trying to avoid. I'm sorry, can you mute yourself, please? That will take you how I feel at the time and after the experience, and why was it important? Okay? That will make you stop, make you analyze your feeling while you're going through this process. And that might allow you to explore. There are so many different feelings that is you could explore. In each sort of steps, there might be something you could explore or something you could learn from. Okay? And why was that important? It's important because it takes into account the wider aspect. It doesn't really take into account, actually, I felt absolutely horrible when I ate these things. No, it's not about that. It's about what are those steps. Can I modify each and of those steps? What are the steps going through? What did I feel through each aspect of those? And why was that important for me? Okay. So all of those steps are really, really important. And that is a different way of thinking that, oops, I shouldn't have done that again, because this is really not the point of a reflection. Then let's go to now what. So now what is the final aspect of the journey you're going through the reflection before the cycle will start again. So then now what, it looked at the process and the opportunities that can help learning from experience and identifying future action, reflection on those actions, and how to use these to develop any future actions. So I put as an example, what can I learn from or do differently next time? That could be starting point, I will never eat this dish again. That is fair as a point. Or actually, I might need to modify the way I learn it, might need to cool it a little bit down, might need to add a little bit more to neutralize as fast as I can do, might need to drink something with it and to coming across. I might need to modify the ingredients that I put into it. So if you take it as a symbol at the dish that you ate, you can realize there is more than one action. If you are blocking yourself saying, I'm never going through that, you've completely missed the point of a reflection and missed the point that you could still enjoy what you would like to eat, but you could modify it by which you make it much more tolerable and enjoyable in the same time. And without going through a process of a structured reflection, you will never be able to achieve that. And I'm intentionally so far have not really put in any example in medicine because we will be coming to an example in medical practice. But this is really a talk directed to people who never come through what is the process of reflection. What does reflection mean? I can't remember how many, or I don't know how many of you are completely overseas and how many of you practice in the UK. I remember coming to the UK quite a while ago and like, what exactly reflection? I really don't know. You have to do something, you don't do something. You go as a child, you put a cannula, you either get the cannula in, you don't get the cannula out. What actually the whole idea of reflection about? And then you realize putting a cannula, it's not just by succeeding or not succeeding in putting this cannula. It's not by asking someone more experienced or someone more senior to do that cannula. There is so many factors that is you could consider when you are trying to put that cannula. How cooperative what the child is, how hydrated what the child is, how hungry what the parents is, how helpful what the nursing staff is. So there are so many factors that could potentially influence your ability to put that cannula. You could be the most experienced or the most skillful person in putting cannulas as can, but if we put you in an extremely stressful situation by which you put an angry parents looking at you, with an absolutely unhelpful staff supporting you from that, you will not get it. On the vice versa, if you change that surroundings and make it much more comfortable and make it much more better to improve your skill from doing that, you will likely to be able to cannulate that child successfully. So that is a whole idea of reflection, and that is, it took me a bit of a journey to actually to achieve from when I just came from Sudan up to here, and to like, okay, what exactly is the whole of the idea, to understanding it is actually a process that if you immerse yourself into, it's not just a tick box exercise you want it because the GMC said you have to learn for reflective, or it's not just a process I have to put to make sure that an application form or my CV get picked up and I can be invited to interview and get that job. It's really designed for you to improve your ability and to get the better out of your own self. Obviously, the final aspect of doing any process is you have to document it. There isn't really anything not documented, not happened. That is medical notes, that's reflective practice, that's anything that we do here has to have an aspect of documentations. When you reflect, it helps an individual to challenge the assumption and consider opportunities for improvement. Because again, putting a cannula in a child, a screaming child, if you could not get it after multiple tries, you can either come into two conclusions. One conclusion, I'm absolutely rubbish, I really don't know how to put cannulas. You're full stop, you're done. That's not a reflection, that's just dooming yourself. But actually, what is this assumption? You can challenge it and try to find ways, why did I not get it? What actually has happened? What are the process that is I followed? And what is the feelings? And I can go through the 3 cycles we've talked about earlier to reach what are the opportunities for improvement, allowing you for the next time to put a cannula successfully. But also developing the capacity to reflect should focus on the reflective process and how to use it productively rather than the specific number and type of reflective notes. So again, it's not about tick box exercise, not about actually I sat down, I put a cannula, I didn't really get it, I go outside in the office, I write a reflective note and finish, I put in my portfolio, I'm done. That's not really reflective. That's a tick box exercise and will not really allow you to progress or improve. And then engagement in the reflection can be demonstrated in different ways depending on the career stage. Your reflection as a ST1 is very different from my reflection as a consultant, but we all have exactly the same principle and the same concept. How can we move from point A to point B and how to progress from that? Again, we taught the child about resuscitating at 24 weekers. As an SHO, you will be the one putting the cannulas. You might be lucky to put the ET tube. As a registrar, you will be the one who is talking the airway. As a consultant, the one who will be actually saying, this is enough. We have to stop and talk to the parent saying, we can't really save your infant anymore. So those are all aspects based on your role into the team. And you would need to learn how to reflect in each of those aspects. So, what can it happens when people ask you? People can ask you in an interview, or the questions could be in your application form. Could tell us about an incident or a situation or a feeling that gave you a cause to reflect. And that's what I want you all to take out of this, to go back and find out your own scenario that will help you to reflect. And that we've gone through a lot of scenarios through this, from a caveman who ate a wild berry to drinking a hot cup of tea or eating spicy food, or successfully putting or unsuccessfully putting a cannula or resuscitating at 24 weeks. Let's try to hone that down. Let's try to bring that down into a one concrete example. And I chose just a random example, say a young child with an established epilepsy came to A&E following a prolonged seizure and is admitted to ITU following a respiratory arrest. You can say, I was on call that weekend and I was part of the team that treated this child in A&E. Story, I'm sure all of you, one way or another way, might have been involved into that. People who have easy access to intensive care would definitely have seen a lot of those. People who work in a smaller hospital where there is no ITU, you would have absolutely come across it because you would be the person to call the retrieval team. And people who work in a different setting might have a different outcome to go and tell the families, but they're all a common pediatric scenario that could happen to any of us in a different stage of your training. So the question will be, what makes you stop and think? It's an incident that's happened. So let us dig deeply a little bit on that example. The example is the child had received 4 doses of benzodiazepine prior to a loading dose of intravenous phenytoin. When he had the phenytoin, the seizures has stopped very quickly. Digging deeper, we realize one of those benzodiazepine doses has been doubled in error. In the milieu of the situation, neither I nor anybody else had fully appreciated how many doses of benzodiazepine he had already received until after his respiratory arrest. So this child coming, fitting So again, we will say the few of you who might have been in a research situation, you would absolutely relate to this. It's so many people, a child is spitting, everyone is trying their best, everyone is trying to do something. A drug error could very easily happen. Nobody went back again and asked how many doses have been happening. Everyone following a protocol in their head, and everyone is trying to come up with something. So it was later agreed that the likely cause of the respiratory arrest was secondary to a number of doses of benzodiazepine the child has received across a number of settings. So nobody has actually reflected this child at home, had an emergency plan. Their parents gave him the first dose of benzodiazepine. The ambulance came and the child was still fitting. The ambulance gave him the first dose of, again, the second dose of benzodiazepine, but the first dose for them. Then he came to A&E, the A&E team first saw the child is fitting, they started again from the same point, which is the first starting point of benzodiazepine. So nobody actually really had recognized how many doses of benzodiazepine has already happened. So everyone started from point A in the algorithm, and nobody moved from that point or reanalyzed point A and how many doses has been received. And unfortunately, one of those doses has been doubled. And after all of this, he needed a short period of incubation because that is a respiratory depression secondary to medications, and fortunately made a full recovery. So there are many ways to reflect on this. How do you do it? You can panic, okay? You can fear, like what? Oh my God, I will be referred to the GMC because I was the one who wrote, I was being part of this team, so I must have had a mistake. This is an absolutely my worst nightmare. How do I need to call the MDU? Do I need to call my indemnity? Do I need to prepare my report? Will there actually have something happen to me? Will I be called and I told off? Or you can do the Bart Simpson. I didn't do it. No one saw me. I was part of hundreds of people. There was 9 people in there. Nobody can figure out actually who did what. It's not me. I might just hide and stay quiet. If my name has not been mentioned, I'm safe. So those are all ways, those are 3 scenarios that could go into anyone's head that has been on the stressful situation. But actually none of those would really help you to learn, and none of those are really what we call reflection. So reflection, again, there are many ways. Number 1, there's no point of hiding it. You're hiding it, it doesn't really help you. The child eventually did not really come into any harm, and the seizures have finished. He was discharged from intensive care. There were so many issues and that need to be addressed, and hiding them will just make them happen. The likelihood of them happening again is significantly higher. So number 1, I can say I discussed that with my colleagues in A&E and the pediatric team. I wasn't aware of the literature. I reviewed the literature on the management of status epilepticus. I looked at that independently, and I familiarized myself with what is the most recent guidelines about how to manage children with status epilepticus. That is a what. And now, what did you do? As a reflection, I flagged that as a near miss. Why is it near miss? Because this child could potentially had a lot of damage happen from this. So the outcome, fortunately for this child, was a good outcome because no harm has been done, but that's only purely back of luck because it could have easily gone the other way around. So it needs to be flagged in the hospital safety system because that's the last of safety. That's the first step. Remember, in whatever we do, you have to put the patient first. And when you put the patient first, the healthcare system should be around, and the child and the patient should be in the center of it. Near miss, it has to be a near miss, it has to be locked in properly, and it has to be taken properly. Second step, what did I do personally? I reviewed the latest literature on management of status epilepticus, because you need to familiarize yourself about what actually the guidelines have said. Because somehow if the guidelines said you have to give 4 doses of benzodiazepine, and there's no issues, you just follow the guidelines. Unfortunately, the poor outcome happened despite following the right guidelines. But if the guideline says something different, that's an opportunity to change what you have here. And the second will be, I suggested an update on the protocol. I emphasized on the correct doses and pathway and medication use and the importance of a timeline. And finally, the duty of candor. I put the duty of candor in that because it is again an integral part of the GMC. The GMC had clearly defined what duty of candor is. If a mistake happened, you have a duty to go and apologize to the family, explain to them what has happened. I wouldn't expect any of you as a ST1 to do that, but you need to be aware of it. You can't really have an incident that is had a medical mistake without mentioning a duty of candor. So the question then will be, tell us what you took away and learned from this experience. We've analyzed the experience, we've analyzed your process going through that. Now you need to go through the reflection. So number one, I could say I could have made more stringent inquiries about the number of doses and quantity of doses of benzodiazepine he has already received when I arrived in A&E. So any of you who has been in the same scenario, you will notice there are so many people in research when a child is coming across. You could very easily delegate someone to go and ask the family and ask the paramedics about how many doses has been given. That will be a very easy step and will allow you to identify areas where the practice could have changed in the future. This emphasizes the importance of teamwork at this acute setting. So again, you see that the steps that we've taken from here, it's not really about one step, it's about learning and looking at it in a different angle. You've come out of it, you've identified the problem, and now you realize there's another areas that you could actually identify, the teamwork. So each member of the team has a role to play, but each member of the team could also be productive in their own way. Okay, you could be the most junior person, the F1 into that. So you don't really have a lot of role to play because there's an anesthetic registrar looking after the airway. There's a pediatric registrar who is cannulating. There's an A&E consultant who is leading that. So the F1 might not necessarily have anything, but you could just simply involve the F1 and ask them to take a very simple history from the family, asking about what the doses of the benzodiazepine taken, and take a quick handover from the paramedics to identify that area. So this is really important because you've identified an extra area that is you might not, if you've not come across a proper reflection, you might not have identified. So if you all the process and oh, actually, what has happened? Next time, what we do, we need to ask them how many doses of benzodiazepine and then take it from there. This is not a reflection. This is just stating what has gone wrong and how do you fix it. But you don't really, you're missing a teamwork. You're missing the work within the A&E has done, and also you're missing what is the new guidelines has achieved, what's the up-to-date guidelines, what the condition has been produced. So final point will be, it's also emphasized the importance of good communication between parents, ambulance, A&E, pediatrician, in acute and high pressure. Again, that's different from the teamwork. It's different about the communications. How can people feel less intimidated to raise a point that has happened, and how there is a way for this point to be received in the heat of the moment. Again, that's a different area. If you've not gone through reflection properly, you could very easily miss this point, and you will just find yourself again 2 weeks down the line in the same situation, different setting, might be asthma this time, and you will have to make the same mistake. So how did you change? So identify the point, we've looked, we reflected, we've identified that. You have to complete the cycle. What did you do to change your practice or making you think of changing your practice? Okay, I took away the importance of good communication, asking the right questions in the heat of the moment. Okay. That is your steps that you are taking. You've stopped, you've come up with all those areas that we've shown you in the previous slide, you've identified areas. And what you need to do now, you said, actually, next time I realize how important good communication is and how that can be very crucial to the outcome of the child, irrespective of the conditions. And I also come out understanding that is asking the right questions in the heat of the moment could be absolutely vital. Yes, the child is fitting, the child is still in the status for the last 20 minutes, but actually by asking the questions, we've sent the child to intensive care. All is what required is asking the questions, and if we ask those questions, we can give this child the IV phenytoin from the start, and he would not have gone to intensive care, and the fit would have stopped anyway, because we know that the fit has stopped after giving the phenytoin. And then he also ensure everyone knows about the appropriate management steps and practices. Because what it happens is that everyone seems to be using exactly the same protocol and starting from exactly the same point. Parents have the emergency protocol, they started from point A, benzodiazepine. Paramedics have the same point, start from point A, benzodiazepine. A&E staff have the same point, start from point A, benzodiazepine. Pediatric has the same point, starting from point A, benzodiazepine. So we are doing exactly the same thing, and they really need to be changed of how is our practice and happening on that, and where everyone should have their starting point coming from. So that will be how I conclude, and how did I change my thinking or I change my practice. So I wanted to conclude my slide, and I think I finished exactly when I wanted to finish, which is giving you a bit of time afterwards to ask questions. What are the top tips? Number one, my number one top tip for anyone who wanted to come and work in the UK, reflection is really not a tick box exercise. Reflection is not something you will take. I did not intentionally mention the case, a really sad case by which a doctor has been struck off for a very long period of time before returning to practice because of her reflective note. I think this is an outlier and we should leave it as an outlier. But generally speaking, reflection is a tool that is extremely helpful to use. We'll learn a lot from it, and it will help you improve your practice quite significantly if used in the right way. Put aside time to reflect. Sometimes everyone is really very busy, you're very, very busy, you're very, very tired. I think 5 minutes to stop and reflect is extremely helpful. Record it as something you need to address, and remember to complete your reflective note when you're finished. Okay? You don't really, it is not about doom and gloom. You're not self-flagellating yourself. You're not just kind of really, oh, absolutely the worst nightmare. I shouldn't have done it. I take complete responsibility. It's my mistake. This is not reflection. Okay? This is just a self-blame, a self-pity that doesn't really help you. And remember, when you write your reflection, you're not really putting your admission of guilt. So there are two different things, an admission of guilt and reflection. If you've made a mistake, then you've made an admission of guilt. The GMC has a very, very clear pathway, which we call the duty of candor, and that has to be addressed and discussed. If you're not familiar with that, I suggest that you could familiarize yourself with it. But reflective note is not about admission of guilt. It's about what we've talked about in the presentation for the last half an hour or so. Okay? You can't, and majority of time, it's virtually impossible to reflect alone. Okay? You need to discuss it with your colleagues. For you as an ST1 or potential ST1, you need to discuss that with your registrar, you need to discuss that with your educational supervisor, because someone will have to get you out of it. If you happen to be the person who wrote the dose, the wrong dose for the child, the double dose of benzodiazepine, who sent the child to intensive care, you can't think clearly out of, oh my God, what did I do? You need to discuss that with your educational supervisor. You need to discuss that with something to take you out of it and try to make you think what has made you write the double dose. What are the steps that you could have done differently to make sure that is next time that does not happen? And that is the answer. Well, that can't be, oh, I will have to double check it very well. This is not the answer. This is just an admission of guilt and a simplistic way of trying to convince yourself, I will not do it again. If you don't go through the step, you will definitely do it again. Okay. You have also to look at the literature and any clinical guidance to further inform you. Reflect on how your team function to address this problem. Okay. And addressing the problem, you need to look at the guidelines. You need to look at what is available, the evidence-based guidance for that. If there's NICE guidelines, if there's a society guidelines, the subjects that is the incident has happened, you need to look into that. You also need to look about how your team function to address the problem. The example I gave you where it is a very tense, if the team is completely fragmented and everyone doesn't really work very well together, there will not be a person to delegate to ask the questions. There will not be a dysfunctional team. You can have the best guidelines available, you can have the best setting, but a non-functioning team is a disaster and a recipe for a mistake to happen next time. Now, obviously, another tip is act on what you've learned. Again, we back again, and I keep repeating, it is not a tick box exercise. If you sit, I said, I reflect, I'll go through the process, I'll write it, I'll document it, I learned. But if you just leave it as it is in your portfolio, what's the point? You've ticked the boxes, but you've not really learned. You really need to learn from it. Actually, I identified a good teamwork need to happen for this, and identified someone need to be asking the right questions. You need to learn from this. If you really have to take effort and making sure how can I learn and what can I change in my practice? What do I do to enable me to successfully insert the cannula the next time I see a child and I put the cannula in the child? And then communicate what you've learned with your colleagues. So it is those colleagues, because people in the same level as you in your department could easily come across the same thing, particularly if the example is something that is common. If the example is, I can't really get a cannula because I'm ST1, I've just gone, I've not really done a cannula in a child before, a lot of people will be exactly in the same position. And if you've identified the common areas as actually the way the equipments are put are really far away, I could help the child, but I have to twist my arm and trying to get a cannula. Maybe if you change the way the trolley is put into your treatment room, that could be a step. If the treatment room is super cold, I can't really see any vein, that is something could be common to everyone. That's not only your own doing of an inability to do that. So there are a number of areas of learning things that could be shared with a wider group and with wider colleagues, and that's extremely helpful. So do share them if you do. And I think that is all what I wanted to say today for you. And we have, I think, about maybe 10-15 minutes for questions. And any of you want to ask something, I'll be more than happy to answer.
Thank you, Dr. Mutalib. That was an impressive talk, really. I enjoyed it. Thank you very much. It's my first time. I'm a trainee already, and I haven't really heard about reflective practice this good before. Now we don't have questions yet, but we have a comment from Ahmed that this is the first time to understand reflection in such a clear way, and she's telling lots of thank you. We have many other thank yous coming in the chat. If any attendee want to ask a question, can unmute themselves and go live. Or write it in the chat box, please.
Can one use the same example as reflective practice and also in the question about clinical governance? Say you use the example of you having made a mistake to talk about ethics and the duty of candor, and then you use the same example to show how you learned and how you reflected on it. Would that be okay?
Yeah, I think it is, remember the important things in all of this. That is, if you are going for an interview, if you are filling an applications form, you're not really talking about a real patient. You're not actively treating something. So it is what you learn from this example in a different settings. So if you use the same example about an incident that has had to, a drug error resulted in a ethics, you are the person who did the drug error, it could have so many areas where you could address. And part of it could be a reflection. You could use it as a strength, meaning that is you've learned a different aspect. You have the same scenario. You've learned the clinical governance from that scenario. You've learned the duty of candor from that scenario. You've learned the reflection that could be used as a strength. The only area where if you use the same example, you might inadvertently keep repeating the same thing. And that could be could be a little bit boring because there's certain terminology you will be using again and again and again. And if that is there might be a small risk for the same example, that is you just exhaust your terminology and you start using the same language and again, and that could be a little bit boring. So if you have more than one example, please diversify that, because that will allow you to bring in something new every time you say something new. If you don't have, and you have one example, use it as a strength, because each step that you discuss will be different from the next step, and it could really highlight how you take the whole cycle from the reflection to duty of candor to the ethics to working with the clinical governance team to closing the case and learning from it. So yes, please do.
We have another question in the chat, but I think answering this when you have gone through it, it's if they ask the candidate about a mistake they made, how to choose one and not sound incompetent.
I think that is that is really easy. Remember, again, I would just remind you that is in the interview, the idea, we're not really trying to trap you. There is no trap here. The idea is really trying to select the right candidate. So no one will be expecting you to come on admission and say, actually, I wrote something that has caused an irreversible brain damage. This is just completely absurd. But you could very easily, drug error is the commonest example people use, and it's completely understood because it happens irrespective of where you work, you will have a drug error. That's not really a reflection about that would happen to you. You could very easily write that I wrote a gentamicin dose that is few times more than what's recommended. I didn't check the renal function before I did it. We have a gentamicin overdose we need to do afterwards. So it could be easily, I think, could be a drug overdose. That's a common one, or a drug error, overdose, drug error. It's really common. How not to sound competent, how not to sound incompetent is really through the process we've talked about earlier. That you could have easily wrote 10 times a gentamicin dose. How to sound incompetent, like, actually, I didn't check. I just remember that gentamicin was 10 milligrams per kilo from my previous job, and I wrote 10 milligrams per kilo. This is an incompetency. This is an absolutely, you're out completely. Whatever you say afterwards, you are just not a person who learns. However, similar, exactly the same example. I wrote gentamicin 10 milligrams per kilo because when I opened the BNF, I saw it, I read it, it was 1.0 milligrams per kilo, and I didn't really see the dot, so I wrote a 10 milligrams per kilo. I recognized that was not right, and I recognized that a mistake. I flagged it. I went to the family and explained to them as part of a duty of candor. I showed it to my registrars. We've taken a gentamicin level, we've held the dose, we booked the child for a hearing test because of possibility of ototoxicity. That's exactly the same example, but the way you've reached doing the drug error in this is very different than the arrogance way of saying, oh, I remember it from my previous jobs, that's what we used to do. Do you see the difference between the two of them? It's exactly the same example. It's something really minor, nothing really happened, but the way you're saying it could entirely make you an arrogant, incompetent person, or the same way it could make you a quite competent person who is in the early stage of their learning, made an honest mistake that you learned from it, and you've put a step in place to prevent it from happening again.
We have another question in the chat. Is it necessary for the incident to be personal, or it could be something happened in the department? I mean to mention it in the interview.
That's Ahmed. Is it possible just to highlight that a little bit more, Ahmed? Do you want to come in the camera, or do you want to just say that what you want to say? Because I'm not really sure I fully understand what you mean by this. Ahmed, you still around?
I mean, hi. Thank
Hello.
you for your nice presentation. It was really helpful. I just mean to say, is it necessary the incident to be like personal, like you are the lead on the incident, or it could be something happened in the department and you were around and you learn something from it?
Yeah, I think they're posed perfectly fine. I think that is, again, you just really need to trying to make something that's, you must have gone through something. Okay? And it doesn't have to be fancy. It doesn't have to be a drug error. Again, I could easily an example of actually, I tried to put a cannula and I couldn't. Okay? I've never had failed a cannula before, and that's my first time ever to fail a cannula. That made me absolutely feel very terrible. This is an incident that you could reflect on and trying to find out why, what happens to you. So that what does make you feel, what are the factors that make you in this particular incident unable to put the cannula, and what the lesson you've learned from, and how would you change your practice next time to make you maximize the chance of putting a cannula. So it's all about what is happened to you as an individual If you don't have any incidents, if you're freshly coming from a program that you've never made any of those and you just want to say something, yes, you can use something that's happened in the department that is you've learned from and that you followed, but you can't have learned from it if you only just read the report. So if you, I know actually the handover, they gave the wrong medication error happened by one of my colleagues. The nurses put a dietetics. We went to the department, we've discussed it, and we've learned from it that will not be a reflection because you're not personally involved in that reflection. So if it's an incident happened in the department, you might want it to highlight it a little bit. You might want to speak to the person who did the drug error, discuss with them what has happened. You might want it to chat to the nurses who filled the dietetics to see exactly what happens. You chat to your governance group to see, chat to the consultant who analyze it. So if you've not personally involved through it, you need to dig a little bit deeper to make yourself aware of all the steps that has happened through the incident. But believe me, you will have had an incident that happened to you. I told you, it could be a very easily from just a cannula, or actually I tried a child coming in with wheeze and I wanted to follow the examination structuredly. And I thought I will first do the abdominal examination, and I realized I made the child very, very upset. By the time I could listen to the chest, the child was crying all the time and inconsolable. I could not listen to the chest. On reflection, maybe I should have listened to the chest first before feeling the abdomen, making the child less distressed. It's straightforward. If you've done pediatrics or if you work, it would have happened to you. Anything minor that could take it around, because what's important is not how serious the incident is, or it's not how big the incident is. It's really about how did you, as a learning pediatrician, what did you do to go through the steps, and how did you complete the cycle of identify a problem, analyze these problems, but identified a plan, implemented this plan, evaluated them, and looked again. I hope that answers you, Ahmed.
Hi, Dr. Mohamed, and thank you for your nice presentation. How to avoid pitfalls on writing a reflection piece and submitting on our e-portfolio? Could you please highlight something on that?
Yeah, I think that's a good question. I think it's I intentionally drifted away and not really talked about it. The pitfall for that is an admission of guilt. Please, please, please do not write an admission of guilt, even if it happens. Okay, if you are directly involved into a mistake, if it is a simple, straightforward reflection, the same as what we've talked about throughout this talk, then you write it, you have nothing to fear. Okay. I think the Babagawa's case has demonstrated a major flaw into how do we deal with things. So if you are directly involved, there will be mistakes. To the best of our ability, mistakes will happen in medicine. If you are the unfortunate one who made the mistakes and simply because it's a mistake, okay, and that is, I'll give you an example. I don't know how many of you work in intensive care. If you put in an outline, if you're trying to put a cannula and you put it in an outline by mistake and the child lost tip of their digit, that's a mistake, right? Because you did not really take enough care to ensure that is a cannula is not in a vein, that cannula is in an artery, particularly in a small neonate that could happen. So if you write down in your reflection, I should have done it better. I had my doubt when I was palpating. I wasn't really 100% sure, but I thought that's a good vein. I've been trying for an hour. We really need the blood. And I just put it. Next time, I will make sure that is, if there is doubt, I will double check it. This is an admission of guilt, and that could very easily taken on you. If that's happened, if you find yourself in that situations and you want to reflect on it because a serious incident happened to it, please make sure that you show that to your senior first before you put in your portfolio, because the language used in this is really important. And your role you've played during the incident and after the incident is also very important, because you can't go and change the incidents. What has happened. But what you could do, you could write it in a way to reflect rather than the admission of guilt. Does that answer your question?
Yes, thank you, definitely.
Yeah.
I think there are no more questions in the chat. And that's perfect timing, Dr. Mutalib.
Thank you very much.
We have all enjoyed the talk, very informative, very impressive. For anybody who have any more questions, please feel free to email them to the email address that occurred in the chat now, and we will forward that to Dr. Mutalib to kindly answer them. Thank you very much, Dr. Mutalib.
Thank you, everyone, and good luck.
Thank you. So continuing our fabulous talks, the next session will be with Dr. Hani Ahmed Gowai. Just two tiny announcements before we go for our next speech about career motivation. This talk, the target audience are mainly ST1 trainees. This will be a station in their interview. ST3 and ST4 are absolutely welcome to attend and to stay. If you feel you want to go for a break, please come back by 1:30 for the rest of the talks. So our next speaker, Dr. Hani Ahmed Gowai, will take us through 45 minutes speaking about career motivation. Dr. Hani Ahmed Gowai is a pediatric registrar trainee, ST7 level at South Yorkshire Deanery. He is currently working in Sheffield Children's Hospital. Dr. Hani Gowai is a graduate from University of Jazeera in Sudan. He started his training in Sudan, then moved to Saudi Arabia before coming to the UK to pursue the rest of his training and career. Dr. Hani has many contributions to helping loads of trainees to smash their interviews, and I'm speaking from a personal experience. Quite sure this will be a very lovely and fabulous talk. And for next 45 minutes, Dr. Hani, the floor is yours. Thank you.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you, Buran, for the introduction, the kind introduction. Is my voice well heard?
Yes.
And the slides are visible?
Yes.
Great. Congratulations to all those who have been shortlisted for the interview, and hard luck for those who haven't, but good luck for the next round, hopefully. The competition this year was really tight just because of the number of people who applied. They said in their report that the numbers this year were unexpected. So they had to raise the bar a little bit. That resulted in good candidates not being selected just because they missed it probably with 1 mark or 2 marks or something like that. But don't make that let you down. Prepare for the next round and go for it. So the career motivation question is one of the stations that you will be doing as an ST1 applicant. And this talk is not going to be based on the slides, on what you see on the slides. There will be only bullet points, most of the slides. I'm going to make an emphasis on the bullet points by talking more rather than, depending on explaining it in text. And I would like people to contribute. I would like to answer questions as I go through. So if there are any questions in the chat, please stop me. Or if you want to raise your hand and ask a question while I'm talking, that's perfectly fine. Just do that. And Boran can kindly help with that because can keep an eye on it. So the career motivation question is really, as you can see on the left corner, left upper corner of the screen, is about why do you want this job? It's really that question. And it's a crucial thing that most of us, talking mainly about my experience, we're not good at selling ourselves. We're not good at saying, I am good, can you please hire me? Or I'm good, can you please give me this job? We're not really good at that. And it's all about this, plus the other factors of having English language as your second language, not your mother tongue. This can also influence the way we sell ourselves, the way we present ourselves. So there are lots of factors that can play into this, including your previous experience, including your background. Are you applying from the inside the UK? Are you currently working in the system and you know it? Are you working from outside the UK and you don't know the system? A lot of factors are playing into this, but you can still smash it, you can still have it. So, did the slide move or not?
Slide, we are still in the, yeah, now moving, yeah.
So this is not to provide you with perfect answers. As I said, there are no perfect answers of why you want to do a job, because everyone has got their own answer of why they want to do pediatrics and why they want to join from this level. So this is a completely personal question on how you go around and answer it. So there will be no perfect answers. You can look into books talking about interview preparation, and they will be providing some examples of how to do it. These examples are merely to provide you with a structure and a framework of how you can go around and answer that question. And I will talk about what kind of questions that can come. But it's not about memorizing an answer. Memorizing it will just make you feel like a mechanical person talking. It's about expressing who you are and why you want this job. This presentation is about just giving you ideas to explain and say how you can formulate excellent answers. And I say again, it's about you. It's not about anyone else. So make it personal. And the interview is the hurdle that is now stopping you from getting that job, which could be your dream. Getting that job. I have been through a few interviews myself. I know how it feels. I've been lucky in having the face-to-face interviews when I joined training here, but I have also recently done the virtual ones for the grid, and I know how it feels, you know, sitting in front of a screen, and people are asking you questions about your future career and who can, and this interview can shape your future. Can you imagine that? So these rocks are stopping you, but they will not stop you if you know how to go around them. There is no obstacle that cannot be solved, and there's no obstacle that cannot be bypassed. It's just knowing how to do it and what to do. So if you have worked in pediatrics, I like this a cartoon that I found somewhere in Twitter, so I opted to use it in this presentation. It's just a perfect example of what we look like when we are doing on-calls or when we are in hospital. And anyone who worked in pediatrics will know most of these things. This is the focus of your career motivation. These arrows that are pointing towards different aspects of this pediatrician trainee life. If you can tailor your answer around any of these aspects, then you will have a perfect answer. Obviously, it has to be personal. Again, as I said, I keep saying this every time throughout this presentation, it is personal. So, you know, being busy during on-calls, having, you know, using the bubbles to help children settle down while you're doing things, your bleep is running off all the time, calculating doses using your smartphone or using a calculator, having the stickers to say to the child, I have been brave today in the assessment unit because I had my cannula done. You know, things like that, having a very small stethoscope, listening to a 500-gram baby is completely different than listening to a 15-year-old child also chest. So these variations and these things that constitute your life as a pediatrician or as a pediatric doctor or as a pediatric trainee are the things that you need to focus your talk about when you are talking career motivation. And we'll see how we can do that in the coming few slides. I would like people now on the screen, please get on your phones or your laptops, and can you please write in the chat about why do you want to do pediatrics, and make that, give me 3 reasons. Every reason should be only 3 to 4 words maximum. I'll sit silent for a minute or two to give you a chance to do that, and then we'll move from there. Please do that now. Great, things are coming out. Fun workplace, challenging, rewarding. Yes, yes. Keep going. Teamwork, different in the pediatric field, good outcome, full of puzzles in addition to straightforward cases. Yes. It is a section of pediatric that I enjoy the most, myself in. Enjoy working with children. Yes, perfectly good. Dealing with different age groups. Children never lie. I love that. Although you will get to learn that they can lie sometimes. Any more answers coming? Yes. Affect the whole family and the future of children. Definitely. Definitely. It's not just about the child. Okay, I think people have contributed. Excuse me. Let's move on to the next section. I have written this. I want to do pediatrics because I'm good at cannulation. I enjoy working in pediatrics. I don't like other specialties. It is easy to find a job when I finish training. Someone told me I'm good at treating kids. I don't mind being peed on or pooped on. I tolerate crying and crying kids, and I like playing with patients. Can you please also write in the chat, or if you want to voice it out, that's fine, what people think of these reasons as motivating reasons to do pediatrics. Feel free to write in the chat. We'll give another minute, or if you want to put on your mic, unmute and say it, also fine.
Maybe they are not enough to make you committed to pediatrics.
Okay.
For example, I like playing with patients. You can be a play therapist, for example. Necessary pediatrician.
Yeah. Good. Thank you.
Good
Mohamed.
at cannulation. You can do a lot of other specialties also.
Thank you, Mohamed. That's a good thought. Nusrat said very personal and specific. Any other thoughts about these reasons to join pediatrics?
Someone told me about I am a good in treating kids. It's not about someone who told you. You have to believe on yourself that you are a good pediatrician.
Thank you, Tawreed. That's right. As Zubair said, they seem general, they don't seem passionate. Okay.
I don't mind being beat.
I don't mind being beat on. Yeah, I like that one also. It's okay for me. I think as each one has own beliefs and thoughts. Good, Jihan. Jihan has an opinion on that. Okay. So as you can see, different people have different views about what is on the screen now. These reasons might look personal on the surface because they are about someone who's written them. But if you go deeper a little bit, for someone who wants to do this for their lifetime, is it really good to say, someone told me I'm good at treating kids? If you don't know if you are good at something, then you are not going to sell yourself in the way that that makes people choose you for that job or for that purpose. I'm good at cannulation. Okay, fine. But does that make you a good pediatrician? That's the question. I enjoy working in pediatrics, a completely valid one. We just need to elaborate on that and say how you enjoy working in pediatrics and why you enjoy working in pediatrics. I don't like other specialties. This is a complete no-no. Don't ever underestimate the value or what other specialties are doing. You don't like them, that is fine, but that is not a reason to join pediatrics. Pediatrics is not for someone who chose a specialty by exclusion of other specialties. It's completely different specialty, is a unique one. If you just said, I hate surgery, I hate scalpels, I hate geriatrics, and I hate ENT, what's left for me is only pediatrics. Don't come and do pediatrics. You're not going to be good at that, because that is not a good enough reason to do it. It is easy to find a job when I finish training. That might be, by the way, a genuine reason. It's just about how you phrase it and how you say it. Because looking at the future of the specialty itself is something that we should be paying attention to. If you want to do subspecialize in infertility, you know, or something very niche, then are you really aware of the future prospects of jobs in that specialty? And are you happy to take the risk and do that? But it's just about, again, how you say, as I said, someone told me I'm good at training kids is not good to mention. I don't mind being peed on, pooped on. That is something to joke about in pediatrics that, you know, I mean, most of us who have got a decent experience in pediatrics, they must have had this before, either being vomited on, you know, peed on, pooped on, or something like that. It's part of the job. But is that a reason for you to want to do pediatrics? I wouldn't say so. I tolerate crying. No, that's not good enough. It seems personal because, you know, yes, there will be a lot of crying while you are doing the ward round. There'll be a lot of crying when you are touching an infant or touching a toddler that, you know, is afraid of strangers. But that's not going to make the panel choose you as a good candidate for a pediatric post. I like playing with patients. Yeah, this is something unique we do in pediatrics. It is unusual in adult practice to see a consultant or a registrar or an SHO sitting on the floor in the middle of the ward, playing with bubbles or playing, you know, with a ball or playing with whatever, a bear, teddy bear, with a child and their parents. This is a common scene that we see every day on our wards and our acute assessment units. And we've got play specialists who are doing that. But I will put that in the middle of me talking about myself as part of me liking the job in pediatrics and enjoying it and all that. But it by itself will not constitute a reason for them to choose you for the job in pediatrics. It should be part of your passion, part of why you like pediatrics, and part of the other things that we need to talk about in the coming few slides. Okay. If there's anything in the chat that I'm missing, just let me know. The Royal College on their website have got some pages that they interviewed some trainees, they interviewed some consultants to talk about why should people join pediatrics. And this was mainly targeted for foundation doctors or medical students who are still about to graduate, to motivate them and give them the taste of why pediatrics and how pediatrics is, to get them into the specialty. As you know, we're losing a lot of doctors from pediatrics. This is not something to hide. There is a lot of dropout from the training and all that for different reasons. So those trainees, I encourage all of you to go onto the RCPCH website, have a look at why it comes under why choose pediatrics. So if you Google why choose pediatrics RCPCH, this will come as your first results, and then you can go through them. The statements written on those answers can help you formulate your own personal answers using the words here, because there are certain buzzwords that if you use, it can make you look better and can make you look a better candidate for the job. For example, the bottom one, many of the changes have happened within training as a result of training, of trainees coming up with good ideas, supported by senior colleagues. That is clearly, you can just phrase that and say, part of the reasons I'm joining pediatrics, because I know it's a very supportive specialty, and the Royal College of Pediatrics is supporting trainees and taking their views into account when they are making changes to training, and when that gives them the idea that you know what is happening in pediatrics in the UK, you know how the college is running the programs and how they are taking into account the views of other trainees. Another example for this is this. These are other trainees also who have given their feedback. The joy and happiness these children bring to their families make it possible for me to work in such a demanding and intense environment. Because part of you talking about yourself, you can't just say pediatrics is the best specialty in the world. You have to say that I know it's a demanding specialty. I know workload can be high at some times, but I'm ready to take that into, and I'm ready to step and face this challenge as, you know, the other things in the specialty that make you continue working, you know, the support, the teamwork, spirits, how people work as a family in a pediatric hospital is a reason that made you choose pediatrics as part of the other reasons that you will mention. And it's clearly mentioned in the bottom one, which says, in this specialty, you are never alone, and that is true. You are never alone as a trainee or even as a specialty doctor if you are not in training, because they're not expecting you to work as a Superman or a Superwoman, a one-man show. It's a teamwork. People are really friendly. You know, you will find every now and then the odd examples of tough or rude people, but these are not the common thing. So these are examples. So you can talk about also that you chose pediatrics because you have seen examples of pediatricians that have made you look at them as role models and you want to be one of them. What questions can come in this station? The questions in this station can come in different ways. The commonest one is why pediatrics, or why did you want to do pediatrics, or why do you want to do pediatrics? Other questions, which can also be, you know, running in the same kind of theme, is tell us about yourself, talk us through your CV, what are the characteristics of a good pediatrician and how is that reflected on you? What are you most proud of in your career / life? What is your biggest achievement? As Dr. Simon mentioned earlier, that they are not expecting you at the level of ST1 to have any previous pediatric experience, but I'm aware that some of you already have it. If you have it, or if you don't have it, you have something to talk about in your career. If you have spent all of your previous career, you know, let's say in ENT or obstetrics and gynecology, and you wanted to do pediatrics, there are things that you have done in the other specialty. There are things that you have done in obstetrics and gynecology or ENT or pediatric surgery that you can transfer and use them as transferable skills in pediatrics. So being able to put IV lines is something that you will use wherever you go in medicine, right? If you're doing adults, if you're doing pediatrics, if you're doing anything, having good communication skills is something that you will need if you are doing pediatrics, of course, definitely, but you will also need it if you're doing any other specialty. You know, if you're doing acute medicine, if you're doing cardiology, if you're doing any other specialty, you will still need to be a good communicator. So when they ask you why pediatrics, you need to show that you know why pediatrics is unique from other specialties. And you can find about this also on the Royal College website, and they have a lot of YouTube. I can't run through everything that makes pediatrics unique in this presentation because of time limit. But we know pediatrics is different. And if you know why pediatrics is different, you are the right candidate for the job, I'll tell you. Pediatrics is different because adults are all adults. They're all alike, you know, in generally speaking. But taking history and examining a 1 month old is absolutely different than taking history and examining at 6 years old. A completely different one again from talking to a 15-year-old. So because children change with their developmental stages, their physiology and pathophysiology also change. And this is a real challenge in pediatrics, because most of the things that parents come with to hospital or interpret as abnormal are actually normal developmental stuff that kids go through. So you knowing this, that pediatrics is unique because of the continuous developmental progression of the children, and that this is the challenge for you to know what is normal actually before you jump on and know what's abnormal. And that's why you chose pediatrics. That is a very nice reason for you to mention. When they say, tell us about yourself or talk us through your CV, they don't literally want you to say, I graduated from the University of Jazeera in 2000 so, and I started my internship. I did 3 months of obstetrics and gynecology in Medani Teaching Hospital, and then I did 6 months of adult cardiology in this hospital, and then I went on and did this, and then I went on and did this. This is, they don't know, they don't want to know this. They want to know that you have had a minimum experience of clinical work, because you must have done your foundation at least, or internship, and that from that work you have gained some skills that make you suitable for pediatrics. And you have to always link everything to yourself. Everything you mention, you have to link it to yourself. You can't just be talking generic stuff. So then the next question is about what are the characteristics of a good pediatrician and how is that reflected in you? This and the previous question, which is talk us through your CV, you can link them together. So when they ask you what are the characteristics of a good pediatrician, they are asking actually, what are your own good characteristics that make you a good pediatrician? And if you know what a pediatrician should be like or what should do, then you will know how to make it personal and reflect it on yourself. So for example, a pediatrician is someone who treats children, of course, of different ages and adolescents, and have the ability to apply holistic approach and holistic care to the care of the children, sick children and adolescents and young persons. This, if you are talking about yourself, I myself have been described by my colleagues as someone who has got a holistic approach, and this is reflected in my MSF. MSF, for people who are working outside this country, they don't know what is MSF so far, but it is the opinion of your colleagues about you, which is written, and it's part of the training that you will do here. But you can say that I have received feedback from my consultants, I have received feedback from my colleagues that my approach to patient problems is not just fixated on the disease or the problem they are presenting. I am actually looking at the wider picture, including the family, in the decisions I'm making for the treatment of this child, acknowledging that this child is going to go back into the community. So I need to get this family ready to continue treating this child in the community by giving them proper safety net advice and everything, taking into account the family circumstances and everything. So these kind of answers shows that you really know what is pediatrics and you know what pediatrics is about, and you have actually done it before. If you give an example, that will even make you stand out. So if you say, oh, I had a child who used to come in with recurrent attacks of asthma, and I noticed that while working in acute units that this child attendance is really frequent. So I went the extra mile and took further history from this family when they presented in one of their attendances. And it turned out that actually this family lives in a very old home, and that father is a smoker. So before discharging this child, I took the chance and spoke to the asthma nurse who came and spoke to parents and gave them leaflets about asthma. I spoke to father and gave advice about smoking cessation and all that. Don't run into details, more details about this. It's just to show that you just didn't give this child salbutamol and told them to go home. You give them salbutamol and steroids and say, go home, and then they will come next week again. You have looked into the bigger picture of the child, which is, why is this child coming every time? And you try to solve it. And that is what we want from you when you come into pediatrics. So when they ask you what are the characteristics of a good pediatrician, you mention the characteristic and you say that I have it, and this is how I can show you that I have it. And then you go to the next one, and then you go to the next one. And again, I'll say, go back to the Royal College website, which actually really talks about what pediatricians should be like and what pediatricians should do. Questions like, what are you most proud of in your career or life? This question doesn't have to be about medicine, by the way. It can be anything that you have done in your life that makes you a good person, that someone has good potential, that when you come to the team, you're bringing good things with you. So for example, if you are part of a non-governmental organization or a charity, and you're doing work outside hospital to help people, to help children, to raise funds for good reasons and for good cause, that is good. That is someone that I want to work with. That is someone I want to be part of a team in, because it's your personality outside hospital will also impact on how you work inside hospital with children. And so they're not just looking for someone, who can put in cannulas, who is a good communicator, or who knows that they have done a mistake and they can reflect on that. They also want people who have other things in life to do. Because if you only work in hospital and go back home, you can't do this job for longer. You'll do 2-3 years and then you will have burnout and you leave the job. So you need to have other things that you are doing outside that shows that you have got, you can vent yourself out, and you can actually show that you have a wider picture of life rather than just, carrying your stethoscope, listening, putting cannulas and prescriptions. Questions about what's your biggest achievement is similar to the previous one. What are you most proud of in your career? And it can be anything that you have done, or a prize that you have had, or something that happened in your life that people have commended you on and said that you are good in this. The panel need to know about that, because that could be your most, the highest selling point for you. So if you've got achievement, say it. If you don't have one, like a clear one, try and look into your CV and find one. I'm sure each one of us have had something to be proud of. And as I said, it doesn't have to be clinical. It doesn't have to be in medicine. It can be anything that you have done that you think has made a difference to people or to other people. So I'm just going to leave that here, and we can come back to it if we have time. Just a reminder that the panel, they don't know you. They only know you when you start, your camera and you start your screen on, and then they know your face, and they know your name, of course. But they don't know anything about your past history, your previous CV. They have not looked at your application. They don't know what you have written in your application. So what you say is what they are going to score you on. So these 30 minutes are crucial in deciding whether you're getting a job in pediatrics or not, at least this year. Make use of it. You have got a lot of things to say probably about yourself. Concentrate. Summarize the biggest moments in your life and the biggest achievements in your life that can make you look a good candidate for the post, make you look like a good doctor, but also make you look like a good person. And this is your chance to shine. So use it wisely, and you'll get it. You'll get it. What is the panel looking for when they are interviewing you? They are looking for enthusiasm and passion. You can't just be sitting like this and say, I have done pediatrics for the last 4 years, and I have worked with children from different ages, and I really like working with kids. I have got a lot of skills. I have communication skills. You not get the job, because your tone is so monotonous and so flat that there is nothing that tells the panel that you really want this job. You need to do it. You sit like that and say, oh, you know what? I have always been passionate about pediatrics. I wanted to do pediatrics since I was a medical student. And once I started my career and started doing my internship, that passion and that desire has actually consolidated. I now know that I want to spend the rest of my life doing pediatrics, and these are the reasons. See, the way you talk and you come to the screen and use your hands and everything, of course, in a face-to-face interview, this you can show this better, but we just have to deal with what we have now. On the screen, you have to put more effort in showing your passion and your enthusiasm. They need to see motivation and ambition. You can't just be someone who has just been doing the job and going in and out without any other, involvement in work in pediatrics. So getting involved in other management experiences, quality improvement projects. You have got a plan. I would like to do a master's in medical education at some point during my career because I'm really passionate about teaching. And I have been involved in teaching before and so on. So they need to know that you have a plan in your life. You know what you are doing. You have potential. When I say potential, that means you have got things in you that when you go into training, your trainers can take that and build upon and make you a better person and a better clinician. Potential means you have the basic things that is needed from you to do this job, and then you can build on it and be better and better and better every day. They're looking for personal attributes and experience, as I said. Don't mention other people's experiences. This interview is about you. It's not about anyone else. Talk about yourself. Talk better. Talk better. Talk better. Give examples, and examples. Even if those examples are not from pediatrics, even if you have worked, as I said, in other specialties, they are still valid to be used as transferable in pediatrics. Even if you are not working at the moment because you are in a break, in a career break, because of maternity or because of health reasons or because of anything, and you just decided to come back and do pediatrics, that's fine. People have lives outside hospitals and things can happen to them. But use whatever you had in your past, before your current state, and make it stand out and make it about yourself. I just found myself talking a lot now. Is there any questions in the chat that I missed? Anyone wants to ask any question at the time, or I've got 2 more slides and then we can maybe make it more interactive.
No questions so far in the chat. Hani, it seems you are hitting all the boxes and answering all the questions already.
Great. How much time do we have?
We have 10 more minutes and then we have 10 minutes for questions.
Oh, brilliant. We spoke about what the panel wants from you. What they don't want to hear from you or see from you is generic answers, no personalization. So part of the reasons I gave earlier for wanting to do pediatrics is pediatrics is a really great specialty that everyone wants to do, and I would like to be part of that. That's not good, because we know pediatrics is good. People who are interviewing you are consultants, so they know pediatrics is good because they chose it. They want to know, why is it good for you? Why did you choose it? Why, on the personal level, you want to do pediatrics? It's not just that pediatrics is a good specialty and I like it, and I love it, and I love playing with kids and all that. Yes, you can add these personal things, but make it genuine, make it with passion, make it with enthusiasm, and make it with a smile. They don't want answers that feel mechanical, where there's no passion about it. I keep saying passion. When I say that, because some people may try and prepare answers, which is good and fine to prepare answers, but don't memorize your answers. It will make you look like a recorder. It will make you look like a robot. Don't memorize it word by word. Memorize the heart of it, the essence of what you are writing. So you can talk about it in different ways every time. If I ask you the same question now, and then half an hour I ask you the same question again, you should give me different answers. not different answers in the content. The content will be the same, but the way you expressed it should be different, because you just can't memorize it. That's not good in these situations of interview. If you memorize them, they will think that you've just done them for the purpose of the interview, rather than this is exactly what you feel and what you are doing on everyday life. They will not look real. What they want in the interview is your real self, not an invented one. So make yourself real. If you showed no enthusiasm, if you've given no examples, this will just make your interview look very plain and very monotonous, and they will lose interest in you soon. People in the interview will be sitting with you half an hour. As you heard Simon earlier, he said they are interviewing 650 people this year. That's a big number. So people on the interview panel will be bored if you don't make them if you don't attract them to what you are saying, if you don't make it personal, if you don't show them passion, and then they might just say, you know what, let me just listen to this guy or listen to this lady. Sounds like a good candidate, and I might want them actually to work with me in my hospital. So think of that. Think of it for all the answers in different domains, but mainly the domain of career motivation. Classically, people will tell you to talk about career motivation questions in 4 points. If they ask you to go through your CV, as I mentioned earlier, they are not looking for merely, the number of jobs you have done, and I've done this job and this job and this job. No, they want to know what you have learned from each job that makes you a good candidate for the post. Sounds easy to say. So that's why people have made these points to make it easier for you to talk about. Talk about your personal reasons and attributes that made you want to do pediatrics. As I said, you found yourself, you were passionate about pediatrics before you graduated, but after you graduated and you started working in pediatrics, you have actually liked it more and more. It satisfies your personality because you are a person who likes working with kids, because you are a person who likes working with teams, and pediatric is all about teamwork, and that pediatric work as a family together and all that. So make it personal, and then talk about these reasons in 1 minute or so. The clinical experience and learning, then mention it later after this, and then you can talk about how many. You can just say I graduated and then I finished my internship. And during my internship, I have done this post. If there is a special post that you have done that made you stand out and will make you look good in this post, then you have to say it. Say, for example, you've done your internship and then you did a pediatric post in a tertiary hospital where you have seen how the multidisciplinary team works, and you have gained experience in communicating with different specialties, with different healthcare professionals that are all working towards one goal, which is, the holistic care of a child and their family. So, and what you have learned from that. I learned that good communication is important. I myself am a good communicator because my consultants said I'm a good communicator. And there is an example that I have spoken to a family and did this and this and this. So the next point will be about research and academic. If you have done research, not all of us, very few of us have done research, but if you have done anything related to academics, presented in conferences, you have a publication that you have done, at this level, they are not expecting really much from that, but if you have it, then it makes you stand out, and I'm sure they will love it. And then lastly, speak about your management and QIP, which is quality improvement projects. If you have done audits, if you have done, people working overseas think that they don't know audit, or they haven't done audit. You have done it, I'm sure, but you don't know you have done it. You have helped, devise a new admission pro forma in your hospital. You have helped change a guideline. You have helped stream the way patients go in and out from a clinic. You have helped how to book patients in a certain service, or how to minimize their waiting time and all that. These are all management and quality improvement projects that will make you stand out. And if you have been working, as a medical director previously in a hospital, or you have worked in a single doctor hospital or something like that, that is a significant point that you need to mention. Is it time, Burhan?
Yeah, 3 minutes remaining, and we have a few interesting questions in the chat box.
Great, I'm about to finish. How to make your answer effective. I keep saying this, and I will keep saying it to the end of my life. Personalize it. Personalize your answers. Make it yours. It's not about someone else. It's about you. Show your passion and enthusiasm. Use a structure. The only reason we say use a structure, it makes it easy for you to remember how to do things. So, I have spoken about my personal things. I need to talk about my experience now. I need to talk about my quality improvement projects, and then I will mention my management experience. You will not forget. A structure is helpful in making you not forget, and will also make it easier for the panelists and your interviewers to pick points and score you on while you are talking, because they will be scoring you while you are talking. Give examples, spoke about that plenty. Use transferable skills. As I said, if you've done everything before in other specialties and you just decided to do pediatrics now, just use what you have done in those jobs and bring it back into how you are going to use it in pediatrics and how it is going to make you a good pediatric candidate. Smile, smile, smile. Interview is a serious, scary thing for most of us. You have to take it seriously, but also keep smiling, because this will engage. Simon mentioned this earlier. This will engage your interviewers, and they will give them the idea that you are not really stressed. They know that there is a degree of stress because you are in an interview, but they want to see that you are loving to talk to them, because they are pediatricians like you, and you want to be like them. So believe in yourself. You can do it. Keep smiling. Make it personal. Mention the examples that you have, and you can do it. There is a book that is recommended by most people in this country that you can read about. It just prepares you generically for interview and tells you how to answer different questions. As I said, it gives different examples and it gives you different structures. You have to take that and make it yours. So don't memorize the answers inside. No, make your own answers, but apply the structure in the book and apply the structure that we have spoken about. And I'll see you probably with me in Sheffield next year for the job. I'm done, hopefully in time.
Hani, can you see the chat box, or do you want me to read for you the questions?
I'm just about to open that now. Okay. How can we answer the question about our weaknesses? Yes. This is similar to what Dr. Mutalib mentioned earlier about a mistake that you have done and things like that. Choosing a weakness is something that we are not good at. But you have, this question specifically, you have to be prepared for. I'll have to say that now. You have to choose a weakness from now and say how you are going to phrase it and say it. Different people have different weaknesses. The book mentions a number of them, like, having difficulty taking breaks because you just get yourself immersed in work, and sometimes you just forget to take breaks, which is not good for your health and is not good for your but when they say weaknesses, they don't just want to hear the weakness. They want to say, yes, I am having difficulty taking breaks, but I have been notified many times by my colleagues that I need to take breaks, and I noticed that this is something that I need to work on. I started, using prompts for myself. I used alarms in my phone to remind me that this is the time to take break, and I started getting better at this, which has actually improved my concentration during on-calls and made me feel less exhausted, things like that. So they don't want the weakness only, they want the weakness what you have done about it, how are you getting on now? So you can choose different weaknesses, like as I said, this one, having breaks. Some people talk about the inability to say no. So anyone will give you any job and you can just take it because you haven't learned how to say no. Sometimes you have got enough in your plate and you don't want to take more, otherwise you might not be able to achieve everything that you are asked to do. So having the ability to say no is also something that we learn through our career. So have a look and decide what kind of weakness you want. Don't say I'm bad at communication. That is absolutely no. You shouldn't be saying things that can be taken against you. Don't say I'm bad at time management, because they expect you to be at least, have the basic things of arranging your time and things like that. You can say that in a different way and phrase it. For the purpose of time, I'm just unable to elaborate more probably, but I'm happy to take questions individually and answer them. The next question from Ahmed is, can we give a story happen that makes me to be a pediatrician, and can we tell the same story mentioned in the application? Absolutely, yes. And that is what they like. They like stories. They love stories. What they want you to do in the career motivation question is to use what you have written in your application. Just make it a bit more live and personal, as I said. Show passion and enthusiasm. So instead of them reading it on your application, they are now listening to you talking about it. Yes, use your application form. Use what you have written there, because they haven't read your application. And stories are always good, but just be careful, because stories you can get carried and then suddenly find yourself, the story has consumed half or more of half of your time, and you haven't had the chance to talk about the other things that you are good at and that makes you a good candidate. So yes, stories, make it concise, what you have learned, why does it make you a suitable candidate? How to tell about a role model as a motivation to be a pediatrician. Yes, you can say, because you are passionate about pediatrics, you have actively sought to get a post in pediatrics, which you have successfully had. So you are working in pediatrics now. And while working, you have been lucky enough to work with a brilliant, fabulous team. One of the members, or some of the members of the team, have actually really motivated you and made you feel that this is the job you want to do, because they are very friendly, they are communicating good with patients, you have learned a lot from them, they are very good teachers, they are keen on you getting better and moving forward. So they are giving you all the reasons from a good leader that they want you to be better, they want you to be like them. So you are looking at them and say, these are the examples of good pediatricians that I want to be like, because they tick all the boxes. They are good personally, they are good clinically, they care about their trainees, they care about their colleagues, they care about their patients, and I just feel like this is what I want to do in future. And you can also answer that in the question when they ask you, what are the characteristics of a good pediatrician? You can say, you know what, I have once worked with a consultant that has actually motivated me to do pediatrics, because I think he had everything in him that a pediatrician should be like. So now you're talking about the question, you're answering the question, but you're answering it about a person that you have actually seen in your life. That is really good, because that gives them the sense that you're not just talking generic, you're not talking from a textbook, you're talking from your real life, that you have seen someone who is good and has shown you that what a pediatrician should be like, and then talk about their characteristics, as I mentioned, why they are good, and how that reflects in you. You started learning how to be like them, you started learning how to teach other people, you started learning how to be a good team member, how to be there for your team, how to support your colleagues, how to a lot of things that you have learned from that idol or from that role model that will make you a good candidate for the post. That's really good. If you do that, I'm sure they will like it and you will score high on this station. If anyone wants to ask a question in person, that's fine. If you want to unmute yourself or raise hand or anything, I'm happy to do that.
Assalamu alaikum. Can I ask a question?
Absolutely.
Yeah, I just wanted to ask, when I was approaching a few people to ask about the fact that I have experience in pediatrics, and my major reason for joining pediatrics in the UK is actually to get pediatric neurology. They said maybe don't mention that, just talk about general pediatrics. I don't know what you feel about that, saying that my ultimate goal is doing pediatric neurology, and what do you think about that? Is it too far-fetched?
I love it. And I say, definitely mention it. For one reason, these people, as I said in one of the earliest slides, are looking for potential and they want someone who has got ambition. You have got the ambition because you know what you want from pediatrics. Yes, you love pediatrics and you will mention the other reasons that you love pediatrics, but on a personal level, you have worked for a certain time in pediatric neurology, and this is what you want to do for your future. I would like, yes, I love pediatrics, but I would like, and I can see myself in 10 years' time working as a pediatric neurologist in a tertiary center here in the UK, because I'm passionate about neurological problems in pediatrics. And I have had some experience in that, and this is what I would like to do for my future. They will love that because you are someone who not just wants to do pediatrics, but you know what you want to do in pediatrics. You want neurology, which is completely fine. It gives you an extra score, I will say, on top of other people because it shows ambition. You have got a goal for your future. You are very focused. Do it. That's good. But don't make it sound like that is the only reason you want to do pediatrics. It is one of the reasons, yes.
Okay, okay. Shukran.
No problem. Any other questions?
Sorry, I have another question.
Yeah, go for it.
If you, when you talked about like doing charity work, and is it going to be a problem if most of what you do in terms of charity is out of the UK? Let's say you help with medical students teaching, but in your home country, you contribute to a charity and you're on the board of some non-governmental organization, but in your country, does it mean that you're then not suited for a UK job? What would your comments be on that?
That's not true. That actually, gives you an extra point on people applying from inside here, because you are bringing to the country the experience of an overseas doctor that people applying from here, or people who have been raised and born and raised here and graduated from here, they don't have. So beside being a good doctor, you're bringing things from outside that they don't have. The idea, the fact that you have actually been shortlisted, okay, that means you are good enough to get to this point. Secondly, they know that they are interviewing people from overseas because they know how many people, how many applications they had and all that. Most of the people on this, on the moderators and all these people are actually came from overseas and they interviewed here, and they have all got the jobs. Doing things overseas will not underscore you. It will actually probably give you better scores if you say it in a way that, I have done this overseas, but this will also help me when I come to the UK because I had the experience of management in a non-governmental organization. I have worked in a charity. I help patients. I know how these things are done. And I think I will bring this to pediatrics and I will continue to do this in the UK also. So absolutely mention it.
Our time is over. That was an incredible, impressive talk, Hani. all the tips and tricks you have given. I'm quite sure they are all indispensable and invaluable for all the trainees. Just follow what Hani said and you will rock it. Everyone, we are going now for a break, and we expect you to be back here at 1:30 for a couple of more great talks, hopefully. Thank you very much. Thank you, Hani, and see you all later at 1:30.
Thank you, Bora. Thank you.
Thank you.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله تعالى وبركاته. This is Dr. Ali. I'm happy to meet you today to introduce you to our website www.bsapch.co.uk. It's not a new website, it's been there for a while. However, this is just a promotional video, just asking you to browse different pages and sections of these websites and contact us in the contact form attached. So let's go and have a look at the website, and in the home page which we are in, you see a promotional video, and then usually we put our next upcoming event in the home page. So here our next upcoming event is tomorrow, and it's the second workshop for pediatric training interviews. So in the left side you see that there is the poster, and the right side the full program of the day. One of our recent events as well is Med Talk series, and then we have an activity calendar, and we have the look at our previous activities and events, as well the BSAPCH event calendar, which is an interactive calendar in which you find important childhood days, linked to our poster for raising awareness about these days, and a link to website as well. And this is for example like ADHD days and other days. Here we have follow us to follow our social media outlets: Facebook, Twitter, YouTube, Instagram, LinkedIn. So for example, if you click on YouTube, it's going directly take you to our BSAPCH YouTube page, and as well if you link in the Facebook, it's going to take you to the BSAPCH home page for the association. So we'll go back to our home page, and then we'll go back at the top. So different other sections, other pages, news and activities, our competition, become a member, archives and accounts. News and activities has different subsection. In the main news and activities page, there is again the recent events and recent news, and here as well is one of our upcoming activities is an audit and QIP for junior doctors. So a promotional poster about it, and a few information, and even the Zoom registration link. If you click on that, it's going to take you to the registration page, so you can directly register to that event. So we go back to our website here, and as well reflective practice and much more of our previous lectures and activities. So we'll go back to the top, and in these news and activities there are subsections like pediatric emergency series, Med Talk, webinar and workshop, launching event, e-portfolio training, children COVID awareness day. So I'll have a look at one of these sections, e-portfolio training. So this is by Dr. Hani, who has fantastic collection of videos for advice regarding e-portfolio. So all of the different domains. Here is an art competition, which is an annual competition for children, open for all children to participate. So last year we had on the 27th of February the participation of the children. So if you look, you will see all the beautiful drawings, absolutely beautiful drawings by the children. And we choose a winner as well. So if you click in, you will see the gallery and all the drawing that was participated in. So nice drawings, very nice and beautiful for so many of them. So have a look at all of these. Okay, we'll go back to the top, and here you can apply for membership to the association. So when you click on become a member, you have the membership page. So you put your information, the email address, title, etc., everything. And when you submit this form, we are going to get your application form for the association, as well as you are going to be subscribed to our news letters and emails, in which we send promotional posters, and we send links for Zoom and Zoom instruction for the events, and lots of other things. There is an important part in here. These three things here. You need to click the email, direct email, customize online advertising, especially the email and direct mail, because otherwise if you don't click on this, you are not going to give us a permission to send you emails, and you are not going to be a subscriber to our newsletters and emails. So lots of the members, they are sometimes saying that they are not getting emails, and one of the reason is that's because either they're opted out in here or they have unsubscribed from our email newsletter. So please, when you are applying for membership, don't forget to click on that. At the archive page for the archives for the previous events and launching events as for the association, and this is the first executive committee for the association in the year 2003, some of the meetings as well, so you'll find that. Account page is for members account, so when you are a member you can create an account in the web page and you'll find it. And last thing, as I said, is the contact us form. So we are waiting for your suggestions and for your queries. If you have any query or any suggestion, just write us in, fill this contact form. So you write your name, you write your email address, and then so you have you write the subject and the message, and then you submit that form, and we are going to get your query and we'll get back to you. So thank you very much for joining me in the tour on this website. Please have a look yourself and give us your suggestions. Thank you for watching again. Thank you.
الشوق عيال كلك ذوق مر رسالة الشوق عيال كلك ذوق مر رسالة الشوق يا كلك ذوق عغش الحبان في كل مكان طوف بالحبان في كل مكان قول ليهم شفنا جبل مرة وعشنا اللحظات حب ومسرة قول ليهم شفنا جبل مرة وعشنا اللحظات حب ومسرة وبينا بينا تغازل كل زهرة وخيال رمانة لسه للشوق لوحة فنان تمحى الأحزان لوحة فنان تمحى الأحزان صفرة وحمرة زرقة وخضرة صفرة وحمرة زرقة وخضرة وزحفة نضرة وزحفة ألوان.
My name is Sara Abdelgalil. I'm a pediatric consultant working in the east of England. I joined the British Sudanese Association of Pediatrics and Child Health in 2003. At that time, I was a trainee. I joined for support, academic and social support. I continue as a member in the organization to support junior colleagues in training in Sudan and in the UK, and to help with delivering safe, high-quality care in Sudan.
Hi, my name is Ahmed. I'm a Sudanese pediatric trainee in the UK. I have joined British Sudan Association of Pediatrics and Child Health to be an active member of the initiative that primarily aims towards improving services provided to children and pediatricians back home in Sudan. Also, as a junior trainee, this organization will help me and support me to achieve my career goals on the long term. Thank you for giving me the opportunity to join this organization.
Hello, my name is Nada Ibrahim. I'm a consultant pediatrician working at Staffordshire Children's Hospital at Royal Stoke in West Midlands. I joined the British Sudanese Association of Pediatrics and Child Health so that I can connect with my colleagues inside and outside the UK, Sudanese professionals who work in child health service, to share ideas and support each other in professional path. One of the most important reasons I joined the association is to work in collaboration with our colleagues in Sudan who work in pediatrics and child health, to exchange knowledge and experiences in order to further develop pediatric profession and improve health policies for children in Sudan. I am a mother of 3 children. My hobby is to play volleyball. I used to play volleyball in high school and medical school. I still play volleyball occasionally if the weather permits with my children and my friends. Unfortunately, the weather is not great at the moment to show you some of my skills. I hope all Sudanese professions who work in child health to join our association. Thank you very much.
I became a member of the British Sudanese Association of Pediatrics and Child Health because it is my duty to offer support to my fellow Sudanese colleagues coming to the UK, as it is my duty to contribute with whatever way I can to the improvement of child health in Sudan.
I want to join the association because I want to contribute to creating a healthy environment for Sudanese children and to improve the situation of where they live.
I joined the BSAPCH because I believe we need a solid platform not only for pediatricians but also for everyone interested in pediatrics and child health. I think through the association we can share the experience and provide support and advice for our junior colleagues whether they are in training or planning to join. Most importantly, the association is planning to establish links, projects, programs to help improving the pediatric child health care in Sudan. It's our duty, commitment, and responsibility to be part of this improvement, and we should all work together towards these goals.
I'm pleased to join the British Sudanese Association of Paediatrics and Child Health as to be part of a union or a group where I can be supported, I can support others, being listened to, and my ideas to be valued. I needed to contribute towards enriching the solidarity of the Sudanese children carers, including parents, doctors, nurses, and all aiming at the end to improve their self-career and childcare in Sudan. I hope the association will also help the children health care services in Sudan to get better and will have a role in supporting its members in their daily career challenges. Thank you.
I have joined this association because I think it's a good platform to present some sort of support to my fellow colleagues in Sudan in order to enhance and develop our healthcare system in our beloved country through knowledge sharing and knowledge and experience sharing.
I joined the British Sudanese Association of Paediatric and Child Health to guarantee a smooth link between the Sudanese Paediatric Society in British and in Sudan.
Bismillah ar-Rahman ar-Rahim. Wassalamu alaikum. Dr. Osama, pediatrician in Darlington, and here are my reasons for joining and urging you all to join the BSAPCH. So I'm here to say that child health and well-being is of paramount importance, and it's the right of all children and adults to have an unrestricted access to free health care, have an access to health, to education, and to all of their basic needs. But unfortunately, some of these come short to our children in Sudan. So I believe BSAPCH have the potential to play a fundamental role to fill the gaps in this matter. And I urge you all to join the efforts led by the BSAPCH, and that's for three main reasons. Firstly, because of their excellent relationship and support to services provided in Sudan and to the Sudanese Association of Pediatricians, as well to the role that the BSAPCH plays in the humanitarian efforts to provide for the most needed. Second cause, that BSAPCH not only provide for the needed in Sudan, but it does as well assist doctors here, the Sudanese doctors, in planning and progressing in their career via advice and professional guidance. Perhaps the most of all, main reason I joined and I urge you all join the BSAPCH because of their excellent and professional committee, who are a group of professionals, dedicated and very friendly colleagues. I'm personally happy to help at any time, and so all together we can make a positive change. Thank you very much. Assalamu alaikum.
like a small boat on the ocean, sending big waves into motion, like how a single word can make a heart open. I might only have one match, but I can make an explosion. And all those things I didn't say were wrecking balls inside my brain. I will scream loud tonight. Can you hear my voice this time? This is my fight song. Take back my life song. Prove I'm alright song. My power's turned on. Starting right now. I'll be strong. I'll play my fight song. And I don't really care if nobody else believes, 'cause I've still got a lot of fight left in me.
I found that I could say things with colors that I couldn't say any other way, things I had no words for. Coloring is a deep, mysterious language of dreams and stress relief.
Okay, welcome back, everybody. I'm glad to be with you this afternoon in the BSAPCH Pediatric Training Interview Workshop. My name is Mohamed Abdoun. I'm a pediatric ST4 in north of Scotland, currently working in the Royal Aberdeen Children's Hospital. Right now, I'm delighted to introduce Jessica Burgess-Shannon. Jessica is an ST7 pediatric trainee, currently undergoing subspecialty training in neonatology. She recently moved to London for final years of training, having worked in the west of Scotland. She's interested in teaching, and she is both an NLS and ABLS instructor. In addition, she's developing interest in genomics, and currently she's doing a master's degree in genomics in Imperial College. Jessica will talk us through pediatric clinical reasoning and clinical thinking today. Welcome, Jessica. The floor is yours.
Thank you so much, Mohamed. That's very kind. And I also wanted to say thank you to Nuha for asking me to join you today. It's a pleasure. I'm just going to sort out sharing my slides. Let me see. It's just opening. Can you see my presentation?
Yes, clear.
Great. Okay. Okay, that should be full screen now. Can you see that?
Yeah.
Great, lovely. So as Mohamed said, I'm talking you through the clinical thinking station today. It's one of 4 core interview stations that you'll face when you're applying to subspecialty training. And what they're hoping to do is review your ability to assess and manage a clinical problem. You're given a verbal scenario and asked to describe your initial management to that scenario. And you then progress through the scenario further with the assessor through a series of follow-up questions. You're being assessed as a doctor in training at the level that you're applying for, and this reflects what is outlined in the person specification that you have available to you. The assessors will have a marking framework for that scenario, and it will cover a specific number of points that they want you to hit through your discussion. This is the person specification, and I cannot encourage you more to read through that, because the interview process is designed to test your knowledge and experience in these key areas. If you've looked at that document, you will know all the various things that might come up. And as you're looking through, have a think about what you know about the different areas and what your strengths are in those areas. It really does help when it comes to interview. And this is the same for all interviews that I've faced in my training so far. So that includes my subspecialty training in neonatology, as well as when I was applying to pediatrics. It's always the same, that it is based on the person specification, and that document is there for you. It's a bit different what they'll expect to ST1 and 2 to ST3 and 4. So the top box is the clinical knowledge and expertise, which is really the central kind of theme that they are testing in the clinical thinking question. And you'll see there for ST1 and ST2, what they're expecting is for you to be able to apply and demonstrate sound clinical knowledge and judgment, prioritize clinical need, optimize patient safety, and show that you know how to make an assessment and initially manage a sick patient. They also mention quite clearly there that there might be a safeguarding aspect. It could both be the medical side of an acute assessment or safeguarding that comes up in this station. With ST3 and 4, it's very, very similar. It's mostly the same, but you'll see there's a few bits and bobs that are different there, particularly the potential to develop excellent diagnostic skills. So they might expect a little more in terms of differential diagnosis and how you go from a differential to a specific diagnosis. But the themes are very much the same. What they are looking for is for you to be safe And again, I cannot emphasize that enough. They are not looking for you to assess a patient with complex epilepsy who maybe has one drug that's not working and looking for another drug option. It's very much acute stabilization and management to the level that is expected to be safe. And that does differ for people who are applying at ST1 and 2 and people who are applying at ST3 and 4. They'll want a little bit more from the ST3 and 4 applicants. However, patient safety always first, do the basics well, and you can then show off extra points with the kind of extra things you know as you go through. What they're looking for you to do is perform an initial assessment and stabilization of a sick child and arrive at a differential diagnosis. And again, this may be slightly more of a theme for the ST3 and 4 interviews, where you would then talk a little bit more perhaps about the kind of initial investigations and management options that might be appropriate for that case. They also want you to know about current guidelines and evidence-based medicine. So there's always an opportunity, if you're not sure of the exact doses or treatment options, to talk about the fact that you would review your guideline to make sure that you've got the steps there. And that's part of being safe, is using the resources around you sensibly. And both medical stabilization and safeguarding skills can be tested, as we have discussed. So safe practice is always the first priority. And that means assessing the child yourself and having a systematic approach to assessment. It also means working as part of a team and getting help early. Think about who you need to help you. When you ask for help depends on the situation and your level of training. As an ST1 or 2 applicant, as soon as you've identified a sick child, it might be appropriate for you to ask for help at that stage. And even if you're not asking to hand over to the consultant, you may be asking that they are called so someone is on their way to come and support you as soon as you realize that child is sick. If you're an experienced ST3, 4, it might be that you wait until you've done your initial assessment, but it's making sure that you're clear at the point where you would normally clinically ask for help, that you do, and that even if you get to the end of the scenario and you've stabilized the child, you're talking about now updating the consultant, because they're ultimately the person in charge of the care of this patient. And getting help doesn't just mean getting senior help to come and escalate the situation to. It also means getting pairs of hands, because if you have a sick child, everyone will know from clinical practice, if you have a sick child, it takes lots of people to move forward through an efficient assessment with them. You want someone to be doing the primary assessment, and you never want that to be interrupted. So at the point where you go and ask for oxygen or a fluid bolus or monitoring, somebody has to go and do that for you. So getting help also means getting pairs of hands when you've identified a sick child. And that's really important, because it means you can carry on your assessment and stabilization while other people are doing tasks for you. So have a think about those things and make sure you are talking through with your assessor when you would ask for help, who you want. And if you're not asking for help at that point, that it's something you still have an awareness of and you have a rationale why you're not asking at that point. In terms of a systematic approach to assessment, our primary assessment and resuscitation always takes an A, B, C, D, E format. And that's really important that you know that. I'm sure everybody does, and I'm sure it's something you're all using in clinical practice. But we all know that an airway issue is the first thing that is a danger to our patient. And if there is an airway issue, it has to be managed in a time-critical matter. Next, it's a breathing issue. Next, it's a circulation issue, and then we can move down. And it's ordered in that way because of clinical needs. So it's important that we address each of these issues in turn. Once we are sure things are stable from an A, B, C, D, E perspective, we can think about our secondary assessment, key features in the history, and that can allow us to then move on to urgent treatment. So for example, if you have a patient with diabetes, a new presentation of diabetes, if they have shock, that's the first thing you're going to manage when you get to your C assessment. And once you've stabilized things in terms of a circulatory perspective, you're then looking for these features that allow you to identify that this is a new presentation of diabetes, and you can move forward with your diabetes management, which is really important, but you always have to treat the A, B, C, D, E things first. Once you've done your urgent treatment, you can then think about the other aspects of further management. You can do a full, complete history, a full performer that you would do for any kind of admission, and talk through the fact that you know that that would come next. You can do a full examination, think about any investigations you need, and think about any aspects of further management. And that will involve things like making sure the consultant knows if you haven't already talked to them as part of the situation before, making sure they're admitted to the right place, and making sure all their regular meds and meds that you now need following your assessment can be prescribed. So the ABCDE assessment, this is your bread and butter pediatric emergency stabilization, and it's good just to refresh in your mind the things that you're looking for and the things that you need to do from an ABCDE assessment. So airway, you want to establish if the patient is breathing. Obviously, if they're not, you're not going down the sick child stabilization pathway, you're going down the resuscitation pathway. Is there any signs that the airway is compromised in a breathing patient? So gurgling, snoring noises, lots of secretions. If you have an airway issue, you need to stabilize the airway. So in the first instance, that's our airway maneuvers, head tilt, chin lift, suction if there's secretions. And always if there's an airway issue, you're going to need help. You're going to need lots of people, and you're going to need someone with airway skills. So that's usually anesthetics or other kind of intensivist practitioners. Moving on to breathing, you might want to know what the saturations are, the respiratory rate, look at the work of breathing. Is there recession? Is there tracheal tug? Is there grunting? You might want to do auscultation. You might want to check chest expansion. And if you have a breathing issue, oxygen is your first treatment. Further down the line is your specific treatments, depending on what breathing issue you find. But oxygen is always the first thing that you would put on for a patient with a breathing issue. In circulation, you're looking at heart rate, pulse volume, capillary refill time, and if there's a difference in terms of warm-cold gradient between the peripheries and centrally, and a blood pressure. And if you find a circulation issue, you're talking about cannulating and giving a fluid bolus. You then move on to D, which is for disability. So you can do an AVPU assessment, which is a kind of gross assessment of a GCS, basically, and it gives you a much more concentrated, quick assessment that you can use. So is your patient alert? Are they only responding to verbal cues? Are they responding to pain, or are they totally unresponsive? Checking a temperature is always a good thing to do. Checking a sugar is really important, and seizures might also be something that come up in the D assessment. If a patient is seizing, you are likely to have seen it before that point, because you will look at the patient while you're doing all of these. But it's really important if you do have a patient that's seizing, for example, while someone's going to make drugs that might help you progress through that part of their management that this patient needs, that you are making sure that A, B, and C are all stable. And you would also obviously always want to check a sugar for a patient who is seizing. If there is, for example, a presentation like a seizure, if we all just stood around waiting while the nurses were making up the drugs, we might miss an airway issue, and that's something that can happen with seizures. So it is really important to check all these other things. If there's anything in D that needs actioned it. For example, if you have a low sugar, you'd want to give a dextrose bolus. And then E is everything else. So any other important clues like suspicious rashes that are non-blanching, abdominal examination. There's lots of different things that you might look for in E, and it depends on the kind of scenario what you would be looking at. But your initial management is always your primary assessment in any resuscitation. So your A, B, C, D, E first. Reassess, that's really important. If A, B, C, and D are absolutely fine, you don't necessarily need to reassess. You'll need to go back at some point, but you can move on. But if, for example, you found a breathing issue and you started oxygen, you need to now go back and make sure that that treatment has worked, and is there anything else you need to do in that part. Then you're doing your secondary assessment, which is your wider assessment of the patient. Is there any key features you need to ask about in the history? For example, if it was a patient with a breathing problem, you might want to ask about a history of asthma, or if it's a new presentation of diabetes, you would want to ask about, is there any family history of this? Is this something that the patient has had before? Have they had polydipsia? Have they had polyuria? And get a focused couple of questions in that allow you to be clear that that's what you're dealing with, and provide any urgent treatment. There may be some cases when there is a little bit more flexibility, but always keep patient safety in mind. So for example, if I had a patient where I got to my B assessment and it was quite clear that I was dealing with asthma, I might ask the nurses to get me some salbutamol while I then continue my B, C, D, E. And then at the point that they come back with the medication, we can start that. But what you don't want to do is get to B and say, this is asthma, and then stand back and ignore the C and D while someone's getting the medicine. And this is the importance of working in teams as well. If you have a team around you, you have that opportunity to carry on your A, B, C, D, E and not miss anything, which is the reason that we do it while other people are getting things ready. Because you might identify the problem that's going on very early, but it's important to make sure all these aspects are stable before we move on. In terms of the kind of further management, you will hopefully have completed your scenario, stabilized your patient, and provided any urgent treatment that's needed. And you might now be talking through what your differential is. And the differential can be wide or it can be more narrow, depending on what the history is. And there might be an obvious cause or it might be more difficult to tell. So in order to kind of work out whenever we have a patient that presents with something that could have a range of options in terms of cause, we take a complete history and a complete examination and think about the investigations that help us confirm that diagnosis. Once we've done that, the assessor might ask you about what your kind of initial plans are with regards to those things. And then we need to think about any other further acute management that's needed in the treatment of this patient and any other long-term issues that need to be addressed. So for example, again, if it was a presentation of new diabetes, you would want to make sure that you've done all of the things that you would normally do for a new presentation in terms of the acute management. And you might want to mention, you know, tomorrow I'll get the diabetes specialist team to come and explain this to the patient further. I would want to have an initial discussion with the family about what this means for them. And these longer term issues are being addressed as well. Always mention guidelines. And if you're not sure, mention that you would check the guideline. And that's really important. You might feel nervous. It might feel like you're admitting you don't know exactly. But they always mark you up rather than down for being safe. So even if you have a clear idea of what your asthma guideline is in your hospital, for example, you can give that, but then say, and I would just double check the guideline wherever I'm working, and it shows that you know how to be safe. And if you're not sure of the doses, things like that, just say, I would check the guideline, I would check the BNF, I would check the local formulary. And that's not a weakness, that's very much a strength, being safe. Think about where this child is going and who you need to help you. As soon as you've identified a sick child, you should be thinking about what help you need. And at the end of the scenario, you need to think again about what help you need. Is this child someone you can admit to the paediatric ward? Or is it a child who's going to need intensive care support, for example? So have a think about where you think the care of this child is going and who you need to help you with that. And always think about family. Never forget family in your clinical thinking situation. And I like to think about it as A, B, C, D, E, F. And then that reminds me that I need to think about family at some point in that situation. They're going to need an explanation. The child is going to need an explanation. The parent is going to need an explanation, and they probably will need some education further down the line. So mentioning that you're thinking about these things is really, really important. So this is the structure that I use, and everybody's different in terms of what structure they have, but this has served me really well through years of interviews that I have done, and this would be an approach that I would recommend. It's not a set approach. There's not a secret formula that I'm giving you knowing what the examiners are looking for, but it's always served me well. So I'm happy to share that with you. So I would always assess the patient myself. I would do my A, B, C, D, E and resuscitate and address those A, B, C, D, E issues first, and then follow that up with any other urgent treatment that's needed. I'd then go back to do a full history and examination, which is different to my focused history, which I've used to do my urgent treatment, and think about the investigations that I need. With my final plan for where this patient is going once I have stabilized everything and we've treated the initial issues is appreciating both those acute and long-term issues that need to be thought about. I'm going to always mention that I would make sure that my management is in line with local guidelines, and I'm going to think about who and where this patient is going, who I need to help, and communicate with the family. Safeguarding can absolutely be in this station, and there might be a medical situation which has a safeguarding aspect, or there might be a focus on a safeguarding situation. So they should still be approached with a similar structure. Assess the patient first and just make sure an ABCDE is stable, because most presentations out of hours that come in with a safeguarding issue, they will be presenting with an injury or something like this that may still have medical aspects that need to be addressed. So just think about ABCDE and make sure that there's nothing there that needs to be actioned. And the examiner or the assessor will move you through that very quickly. If that's not their focus, they would go, great, the child's well, what happens next? And any urgent treatment that's needed, for example, for an injury. You then want to do a full history and examination, and again, think about investigations and further management. So it's the same structure, it's just the focus of that encounter will be different. So these are some safeguarding red flags that you might look for that would sort of indicate to you that there's something going on here. If you get a vague history which lacks detail, if the history is not compatible with the injury that the child is presenting with, or the child's developmental stage is not fitting with the injury. So for example, if there's a history of a fall in a child who can't walk, that's a concern. If the history is inconsistent and if it's changing between the different practitioners, if there's a delay in seeking medical attention, things like multiple previous attendances with injuries are also a bit of a worry. And if the child's interaction with the carers appears abnormal. So just think about if there's anything in the scenario that they're giving you that makes you think of safeguarding. If the differential diagnosis includes a safeguarding presentation, you do have to mention that and get an idea in your mind of how you might explore that further. You always need to get help. It's the same with safeguarding presentations, and your consultant is often the first point of support that you would look to for advice. And then the others that you'll involve depends on the safeguarding processes local to your area. It might involve a referral to social work. You might have a child protection medical team who are there to support you. Or if you're in a district general hospital, that might be part of the role of the general paediatricians. So knowing what your local processes are is really helpful. And if you don't know, you can also mention, I would speak to my consultant first and then go through the normal pathways of safeguarding processes. And I would ask my consultant what they are, and I would fill in any paperwork and chat to whoever I need to move forward with that. Whenever you're taking a history from a patient with regards to a safeguarding issue, make sure you ask open questions, because you don't want to put words in their mouth. That's really important. And you need to record any information that they give you in their own words and make sure it's clear that that's what you're recording, so you can put it in speech marks and things like that to make it clear that that's what's written down rather than your assumptions. It's what the patient has told you specifically. Think about place of safety. If you have a child presenting with an injury and you're not happy that they would be safe at home, you absolutely have to provide them with a place of safety. And again, that's different where you work. Sometimes that's always admission to the paediatric ward until the place of safety can be found with social work. If it happens within 9 to 5, sometimes it's calling social work and they'll find an emergency placement while they investigate. You just need to mention place of safety, and again that you would review that based on your local guidelines. You don't need to necessarily find the place of safety in your talk, but it would be following your normal processes that are available where you work. But also think about other children in the family home who might need protection. So you might have a history of an unexplained injury that you're worried about, and you just need to think about, are there brothers and sisters at home who may also be at risk? And communication is key. And there's a real skill in doing this in real life, in communicating with a family that you do have a child protection concern and you need to investigate that. That's your duty as a doctor, and that's your duty for the child. And doing that sensitively and in a way that's not very, very accusatory, that makes the parents feel very angry. And they often do feel worried and angry anyway, but doing that in a sensitive way that at this point It's just about investigating the possibility that it's your duty to explore all possibilities of how, for example, this injury happened, and therefore that means looking at child protection as a possible reason. And that you will see throughout your training by people who are very experienced at it over time. Accurate documentation is essential. And again, if you're doing a safeguarding scenario, just make sure you mention that you would make sure to document accurately and in the patient's own words. And the RCPCH has a child protection companion, which is an amazing resource when it comes to child protection issues. So you can have a flick through that if you want to revise anything with regards to safeguarding before your interview. And there might be some opportunities of other things to bring into this scenario. These are all of the other topics in the person specification. They're not the focus of this question. It will be more the clinical knowledge, the safeguarding processes, but there may be aspects to at least mention that may get you extra points. For things like communication, we've talked a bit about communicating with families, so making sure that you know you're aware of that. Problem solving may well be incorporated into this scenario. It might be that you have a small team, and how do you work together to make sure this patient is stable. Demonstrating empathy and sensitivity might come in, especially if there's a child protection element. Managing others and managing a team is likely to have a slant on this scenario because you'll be assessing a sick child and you need people. Organization and planning, again, there might be an element of testing that, showing that you can apply a structured approach. Management and leadership, again, that's working with the team. Vigilance and situational awareness, that's about knowing what's going on and making sure you maintain an overview of the situation. Coping with pressure, managing uncertainty. Teaching, that might be something that you can mention in your scenario. So if, for example, you've been working with an SHO, you might want to say, we would do a CBD afterwards. That's a nice thing to bring in that might get you a little bit extra as long as you've got everything else first. Research and audit perhaps is less obvious to come into this question, and core NHS values really are the things that we've talked about. So I'm going to work through some scenarios and how I would approach them, and you might want to think about what you would do in these situations. So imagine you're in a district general hospital and you're asked by the nurses to come to the assessment unit urgently to see a patient that they're worried about. The patient is a 6-year-old girl who's attended with difficulty breathing. She's got a background of eczema. She's developed a cough 48 hours ago, and over the past 12 hours, she's been increasingly short of breath. So how would you assess and manage this patient? So think about what I've said and just think about the things in your head that you would want to know if that was your question and how you would work through that. My thoughts are that I would come to assess the patient urgently, and I would do an initial A to E assessment. So I'd make sure the airway was patent. I'd check what the respiratory rate is. I'm told by the examiners that it's 55. I'd listen to the chest. There's an expiratory wheeze, and the SATs are 91. So that concerns me. I found a B problem. I found low saturations. I found a fast respiratory rate, and I found wheeze. So I'm going to start oxygen at that point. It might be with the wheeze, the background of eczema, that I say to the nurses, this might be acute asthma. Could you start looking at getting the salbutamol ready for me? And I'm going to continue my assessment, but you never want to stop your assessment and move away from the patient with no one checking the ongoing A to E to do something like that. But if you have the opportunity to do both at the same time, you can. So then we move on to C. We've got a slightly fast heart rate. We've got a cap refill time that's okay. We've got a normal blood pressure. We've got a normal pulse volume. So I think that's okay. I think that's a breathing issue that's causing a bit of tachycardia, but otherwise okay. She's agitated and uncooperative. Again, that's a bit worrying. This could be because she's hypoxic. So I really want to get my oxygen on. I might want to check a sugar here as well. And then on E, I find a kind of eczema type rash. This is a sick patient and I need help dealing with this patient. I want nurses to come and help me, and I would like someone just to make the consultant aware that I'm dealing with a sick patient in the assessment unit, and could they come as soon as they are available. I think this patient has asthma based on the history of the eczema, the wheeze, the history of the cough, and then the shortness of breath developing, so maybe a viral trigger. And she's 6 years old, so I think she would benefit from an assessment of reversibility. So I want to give her nebulized salbutamol and nebulized diplotropium. I want to start steroids, and I can give that IV if the patient's unable to take that orally, and I want to reassess. I want to consider the need for further treatments depending on how the patient responds to salbutamol and having started the steroids. So thinking about magnesium, IV salbutamol, or aminophylline. And how much you know of this pathway will be determined by what level you are. When I applied at ST1, I had an acute severe asthma, and I recognized that. And I said I would give salbutamol, and they said, great, do you know the dose? I said, I don't. I would check my local guidelines, and I would give steroid. And they said, what do you know about further treatments? And I remembered magnesium and I remembered aminophylline, but I didn't get everything, and I didn't know all of the doses. But that's safe for an ST1 if you know some of the treatments, you know roughly what level you give them in, what order you give them in, and you know where you need to go to find more information on that. With an ST3 or 4, you would expect that they would know a little bit more about the management pathway. Again, it's unlikely that they will ask for doses, and as long as you know where you need to go to find them, that's all you need. I'd then take my full history and examination, and I want to make a plan for ongoing acute and long-term management. So acute depends on the progression of the scenario, and I will be doing that with the assessor, so they will talk me through that. So if she's getting better, I want to update my consultant that this patient is coming to the ward. She's going to need regular steroids. And again, I want to assess her at least 1 hour later to see if she needs another neb or if we can stretch her salbutamol. If she's not getting better, again, I want to discuss with the consultant and think about an intensive care setting for this patient. Long term, I might want to look for features of chronic asthma that might warrant a regular inhaler, and talk about education on asthma and triggers with the family. So that would be my approach for scenario 1. I need to communicate with them, and I might have an opportunity to bring in some extra things which gets me extra points. I might want to talk about the fact we've dealt with a sick patient as a team, and we now have an opportunity to debrief together as a team, which can be a really valuable learning experience. And I might want to say I would do a CBD with the consultant after managing this case, because I've dealt with an acute asthma patient who's been quite sick on my own. So that's a good opportunity for my learning. So the next case, let's have a think about what we would do with this kind of case. It's a safeguarding case. So you're called to see a 4-year-old boy in the paediatric assessment unit who's been brought in by his grandparents or his grandmother. She regularly looks after this child when his parents are busy, and on picking him up today, she noticed a rash on one of his hands. She's done the glass test, and this rash doesn't fade. So she's brought him in to be seen, expecting that this might be a sort of concerning medical rash. She's been unable to speak to the parents to find out how long this rash has been there, and they're not answering their phones. So just think about how you might assess this patient, how you might manage, what structure you might use, and what are the kind of issues you need to explore here. So these are my thoughts. This is the rash that you can see here, with some blistering on the hand, and blistering in a linear fashion, across the side of the hand. I would assess the patient, and I would do an A to E, and I find a well child with normal observations. So this is less worrying from a medical perspective, and medical rashes don't tend to present in that linear fashion. So I've found 4 well circumscribed lesions on the back of the right hand. There's no signs of spreading erythema, and there's no lesions elsewhere. I want to take an extended history and examination, and I want to think about how I would do that. What are the sort of main things that I want to ask? So I want to get a clear timeline from the grandmother about when she noticed this, exactly what time, when did she last look after him? Did he definitely not have it then? And get as much of that timeline as I can. My patient's 4, so they might be able to tell me how they got these marks, and it needs to be an open question, and you just record what they say. I want to think about the general appearance of the child. Are there any other marks or bruises of concern? I want to look to see if they've come in regularly to the emergency department before and what presentations they've had. I want to ask the grandmother if she has any concerns about this rash and about the home life, and find out if the family is known to social work. And I want to have a think about how the child is interacting with the grandmother, because even though the history is the grandmother's just picked the child up, and therefore we're assuming this could be a rash that's been acquired in the care of the parents, that might not be true. I once with a safeguarding case had a child who had a bite mark, and the mum had said it happened in the care of the dad, but it actually turned out on the investigation that the mum had bitten the child in order for it to look like the dad, because she didn't want him to have involvement with the child anymore. So there is sometimes a different chronology than what you expect. So it's important to document everyone's interactions. So the differential diagnosis for marks like these, where there's discrete blisters in an entirely well child in a linear fashion, includes cigarette burns. If they were all over the hands, in the mouth, in the feet, you would think more hand, foot, and mouth. So sometimes there are medical alternatives for marks like this. And sometimes there are innocent explanations of accidents for things that initially look suspicious. But linear marks in that way that are well circumscribed in an entirely well child, cigarette burns would be on that list. So think about patient safety first. Is there anything that I think needs to be investigated from a medical perspective? Is there a differential that I would want to explore here? And I would want to trigger the safeguarding process in line with what's normally done at the place where I work. So first I would discuss with my consultant, think about place of safety for this child. Does that mean an admission? And the right referral pathways thereafter. So social work, safeguarding, and if it's a physical injury, that often involves the police as well. I need to communicate with the family, and that's incredibly difficult to do, but it's important to be clear about what the concerns are and what happens next, and explaining in the best way that you can that this could be something like a cigarette burn, and that has to be explored. Other aspects you might want to bring in, again, is the opportunity for learning. So there might be a good opportunity here for me to do a safeguarding CBD, and that is just sort of the icing on the cake, really, if you're thinking about these extra things in your scenarios. This is the final one, and then I'll take some questions. So the nurses call you to review a patient in the paediatric assessment unit. The patient is a 5-day-old baby born at term by SVD. He's been feeding poorly for the last 24 hours and is becoming increasingly lethargic. The baby's been assessed by a colleague in ED who thinks the baby might have reflux and has arranged for the baby to come to the unit to try a bottle feed with Gaviscon to see if that makes a difference. The nurse is really worried that this patient does not look well, and she said that to the ED doctor, but those concerns have been dismissed, and she's calling you to review as soon as you can. So again, think about the assessment that you might have for this patient. Come and assess the patient urgently. If a nurse is concerned, come and see the patient. That's always the best rule. And ABCDE with your initial assessment. So is the airway patent? When I get to breathing, I find the respiratory rate is high, there's some recession, and the SATs are low. So that makes me worried. I found a breathing problem. I'm going to start oxygen as my initial treatment for that. I'm not sure why the baby has a breathing problem, but we're starting oxygen because we found an abnormality. The heart rate's really high, 192. The pulses are difficult to feel, the cap refill's prolonged, and this baby is cool peripherally. So I found a C problem now, I found a circulation problem. This is all suggestive of shock. So I'm going to cannulate, I'm going to do bloods while I cannulate, and I'm going to do a fluid bolus. When I get to assess D, this patient is only responsive to pain, they have a low temperature, and they have a glucose of 1.7. So I need to give a dextrose bolus because the sugar is low, the temperature is also low. When I look at E, the tummy is soft and non-tender, the heart sounds are okay, and the femorals are palpable. I would reassess. And this is a sick patient. I need help. And where you ask for that help will depend on your level. As an ST1 or 2, I would expect as soon as you've identified this as a sick patient, even at the B stage, I would be asking for help. As a more senior trainee, there may be a rationale for saying I'm going to complete my A to E and then speak to my consultant. But you need the other people, so you need help in the form of nurses and doctors to help you complete your assessment and get these treatments going. But as soon as you are worried this is a sick patient, think about asking for help, and where that comes for you depends on your experience. The differential of a sick neonate includes infection, congenital heart disease, metabolic, and child protection. A shaken baby, for example, can present very unwell and collapsed. And again, the expectation of how much detail you go into about these various different differentials will depend on the level that you are. But sepsis is always in that list. So I would always expect everyone to say, I need to give antibiotics to this baby until we know it's not infection. You do an extended history, examination, and investigations that help you differentiate. and think about what investigations might be helpful here. Again, it depends on the level you are, what they'll expect. For an ST1, ST2, you might just be talking about a CRP, a full blood count, a blood culture, a blood gas, a chest x-ray, all the normal things that we would mention when we're assessing sick children. You might go into a bit more detail if you're an ST3, 4. So definitely the initial kind of infection screen, think about any other micro and virology samples that you might need. This is a very unwell baby, and as soon as they're stable, you would probably want to do an LP. You might want to catch a urine, so think about these things. And more so than ever, we're doing virology testing urgently because we want to make sure all patients who come in don't have COVID. Think about a lactate, a gas, and maybe some initial metabolic investigations. Again, how much detail you go into will depend on your level, but it's totally appropriate to say, I would check my local guideline, and most places will have a guideline that includes the initial metabolic investigations for a child presenting with unexplained hypoglycemia, and that will include most of the things that you need here. And think about an echo. For this patient, they had normal pulses, they had normal heart sounds, so that's not super urgent in my opinion, but it might be something that you think about for a collapsed neonate. And if there was anything like you couldn't feel the femorals, or they had an abnormal murmur, that would be up your list on account of those findings. Make a plan for ongoing management, and it depends on the progression of the scenario, but you definitely want to discuss with your consultant. You probably have done that already, but at the end you'd want to mention it again. I would discuss with them again. Think about whether they have stabilized and they're fit to go to the ward. If they're still unstable or they've had a lot of fluid, it's more of a PICU or NICU setting. Agree the next person to review the baby. Are they going to see them in half an hour when they get to the ward? What's the timing? Hand over to that person and write up their drug chart, their fluids, and communicate with parents. And again, this might give you the opportunity to bring in extra things into this scenario. So you might want to debrief with the team, do a CBD with your consultant, and feedback to the ED colleague who missed this sick child. And you don't necessarily have to do that yourself. That is more likely to be done by your consultant, but it's important about thinking about these other things, and they just show that little bit extra in terms of your leadership. But the safe things are your initial assessment. So to summarize, this is the structure that I would recommend, and you can tweak it depending on what works for you and your experience. But assess the patient, do an A to E, and resuscitate first, followed by urgent treatment. Or if you need any urgent treatment at the same time, that it's happening simultaneously, but you never leave your A to E to go and do something else. That has to be worked through first. Full history and examination and investigations to confirm the diagnosis. Think about further management, both acute and any long-term aspects. Mention local guidelines and the fact that you would treat in line with them and you would check them. Think about where the child is going and what help you need, and always communicate with the family. So that is the end of my presentation. I'm very happy to take any questions.
Thank you, Jessica. That was very helpful and useful and concise. The floor is open to questions. What are the commonest scenarios that come in clinical thinking?
So I've come across acute severe asthma previously. I've come across sepsis, both in an unwell neonate and an older child with a chest infection. I've heard of a new presentation of DKA and safeguarding as well. And that can be an injury, a burn, things like that. It can be anything, but it will be the kind of normal scenarios that you come across when you're doing simulations, when you're thinking about emergency situations that you need to know. It won't be anything more exotic than that. It's all stuff everyone knows how to do in their normal practice, I think. It's just, it can be more scary in the situation of an interview, and your head can be more easily distracted by the stress of the situation. So having a structure really helps you with that.
Can I ask a question about escalation? So if you're applying for ST1 and you're escalating upwards, should you then say that I would call my registrar?
Yes, yeah, absolutely. Whoever's next in line from you, I would call the registrar. Yeah, you're absolutely right. And do that early, and they probably will still want you to progress through the situation. So what would normally happen is you would say, for example, I found a B problem. I'm worried this is a sick child. I would ask the nurse to call my registrar so they can come down and help me. And they will probably say, the assessors, your registrar's coming shortly, if you would like to continue your assessment in the meantime. So you would continue to progress so they see what you know, but they would say your registrar's coming. But yeah, you say your registrar. You can say the consultant, but the normal process would be your registrar. I don't think they would mark you down on either, because it's about it's about showing that you need senior help in whatever form that is. And some places, some small DGHs, there might not be a registrar. Most places do have them, but if it's a very small unit, it might be the next step up as the consultant.
Okay, thank you.
Hisham is asking if I missed something in the B or C assessment, how I can catch up.
So again, it's about identifying the problem. So for example, if you found the SATs at 89 and you haven't mentioned, you haven't got a respiratory rate, that's fine, because you've identified low saturations, so you've treated it with oxygen. If it's something important, so if you've come down to D, for example, and you haven't mentioned something that's really critical in B, you haven't listened to the chest, for example, you would just say, this is my D assessment. It's just come to me. I would always listen to the chest in B. I didn't do that, so I would listen to the chest, and just make sure you mention it, and they'll go back and tick it off. It's absolutely fine. It's just showing that you know it. And we all get stressed in these scenarios, and we all sometimes skip something that we would normally do. Just mention that I would always normally do that. I've missed it in this discussion, so I would go back and do it now, and they'll give you the information. But B is a good example. If you've got low saturations, you've listened to the chest and you've checked expansion, and you've found a problem and you've actioned it, it's fine if you don't mention tracheal tug or the specific respiratory rate or something that is no longer so important, because you've already found the problem and you've got the information that you need, if that makes sense.
As an ST1, what are the expectations regarding safeguarding?
So as an ST1, you need to recognize that their safeguarding might be a presentation with the scenario you're given, and they'll make it obvious. They won't make it something like a really good history of an injury that it was during sports, where it's very unlikely that there'll be a safeguarding issue. They will make it something where it's quite clear from the scenario that they give you that there's something concerning about this history, there's something not fitting. I'm going to make drugs that might help. It will be obvious, so don't worry too much about that. You need to recognize that there might be something that's a safeguarding issue, and again, escalate appropriately. So you wouldn't have to deal with that by yourself, but you should be speaking to the right people. So speaking to your registrar, speaking to your consultant, speaking to your safeguarding team, and telling the family that you have done that, and asking some of those key questions that allow you to get a little bit more information about it. They're not asking you to do a full child protection assessment or be the person that is going to end up writing the statement that takes you to court. But if there's something concerning about this history, you need to flag that and think about the few questions that you would normally look for, or the red flags you would look for, that help you take that forward.
Are there any more questions? I think thank you, Jessica, for the nice presentation and being with us today.
Thank you.
Hope to see you in the next sessions.
And good luck to all of you. You'll all be fine.
Thank you.
Okay, bye.
Bye. Just I'll share the next session slides. So right now, it's my pleasure to introduce Dr. Sara Abdelgalil. She's a pediatric consultant and associate professor in St. George, Grenada, with special interest in ID, immunology, and allergy. She's graduated from University of Khartoum. Sara is involved in several projects linked to children's safeguarding, quality improvement, safety, and governance in Sudan. And she was nominated in the top 100 influential women by BBC in 2019. Dr. Abdelgalil will teach us today about governance and leadership. This session for those who applied for ST4 and ST3. If you applied for ST1, you are welcome to stay. If you are going to take a break, please make sure you come back before 3:20 as the next session will start. Please welcome Dr. Sara.
Assalamu alaikum. Masā al-khair. Thank you very much. And thank you for your help, Mohammed, with the slides. I'm talking from my phone at the moment.
Just
I'm going to
sharing this.
Yes, I'm going to talk quickly about clinical governance, and I'm sure that most of you by now handles and very aware about clinical governance. So this will be going just like a quick refreshment. Please let me know if it's noisy or you can't hear me well. Otherwise, I will start. So when we are talking about clinical governance, this is the bread and butter in the NHS. And what you need to demonstrate in the exam, that you understand this, the concept very well. And you are practicing that on a daily basis. And therefore, it is can be assessed as a separate station, but actually it is present in each and every station that you will be covering. So if we go to the next slide, and what I would like to talk about is, it is important to bring with you your experience, not only in the UK, but even your experience when you were working in Sudan or you were working in other country. And actually you have to be proud of this experience. And when we did the course called Paediatric KIPS in Sudan, the members of the attendees realized that they were practicing all of the elements of clinical governance, or there were some gaps, but they were not aware of that. So you have to be aware, and don't think that I haven't done this while I was in the UK. You may have done one aspect while you were working somewhere else. So add that to your experience and utilize it in the right way. In the last slide, I want to congratulate you, first of all, because you have done all of the difficult parts. So you have done your MMBS, you have done your foundation training, the PLAB, and you have a vast experience working in the foundation or internship. You've done your MRCP, CH, APLS, NLS, and others. So you have a vast experience. I'm not sure, Mohammed, are the slides moving or? Yeah. So you have to approach this assessment that you have done a lot of work, or the majority of your work or duty already have been accomplished. What you need to do here is self-marketing. You have been shortlisted, so you are eligible. So you want to demonstrate that you are a competent pediatrician, even if you are a trainee, and that you are promoting safety and good quality of care. And in pediatrics, and if you look at the Royal College of Pediatrics, there are certain elements and areas that will come for definite on the assessment. One of them is medicine for children, so medicine information, prescribing, safety, errors in prescribing, errors in demonstration. There are issues about child protection and safeguarding, and there is a quality improvement sector completely. So if you have time, just have a quick look at it, so you are familiar with that as well, and you may as well use it during your assessment. In the next slide, what I would like you to focus on is to be familiar with the system. So as far as you have worked in the UK, so you are familiar with the system. You have the knowledge and the skills regarding safety and quality, which we will come and talk about. Another part which is very important is the communication skills. I'm sure you have done your session on that. And that will include the written, the verbal, face-to-face, virtual, and the handover. And the handover is one of the areas that, you know, may be as well assessed. Being a team player, but at the same time, you are a team leader. So when we talk about clinical leadership can be the, you know, hospital at night, the registrar and the SHO, or as in some hospital, it can be the tier 1 and the consultant. In the ward, you will be responsible after the ward round. So the clinical leadership has got different levels. It's not just at the level of the consultant. At each level, you are demonstrating leadership, and you have to show that in your assessment that you are capable at your level to handle the responsibility that are appropriate, and you know your limitation and when you're going to ask for help. One of the most important aspects about safety and quality is the pediatric early warning scores, the PEWS scores, that most probably you're using every day. But that can come in different ways of an assessment, or you can show that you are responding to that, or you are asking for it, or you are aware of how to use it and escalate. As well, other areas is the situation awareness for everyone, or SAFE program by the Royal College of Pediatrics and Child Health, which will talk about the same aspects about communication, about the huddle, about early warning scores, identifying the sick child. So in fact, most of the areas in clinical governance will be sort of similar, or they will be crossing each other. In the next slide, I would like to talk about the 6 domains of quality. The 6 domains of quality are how we are providing safe care, so that we're not at all providing any harm when the child is with us in the hospital. And that can be by identifying that the child is sick from the beginning, having a pre-alert, or having an arrest call, that we did not provide any harm by demonstrating the wrong medication, or we have not seen the child late because we did not know the priority, and that's an issue. About effectiveness, and that's using evidence-based guidelines, protocols, peer reviews, discussing with tertiary units, so you can demonstrate that, you know, this is a complex patient and I need to speak to their specialty units and get some more information. And then as well, the care should be person-centered. And this is unique about pediatrics, because in pediatrics, you can have neonates, you can have infants, you can have primary care, primary school age, you can have secondary school age, you can have children with special needs, and you have the family. So you have to demonstrate that you are involving, you're caring about the family and about the child. And if the child is able or verbal, you will get the child involved. Mohammed Usman, we are not, we can move on. I will tell you when to stop. Which slide? Here, yes, we're here. We can stop here. The timely management is important. As I said, it's either you see the child according to the PEW score, or you see the child because the nurse have called you and she's concerned, or you're responding to maternal or paternal or, you know, family concerns. And that's really important. Not requesting unnecessary investigation, and not, you know, causing waste by requesting, you know, wrong medication, or, you know, giving medication unnecessarily. That is really as well important. And the equity and the access to health is very is very crucial, because we know that access to healthcare is different. There are different issues. It can be related to that we have a service that's not available in all parts of the UK, or there is issue with language communication and translation, or there is issue about culture, or there's issue simply about transport and using the bus or not being able to drive. So understanding the dynamic of the family, and that can come as part of a communication scenario, or about the family and how you listen and you appreciate that and you try to help. In the next slide, I'm just going to zoom out from the clinical governance and try for you to understand the concept of governance as a whole. So when we talk about governance as a whole, and you work in the NHS, and the NHS is one of the global examples of public health. And then when you come to the clinical governance, it's what you are practicing every day as clinicians. And then you have the corporation governance, which is what the managers are applying within the NHS. And maybe you may not be interested in corporation governance, but just to make you aware of it. In the next slide, I'm going to talk about the generic meaning of governance. And simply, group of people working together, doing the right thing, and using the public money, al-mal al-am, in the right way for the benefit of the people. And as well, being responsive, being innovative, and being inclusive, and showing that that's in their leadership. And the most important example is COVID-19, that made us change the way we are practicing, and always remember to reflect on that and to change. There are things that people felt that they can never do, but actually now after COVID-19 have been done more frequently, and that's is important example. If we move to the national health services in the next slide, clinical governance and quality and safety is an important concept, and you have to look at it as you have a big institution, and in this institution you have clinical and non-clinical, you have management, and you have money that's coming from the government, and how people will be using that. And then looking at yourself as tier 1 or tier 2, and you may think, well, I have nothing to do with it, but you are part of it, and you are part of delivering the health strategy overall, whether you're working in a tertiary unit or a secondary unit, or even sometimes in primary care with community pediatrics. And therefore, the general concept about governance is important, so that you are a building block to achieve that. When we move to the next slide, which is about the organizational governance and trust boards, as I said, you may think like, oh, I'm not interested on this, but this is just a flavor about the trust boards. Will be thinking about what is the responsibility of this trust according to the strategy, but according to the local area. What are the standards and the performance for monitoring, because monitoring is important. How can we provide the quality assurance, and how can we continue improving on quality care, and what are the risk and the incident management, because that's important. And so an incident, a serious incident, will be, for example, on a ward that a child arrested, and when they tried to call, they gave the wrong address or the wrong information about the ward, and the arrest team arrived in the wrong place, and then they came, and the child survived, but there was a delay about 7 to 10 minutes. Things like that will be discussed, because this time maybe nothing happened, but next time something may go wrong. And this is like a journey from the ward to the switchboard, to using the phone for the team to understand what's happening. An example, we had a child visiting with the family in the maternity unit, and the child collapsed. And when they picked the phone, they thought switchboard, there is a pediatric arrest in this ward. The switchboard felt like there is a mistake. So they said there is a pediatric arrest in the pediatric ward. So they gave a different name, and therefore the arrest team arrived in the wrong place. And then people realized it's like about communication, about stressing it, and how things can happen. This will not be discussed just at the level of the pediatricians. It will be discussed at the level of the whole trust, and you are part of it. So your contribution, your documentation, your assessment is really important. So if you go to the next slide, what you must demonstrate in your assessment. You must demonstrate in your assessment your awareness, your understanding, you are practicing, and you are applying the different aspects of clinical governance, and you are promoting that. So that has to come across when we are assessing you, that you understand what you're talking about, you know how to apply it, and you are promoting it, especially at the level of ST3 and ST4. So if we move in more details in the next slide about the 7 pillars. We can go to the next slide. I think we have this is about the definition of the clinical governance. Now, the definition of the clinical governance, which is very standardized, this is for the PLAB, for the foundation. But now at the level of ST1 and ST3, you have to go beyond that level, okay? It is not about just rehearsing the definition and saying this is clinical governance. Now we have moved, away from that. You are at a higher level of showing your understanding and your practice, but not just rehearsing the definition. So if you look at the 4 or the 7 pillars, which I'm sure you're all aware of, but we've started about the education and training, and that will come at different questions about, your education and training. How do you demonstrate that? What is your skills? How can you explain to a medical student about the use of bronchodilators, or to a nurse student, or to advanced nurse practitioners, or to your other colleagues, or how you demonstrate about a lumbar puncture. So this is about education and training. Then about quality improvement and clinical audits. And by now you should have been involved in different clinical audits or quality improvement projects, and you can demonstrate that, or even mention in your discussion, because I'm not quite sure about this case and the protocol was not available. Maybe we need to look and do an audit and then develop guidelines. So demonstrating that you practiced it. That you have practiced clinical audits, that you have done it, and you know that even if you haven't completed the circle of the clinical audit and re-audit, that something has to happen, or you have participated in writing recommendations.
Sorry, Sara, you are mute, Dr. Sara.
Sorry, I was just mute for a few seconds, I hope. So about the clinical audit and the quality improvement, this is an area that there will be a question. You will be asked about it either directly or indirectly. And so you have to prepare your scenarios and your examples about what are you going to say and how you are going to demonstrate your understanding and your practice. Then if we look at clinical effectiveness, as we said, about the evidence base, about research, about studies, and as well your involvement in research. So your involvement in research and studies, you don't have to be the first investigator in the field. You could have helped in writing the proposal, you could have helped in collecting data, you could have helped in taking consent, or you can be, you have done the whole research project. So you have to think about where have I contributed, and make sure that comes clearly. Don't get sort of worried if you're asked the questions like, oh, I didn't do a research. You have to demonstrate your understanding, that you are using even evidence-based, and you know how to critically analyze an article. So even if you have areas where you have gaps, be prepared on how to demonstrate that you you are working on yourself to develop your skills. Openness, it is an important aspect, especially for us when we are overseas doctors, and that will be looked at carefully to see whether we have this practice about becoming open, apologize, explain about sort of a mistake that's happened, be ready to to cooperate in any investigation, and that's as well can be an assessment or a scenario that will come clearly, and that will depend on your good communication skills and being honest and being open and being clear and understanding the system, that there will be an investigation and there will be a feedback and people will look into the practice and try to learn from this mistake. The risk management is something that sometimes junior colleagues are not aware of. For example, that there is a risk register, there is a risk assessment that's taking place, and there is an ongoing governance meeting, because not all of the trainees will attend governance meeting. I would recommend that you should attend the governance meeting if you are not on clinical shift, so that you can understand that there is a risk assessment and risk management. And one of the most important part of the risk assessment is the rota and having enough staff. With COVID-19, we know people are off sick with other issues, that there will be gap in the rota and the gap in the cover. And this is a big risk in most of the clinical areas at the moment. But the risk assessment can be different. There can be different examples as well for that. And I think we have completed this circle, so we can go to the next slide, Mohammed, if you don't mind. So this is a repetition of what I've said about demonstrate that you grasp the clinical governance principles. And as well, I have put an example about how do you think about it in your head, is about giving an example with the SAFE initiative, which is the situation awareness for everyone, especially during the handover. If you're coming for a handover and you appreciate, for example, when you arrived, there was someone sick, or there's someone who's deteriorating, or you don't have your full team with you, and there is a lot of patients to be seen, someone in the pediatric department, someone in A&E. How would you manage that? And what is your priority? And when are you going to ask for help? That's what people would like to hear from you, that you make this assessment and you understand your strength and you know your limitation and you are safe. You're not going to call the consultant at 3 o'clock in the morning to say, there are 15 patients waiting to be seen. I have someone who has been deteriorating and it needs an intubation. And I have as well, a delivery. They want an SHO to go or a registrar to go for a delivery. So you're not leaving things to the last minute, and you are proactive from the beginning. You are assessing the situation, you know what to do, and you know when to call for help. Use practical examples, sit with, get a piece of paper and a pencil and write about the guidelines you have contributed to, the protocols or the guidelines and protocols that you found very useful, or protocols or guidelines that you have made some feedback or correction about. COVID-19, there has been a lot of areas most probably you have worked on and examples that you can use. Safety alerts, mainly about the use of either equipment or medication, if you have been involved with any of this. Incidents about writing datex or about being involved in writing statement with for a datex or an incident, and complaint answering about a complaint, and being transparent. Other issues that you can, or other areas that you can use as well to help you is in relation to mandatory training. I remember your training about infection control, your training about equity, diversity, and inclusion, prescribing, which is really important, documentation, and communication. There can be a lot of examples from there. Referral pathway, whether you are accepting the referral from other colleagues or primary care or from secondary, or you're making the referral to tertiary unit or specialty, and there has been a case where you think can be useful. In the second slide, or the next slide, I mentioned about telemedicine and your experience, and this is something that you may be asked about. Feedback from families about the care, and how would you respond for the feedback, and learn from what people are saying and try to improve the performance, not for you individually, but for the team and for the system as a whole. The teaching, there are different teaching opportunities that most probably you have participated on. So think about the department, the deanery, think about the Royal College of Pediatrics, as well learning about what's been outside international, WHO or UNICEF, if it's related to your area that you are applying for, or you are have interest in that area, for example, diabetes or anything like that. Safeguarding questions will be something that will be assessed either as a station on its own, or it's coming every now and then. And it is something you have to demonstrate that you're thinking about it. It's always at the back of your mind. For a patient who's not presenting, or to pediatric outpatient missing their appointment, for a family that the child is presenting with uncontrolled whatever illness, diabetes, asthma, for a child who is presenting with unexplained bruises, for a teenager who is presenting with multiple deliberate self-harms. And I think when I come and talk about deliberate self-harm and mental health and CAMS team, at the moment, there is a surge of these cases in the pediatric departments, and sadly, we don't have, good cover from cover from childhood psychiatry. There are not enough trainees, and therefore it's an area where you should show how you deal with it. And it's not difficult that you do the assessment, the medical assessment, the mental health assessment. You should have like a tool, and you will make the referral, and you will act as well on safeguarding and on the social and the family structure, and you will come with a plan that's safe for the child or the young person, that address the family concerns. You can have, for example, a scenario of the nurse coming and saying they don't know what to look for, or how they can look after this child, high risk of suicidal attempt, and that you're going to discuss that with your consultant, and you're going to involve the CAMS team and discuss that as well. And you have to show empathy and understanding, for this young person who has presented with this illness. So it goes just beyond the paracetamol and the paracetamol graph and the blood results. You have to show that you understand the whole picture, not just how many tablets and how many milligram per kg, and does the child need an infusion or the child doesn't need an infusion, which you usually do. It's about the child or the young person, and that you have, tried to manage and speak to that person, because they are supposed to be giving you the history about their family, about safeguarding, and you have asked other questions related to sexual health, and the complexity of these cases. If you just put them, in an organized way, it will look that you have managed this case, which you are. I'm sure in each area in the UK now, you're dealing with a lot of young people who are presenting with deliberate self-harm. Always go back to your guidelines, always go to the Royal College of Pediatrics and Child Health, and make sure that you are aware of these guidelines. So in the next slide, before I end, I think the duty of candor, and it's all about, being open, being ready to apologize, to explain the mistake that happened, the consequences of this mistake, and what will happen next. And usually that will be either a senior registrar or a consultant, but it is as well important to show that you understand what is the duty of candor. If you have a case and you say most probably there will be a duty of candor in this case because it's a serious incident. I think we're going to go to the next slide, Mohammed, if you don't mind. So the areas that you have to concentrate on or be, very, very ready to answer all the questions is about prescribing medication in children. What are the challenges and what could be the issues? And if a mistake happens, what would you do? The other is about using traffic light and pediatric early warning scores, and acting on that, escalating when necessary, and identifying a deteriorating child. The COVID-19, I'm sure there will be some question at some stage, and you have to show leadership by understanding and answering questions, sometimes to the families or to the staff about it in the middle of the night. There are other issues are related to public health in pediatrics. Some of them is about healthy eating, about poverty, about equity of care. That may not come directly, but as well, it is useful for you to be sort of, to look outside just the clinical sort of picture. So if we go to the next slide, there is the, this report was published a few years ago. It is useful, but to read about it, to understand why children die in the UK. What are the common causes in each age group, because that as well, it comes across as you're talking about it, and your understanding about the epidemiology, that will be useful. And it is not something that you don't know, it's just, you confirm. And sadly, the UK is at the lower of the list for Europe about children's death in different areas. One of the areas that people talk about is early identification and treatment, if it was for acute sepsis or infection, or identification of oncology patients, and the prognosis on the treatment. You have the road traffic accidents, and you have the deliberate self-harm and mental health. So in summary, you are a leader and you are handling clinical units, whether a tier 2 or a tier 1. You just have to sit and write that in front of you so that you are sort of more aware of your leadership skills that you are doing. The SAFE program in the Royal College of Pediatrics will help you, similar to having A, B, C, D, E in your clinical assessment. If you use SAFE and the tools in this program, that will help you to demonstrate your clinical governance skills. The patient journey, think about the patient from admission to discharge. And there are a lot of things that can happen, and how they will have a positive experience when they come to the units. And this is what you aim for, is to have a positive experience, to have a safe experience, and for the child and the family. Another area where there is a difference when you have transitional care and you have young people moving to adulthood, and how can you deal with them and their questions. That will come as communication, that can come in confidentiality, that can come as consent. And your leadership when working in a team and with allied health professionals, so with nurses, pharmacists, dietitian, physiotherapists. So you have to show your wide range of handling and dealing with them, which you are doing on daily basis, and how you support them even in education, in training, or you listen to what they say. If you have one of them, okay, or I'm concerned about this family, I've been seeing them for a long time, I think there's safeguarding concern coming from a dietitian. How would you handle that? At the same time, you know your limitation and when to ask for help and when to escalate, whether it's a tier 2 or a tier 1. And even if you know the whole pathway, you still have to escalate to the right person. So good luck, and these are some documents from the GMC about clinical governance and the Royal College. And I think each of you is different. So you have to, as I said, sit and have your map or like a cloud and write the 7 pillars and put some examples. Look about where is the areas where I haven't contributed, I haven't done an audit, I haven't done a research, I don't know about risk management, and try just to make sure you have an example or even you understand if someone is asking you the question. So I hope that's helpful.
Yeah, thank you, Sara. That was really helpful. Yeah, now the floor is open for questions.
I have a question. Hi. The question is mainly just to make it more practical for those who are going for interviews, because the question will come in the interview in the form of a scenario, and you want to apply the theoretical knowledge that you have about governance and leadership, into that scenario. So how can they approach those scenarios? I know you mentioned how they know about the pillars and everything, but when it comes to the practical point, so for example, one of the scenarios was being given a handover at a night shift or even in the morning, and they will give you a spreadsheet with the patients and everything, and then there will be more than one patient in semi-unwell state with others who are well enough. And you will have one junior with you as a registrar, and then you need to prioritize things and see which ones to see first. Do you need to get other people to help you? So that kind of scenario, plus the other scenarios like, dealing with a difficult colleague, dealing with a conflict, because all the pillars and concepts of governance and leadership will come into that. So how can they approach it in real life scenarios, dealing with difficult people, difficult scenarios, incident reporting, things like that?
So if you have the first question, which is, thank you, Hani, about the handover, you have to go to the safe. And I'm trying to make it simple because I don't want to be. So you're going to say, I arrived at 9 o'clock. There is a tier 1 and tier 2. I have my team. I have the nursing staff with me as well. I'm going to have an SPAR for the handover, obviously. And then I will look at the priorities about who's sick. And then you will going to delegate and distribute. So if you have a tier 1 who is a pediatric trainee, or a tier 1 who is a foundation, or a tier 1 who is a GP trainee, and then you're going to give them work that you are sure that they can achieve, and ask them to come back to you with an outcome. You will going to obviously see the sick patients. You will have to see whether you have sick patients in the pediatric department and in another department. In other areas, you can have an HDU. You have to do a ward round of an HDU, for example. And you may need to speak to your senior as early as possible, because there are quite a few sick patients, and you can't be in one place, in 2 places at one time. So what you need to demonstrate that you have made a quick assessment, you understand your skills, and you have delegated, and you have escalated to your senior at the same time. And the other thing is you have to include all of the other allied health professionals. So you can't say, you can do, as I said, you have to see who's the senior nurse, what are their concerns, if you're covering delivery floor, the midwifery team, what they think about and what is happening. Is there any potential for, ex-prem deliveries? So you have to have like a dashboard, and in that dashboard, you have to have levels of red, amber, and green. And you have to, from the beginning, decide, do I need extra help, or I can do it, or I need to escalate that. Now, it is important as well about communication, about the handover. So if you come to a handover and someone starts to talk to you about patients who are not really sick, and you're not aware about the situation, that there is someone who is on aminophylline, on oxygen, or who had hydrocortisone, who's really sick, and then they're talking to you about something else, that's a big issue. So from the beginning, the handover has to go in a priority order of who is sick, who has not been seen, what is the early scores for that person. You know, this child has not been seen, the early score is 4 or 5, so, you know, alarm bell. Nobody have seen them, they have a high, this patient has been triaged by the nurse, she's happy, the child is stable, so you can leave that. So this is the normal way you are doing it. You just have it has to come across that your thinking is loud or in writing, and that you are having a system that you will work on. This system is about assessment and then calling for help. Now, having a difficult colleague, and if you are a tier 2 or you are a tier 1 and you have noted that, it depends. If you have, for example, you are the representative of the trainees, for example, you can approach that person. But if you are not the representative of the trainees, it will be important to discuss with the responsible person. If you don't have any sort of, you have invited the person for a cup of coffee and tea and you didn't identify any problem, you shouldn't take that responsibility. So you have to address it to the right person, to the college tutor, to the trainee representative. You have to know what is the structure in your area. If this trainee has caused the problem that you think has affected safety and quality, you have to datax that. So that can be investigated properly. For example, drug error or anything like that. So that is really important. Now, the leadership, you know, talking about leadership, I think it comes across about yourself, about being proactive and understanding the system, and delegation, identifying the problems, and then apologizing if there is a mistake. One of the common scenarios is there is a mistake, what are you going to do about it? And you just have to go, if there is a mistake, what is first the risk for the patient? The patient is safe, okay? There is anything I need to do clinical? Then you come and assess the mistake, okay? Investigate that openly. There is risk assessment tools, there is root cause analysis, and then how can we learn from that? Did we have a protocol and we didn't use the protocol? Why? We don't have a protocol, we need a protocol. This is a complex patient and there has been communication issues between different specialties, and there was no enough information and documentation was poor, for example. So I wouldn't think any of the scenarios that will come is something that you haven't come across or something that you wouldn't be able to do it. But as I said, with yourself, sit in front of the mirror and have a piece of paper and look into these things and think, if they ask me this question, how I will handle it. What do I know and what I don't know? It's all about the system that you have in place.
Great, thanks.
There is a question about, I have a tier 1 last minute sickness. I'm doing the night. What shall I do?
Yeah, that's really common. So you will have the consultant on call. You will have to look at what is on your shop floor, which units are you covering, how is the situation in the unit, and how many sick people are there. So you don't have tier 1, and do we have as well any issues with the nursing staff, because that will combine the risk. Who's responsible for the rota? Is there anybody who they can contact to see whether there can be a cover? Is there a potential for any unit that you have a cross cover for your tier 1? You have to inform your consultant, and the consultant may have to come in and work with you if it's really very busy. Your side manager or whoever is responsible for hospital at night must know, because then the patient flow within the hospital will be affected if there's shortage of staff in one unit.
Okay, and there is a question not related to the interview. If I'm losing the situation awareness, how I can maintain it all the time?
I think the way I see and it's difficult. Everybody's different. So if I understood the question, that you have started to answer the question, but you felt like you have missed something. Is that right?
Yeah.
Is that, yeah. Always, and I heard you asking a question, someone asked a question to the previous speaker about if I forgot some of the assessment. Always put in your head that I'm doing a reassessment of my situation. So after you talk for 2 to 3, 2 minutes, say, so in reassessing the situation, and when you reassess the situation, start again, okay? And say that you are doing a reassessment, because you will be doing a reassessment, okay? So always put like there is a reassessment. If it's a clinical case, you will do a reassessment, because say, okay, let's start from the beginning, ABC. So you say, I'm going to do a reassessment now after I knew all of this information. So the situation is, I'm just doing a recap. So when you are doing a recap, then hopefully you will gather more information. Just be relaxed. There is one advice I was given on my clinical examination, and I found that was really useful. It was from, I was going for my clinical, and we were the first batch when we having the clinical, this sort of station of communication, blah, 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 ages ago, of an old lady. So we didn't know what we're going to do. And we had our consultants helping us in preparation. One of the consultants gave me an advice, and until now I remember what he told me. He said to me, I don't want to see someone who's shaky. I don't want to be someone who's frowning. I want to see someone who's relaxed and smiling, as if I'm coming in the morning for a handover. Someone that can work with us. So the same way you're walking for your handover in the morning, they're expecting you when you come and sit and do this assessment that you will look relaxed, smiling. I know that can be challenging, but it worked. So I've had this smile from in between the station, I was shaking. But as soon as they opened the door, I smile. I remember what he told me. They want to see your confidence. Yeah? Your confidence comes across. They don't want to see someone who's shaking and someone who's not happy. And I didn't do well in the previous station. Whenever you finish from one thing, you just close it, you go to the second one, and you do your best. It's something you're doing every day. Okay? You're doing it whether you're doing it in the UK or outside the UK. Just bring it across. Not a fake smile, Tagrit. It is just like, I don't know. Ya Rabbi, yani ya Allah, Allah yahweh. I was smiling when I finished. I said my muscles of my face were, at the end of the day, I felt like, oh my God, it worked well anyway.
Right, Sardonicus. One common scenario also that comes usually for ST3, ST4 is the difficult parent, or a parent who is refusing treatment, or a parent who is threatening to take their child home despite clinically needing treatment. Also, just a frame of how to approach it.
So when you have this sort of difficult communication, safeguarding as well, you will have to say, what is the problem with the patient? How sick is the patient? What does it mean if the child doesn't have this treatment and leave the hospital? Is there life-threatening condition on this child? Because that's the priority, okay? Then you have to understand why there was a difficult communication with the parents. Were they not given the right information from the beginning? So you have to be open, apologize, repeat the advice once again, or this the family don't want because they don't understand the medicine, or they don't want the medicine. And you, as a tier 1 or tier 2, your role will be to repeat, explain, and understand what is the problem. And then you come to the next level where you have to escalate if you think there is a life-threatening problems, there is a safeguarding concern, and this will be discussing with the senior, with the consultant or the registrar, and with the matron as well. In some cases, this can go beyond that into the safeguarding team and social referral, and even the police to bring the child back. But you don't have to say that, but you say, I'm aware that different measures will take place and assessment by multi-professional teams if needed. So it is about life-threatening, about communication, about safeguarding, and about escalating, and about documenting what has happened.
Thank you.
Any burning questions?
Drug prescription, this is common scenario that will come in a way or another, about medication and drugs and errors, or understanding a new medicine, or COVID-19 and vaccination, give it or not give it, immunotherapy, give it or not give it, steroids, safety of steroids. So medicine in children is something will come at somewhere. So you have to, be ready for that.
So if no more questions, I would like to thank Sara for this is very fruitful session. It was very interesting and very helpful. Thank you very much for being with us today.
Okay, thank you and all the best. All the best.
Thank you. Thank you. I think right now we'll give a short break for 10 minutes and we can join all at 3:20 for the next session, please.
نحن أسود الغاب أبناء الحروب لا نهاب الموت أو نخشى الخطوب، نحفظ السودان في هذه القلوب، نفتدي من شمال أو جنوب بالكفاح المر والعزم المتين، وقلوب من حديد لا تلين، نهزم الشر ونجلي الغاصبين كنسور الجو أو أسد العرين، ندفع الردى نصد من عدا، ندفع الردى نصد من عدا. نحن جند الله جند الوطن، إن دعا داعي الفداء لم نخن، نتحدى الموت عند المحن، نشتري المجد بأغلى ثمن، هذه الأرض لنا فليعش سوداننا علما بين الأمم. يا بني السودان هذا رمزكم، يحمل العبء ويحمي أرضكم.
الدم بحل الدم، سامحني يا منظم إذا أنعل الشيطان فعلت فيها ندم. الدم بحل الدم، سامحني يا منظم إذا أنعل الشيطان فعلت فيها ندم. الزم الزور بشيله فوق، سامحني يا منظم. يا داري يا يما جسمي الفقد دمه، يا داري يا يما جسمي الفقد دمه، عيني بجافي النوم قلبي الكتير همه، عيني بجافي النوم قلبي الكتير همه، قلبي الكتير همه. الروح تحل الروح ولا لأخوي حنين، دفقت دمي بكيت أنا بكيت. الروح تحل الروح ولا لأخوي حنين، أنا دفقت دمي بكيت، دفقت دمي بكيت. الروح تحل الروح وانا لاخوي حنين. يا اخوانا هو يلموا خلوا الفتن غالي، يا اخوانا هو يلموا خلوا الفتن غادي. راية صلح تمون والعزة لبلادي راية صلح تمون والعزة لبلادي دارفورنا 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 دارفورنا.
Okay, welcome back, everybody. Now I'm pleased to introduce Mohamed Abdoun. Mohamed is one of the successful overseas trainees who joined the NHS for the first time in a training job. He's currently an ST1 trainee in Yorkshire and Humber Deanery. Unfortunately, Mohamed is working today, but he kindly recorded a video for us today to share his humble interview experiences. Thank you, Mohamed. Appreciated your effort. Now, please, Osama, if you can share his videos.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. My name is Mohamed Abdoun. I'm one of the pediatric trainees at Yorkshire and Humber Deanery. My deepest apologies, guys, for not being able to be live for some working issues. However, I'm quite excited to share with you my humble experience with 2021 interview, both technical and practical tips. This record is a part of the project conducted by the British Sudanese Association of Paediatric and Child Health. Deepest congratulations for those being nominated for the interview and all the best in the remaining. You might be nominated by these times and celebrate your achievement. So what are the next steps you need to be aware of? First of all, you receive an email from the recruitment office that you've been shortlisted and this is your score. And they are happy to have an interview with you. There are limited seats per center to have your interview. And they basically depend on the first base services. This means that if you are booking early, you will get a chance to have an interview. If these seats are full, you might live with unsuitable date and unsuitable time. So please make sure you select the suitable date and suitable time according to your situation. You booked your date and it's very high time. If there are any special tips could help you in preparations, let's see the next slides. So the first tip I want to share with you is the practice, practice and practice. I cannot really overemphasize how it's important to keep practicing. And trust me, this is where the time makes the difference. You can start practicing by talking to yourself in front of the mirror. Or talking to yourself while you are walking. Or talking to yourself while you are driving. Collectively, this will help you to know how your voice and how your tone looks like and what area you need to make some improvement in. Keep practicing with the colleagues at the same level. This will help you to know what is your defects and what you need to do to make improvement. It's quite important to have multiple mock exams with your seniors and getting a structured feedback about your performance. Please try to have a look about the BSAPCH website. They put in a structured way how the interviews looks like and what are the requirements of the interview. The general structure of the interview is quite similar to the last year interview in terms of being an online interview. However, they are intended to change the platform of the interview. So instead of using Microsoft Office last year, they plan to use another program that will make you aware of ahead of interview. It's expected to have 2 stations instead of 1 station this year, so it will be 15 minutes each, 30 minutes in total. An extra component have been added this year which wasn't available last year. This is the pediatric clinical reasoning question. It's quite important to follow the instructions sent for you in the email and being in the loop ahead of a time before the interview. This is basically for some checkup. The first guy you'll see inside the interview is the technician. He will try to sort out any technical problems and will confirm your ID, so please have the suitable ID according to the requirement. Communication station is the most likely station you will start with. The technicians will put the scenario on the screen. I will give you about 2 minutes to read the scenario. They will take the scenario off and you will start to see the role player, and your communication will start at this time. They will give you 2 minutes alarm at the end of the station in case if you want to make summarization or wrap up. So the important communication tips are: talking clearly, listen to the role player and make the conversation as a dialogue. Use your body language as you can as possible and try to practice it. Avoid medical terminology and jargon as you can as possible and explain it if you use it. They like the attitude of knowing your limitation and your intention to seek a senior advice. Have a look please to this comment. Here are the tips for career motivation. The interviewers have no information about the portfolio you make it in the oral application, so you can still use some of them to reflect on your motivations. The time to answer this question is short, so it's quite important to make your answer structured and organized. Questions you might expect in motivation are: why you are applying for pediatrics? What are the characters of a good pediatrician? Tell us about the biggest achievement you are proud of. Here are the important tips for reflection. Try to summarize the title of your event clearly in a 1 or 2 sentences only. They might ask you some questions at the end if there is a time, such as how this could change your practice in the future, or what do you know about reflection. Here are some technical tips. It's not allowed to use your phone at all during the interview, so make sure it's off or silent. No one is allowed to be in during the interview, and they will ask a permission from you to have a look all over the room. You might face some technical problems during the interview, so please make sure you can contact the technician and you can involve the recruitment office if needed. I think these 2 slides are explaining themselves. You need to make sure of proper framing, looking at the camera instead of looking at the screen. You can see how it's quite important to have a good lights in your room. All these could give a good impression to the interviewer and reflect your body language appropriately. This is one of the references. I found it quite useful in the interview preparation. It's a quite extensive reference. So for the sake of time, you can go to the chapter that include your interview components and try to practice it. This is my email, guys, and I'm quite happy to be asked. And I will ask the coordinator to pop it in the chat. At the end, guys, all the best in your interview. Thank you for your time and have a lovely day.
Okay, thank you, Mohammed, for sharing your experience. By this, we almost come to the end of the day. We hope you found it very useful for the interview preparation and future practice. Thank you all for your attendance and interaction. Please remember to fill the feedback, as this will help us to improve our future activities. Now I return to Hani for closing remarks.
Thank you, Mohammed, and thank you for everyone for attending. Thank you for all moderators and presenters and the guests and the candidates who have joined. I hope you had a useful, productive day. If you have any questions about anything, if anyone wants to ask anything, we are a little bit ahead of time. So if anyone has got any question that they thought of, they want to ask now, we can try and answer. If not, then we can forward it to the right person to answer it. Otherwise, please fill the feedback, which is now in the chat. And we will also send it in the emails of those who have registered. If you are an ST1 applicant, then you will be joining us tomorrow, most likely, for the mock interviews, which is actually going to be the most useful thing. Yes, the theory is important, but practicing it is even more important. And believe me, this is the experience of going through some few interviews, not just one. You need practice. Otherwise, you will get surprised on the day of the interview, and then you'll say, I wish I have done that before. So any questions now? Anyone else wants to ask any question? You can unmute and talk. Make use of time. The ST3, ST4 mock day will be scheduled soon and will be advertised in due course also. Okay, if no further questions and everyone is happy, the recording will be available on the BSAPCH Facebook page. It is also going to be uploaded soon in our YouTube channel also. If you go there and just search BSAPCH, you can see it. Please feel free to forward it to your friends who you know can make use of it. As I said, if you have got any questions, you can either get in contact with us through our email or through the website. There is a contact form there. You can also just fill it. The mocks will start tomorrow. Is it 9:30, Mohammed? Just to confirm.
Candidates will come at 9 and then we'll start organizing. 9:30, the sessions will start, but people need to be here by 9 o'clock, please.
Great. That is, thank you for the clarification, Rehab. So 9, we'll see you all there tomorrow. I think there are some people asking something in the chat. Yeah, starts at 9. Okay, good luck everyone. Hope we see you all in training posts recently soon. But don't be disappointed if you haven't. You will get another chance at it, but hopefully you will get it. Believe in yourself, work hard, practice, go and do it. Thank you, and thank you for your time. Moderators and organizers, can you please stay and don't leave the session? Thank you.